Summit and Phoenix Awards for Health Innovation. Today's summit brings together some of the most influential voices across medicine, healthcare systems, policy, research, digital innovation, and technology to discuss one of the most important shifts shaping modern healthcare, the rise of artificial intelligence. AI is no longer a futuristic concept in healthcare. It is already influencing diagnostics, hospital operations, clinical workflows, medical education, remote monitoring, research, and patient engagement. Yet, alongside the excitement, there are equally important conversations around ethics, governance, trust, and implementation. Through today's session, we aim to move beyond the hype and discuss what AI truly means for Indian healthcare systems, doctors, hospitals, patients, and public health. We have a power-packed day ahead featuring keynote addresses, expert panel discussions, and product showcases from leaders shaping the future of healthcare innovation. So may I first invite Dr. Kamalkant Kohli, Chief Editor of Medical Dialogues, to kindly join us on stage and deliver the welcome address. So ladies and gentlemen, please welcome Dr. Kamalkant Kohli with a warm round of applause, everyone.
Honorable guests, members of faculty, delegates, ladies and gentlemen, Namaskar. It is my privilege and honor to welcome you all to Health AI Con 2026. आज का दिन केवल एक कॉन्फ्रेंस का दिन नहीं है, ये एक ट्रांजिशन का दिन है, एक ऐसा मोमेंट जहां से हेल्थ केयर की दिशा बदलने वाली है. Over the last 4 decades in medicine, I have seen many transitions, from clinical judgment to evidence-based medicine, and from individual practice to institutional care. हर बदलाव ने मेडिसिन को बदला है, लेकिन आज जो हम देख रहे हैं वो फंडामेंटली डिफरेंट है. आर्टिफिशियल इंटेलिजेंस इज नॉट जस्ट अनदर टूल. ये केवल एक टेक्नोलॉजी नहीं है, ये डिसीजन मेकिंग को बदलने वाली ताकत है. आज आर्टिफिशियल इंटेलिजेंस क्वाइटली हमारे सिस्टम में प्रवेश कर चुकी है. डायग्नोस्टिक्स में, रेडियोलॉजी में, आईसीयू मॉनिटरिंग में, हॉस्पिटल मैनेजमेंट सिस्टम में और धीरे धीरे क्लिनिकल डिसीजंस में भी. लेकिन एक इंपॉर्टेंट बात है, एआई इज एंटरिंग विदाउट अ यूनिफॉर्म डायरेक्शन. कुछ जगह एडॉप्शन है, कुछ जगह एक्सपेरिमेंटेशन और कुछ जगह कंफ्यूजन. And this is where the concern begins. Friends, you will agree with me that medicine is not like other industries. ये सिर्फ एफिशिएंसी का विषय नहीं है, ये केवल स्पीड का विषय नहीं है, ये ट्रस्ट का विषय है, ये एथिक्स का विषय है, ये ह्यूमन रिस्पॉन्सिबिलिटी का विषय है. If AI enters healthcare without guidance, it can create fragmentation. If it enters without ethics, it can dilute trust. And if it enters without doctors leading it, it can change the very nature of medicine. So today, the question before us is not, will AI come into healthcare? AI has already come. The real question is, will we guide AI or will we adapt to it? It is with this thought that we have conceptualized Health AICon 2026. Our vision is absolutely clear. Artificial intelligence in healthcare must not grow randomly. It must evolve responsibly. We believe in structured and regulated integration of AI across three pillars. First pillar is healthcare delivery. AI should enhance clinical judgment, not replace it. It should improve outcomes, reduce errors, and strengthen patient safety. Second pillar is medical education. Every doctor must understand, not as a programmer, but as a responsible user. Enhance and support. But AI cannot displace responsibility. आज इस मंच की विशेषता ये है कि हम केवल डिस्कशन नहीं कर रहे. We are witnessing a national convergence. We are honored by the presence of leadership from National Medical Commission, Indian Council of Medical Research, Dental Council of India, Ministry of Electronics and Information Technology और Healthcare, Diagnostics, Research, Policy, सभी डोमेन से नेशनल लीडर्स आज यहाँ उपस्थित हैं. This is not routine. This is alignment. आज हमें केवल चर्चा नहीं करनी है, हमें डायरेक्शन देना है. So therefore we propose development of national standards for AI in healthcare, integration of AI into medical education frameworks, creation of ethical and regulatory safeguards. आज आर्टिफिशियल इंटेलिजेंस हमारे सिस्टम में प्रवेश कर चुकी है, ये हम अच्छी तरह जानते हैं. और इसी डायरेक्शन को बढ़ाने के लिए वी आर टेकिंग द नेक्स्ट स्टेप फ्रॉम डिस्कशन टू इम्प्लीमेंटेशन. फ्रेंड्स, this afternoon we will be launching National AI Doctors Mission, NAIDM, a vision to empower every doctor with AI, create structured learning pathways, build national capability, ensure ethical and responsible use. ये मिशन केवल टेक्नोलॉजी अडॉप्शन नहीं है, ये डॉक्टर एम्पावरमेंट का मिशन है, ये पेशेंट सेफ्टी का मिशन है, ये भारत को एआई एनेबल्ड हेल्थ केयर नेशन बनाने का मिशन है. हम एक ऐसे समय में हैं जहां टेक्नोलॉजी बहुत तेज़ है, लेकिन अंडरस्टैंडिंग उतनी तेज़ नहीं है, जहां सिस्टम्स आगे बढ़ रहे हैं लेकिन स्ट्रक्चर्स पीछे हैं. आज हमें ये गैप भरना है. लेट अस बी वेरी क्लियर, AI will shape the future of healthcare, but today we decide whether this future will be guided by doctors or driven by technology alone. I welcome you all once again to this important national platform. Let us not just discuss the future. let us define it. Thank you.
Thank you so much, Dr. Kamalkant Kohli, for such inspiring remarks and for setting the tone of today's summit. All right. Okay, so we now move on to our first panel discussion of the day. Panel discussion topic, AI-driven clinical workflow optimization. AI is increasingly becoming central to improving efficiency across healthcare systems, from diagnostics and hospital operations to clinical decision support and workflow management. In today's session titled AI-driven clinical workflow optimization, we are going to explore whether AI can realistically optimize clinical workflows in India and where the biggest opportunity and challenges lie. To chair this session, may I invite Professor Dr. Rajiv Sood, a distinguished urologist and the Vice Chancellor of Baba Farid University of Health Sciences with over 40 years of medical and academic experience. He has more than 3 decades of post-MCS teaching experience and served as Professor of Urology for 14 years. Everyone, could we please give a round of applause to welcome Dr. Rajiv Sood on stage. I would like to now invite the moderator for this session, Professor Dr. Anurag Mishra. Professor Dr. Anurag Mishra is a professor of surgery at Maulana Azad Medical College, New Delhi, and Secretary, Medical Innovation Center, MAMC, with a strong interest in medical innovation, surgical education, and public health. Everyone, could we please welcome on stage Professor Dr. Anurag Mishra. I now invite our distinguished panelists to kindly join us on stage. Dr. Pradeep Dabla, Director, Professor, Biochemistry, GB Pant, Institute of Postgraduate Medical Education and Research. Professor Dr. Pradeep Kumar Dabla currently serves as Director, Professor and Head Department of Biochemistry at GB Pant Institute of Postgraduate Medical Education and Research. Next, I would like to call on stage Dr. Hari Krishna Raju Sagiraju, Associate Professor, Preventive Oncology, NCI, AIMS, Jhajjar. Dr. Hari Krishna Raju Sagiraju is an Associate Professor at the National Cancer Institute, AIMS, Jhajjar, in Department of Preventive Oncology. I would like to invite Dr. H.S. Chabra, President, Association of National Board of Accredited Institutions. Dr. S.S. Chabra is a leading spine surgeon and president of ANBAI and Spinal Cord Society. He is also past president of the International Spinal Cord Society and the Association of Spine Surgeons of India. I would like to call on stage Mr. G.S. Subramanian, Head of E-Sales, South and Southeast Asia, Elsewhere Health Solutions. G.S. Subramanian leads Elsewhere Health's commercial organization across South and Southeast Asia, overseeing the clinical and education portfolios. Everyone, can we please give them a round of applause? I would also like to call on stage Dr. Rakesh Kumar Dhaka, Associate Professor and HOD, School of Nursing Sciences. Dr. Rakesh Kumar Dhaka is a nursing academician and healthcare administrator with over 12 years of experience in nursing education, clinical practice, hospital management, and research. So everyone, can we please give a round of applause to all our panelists on the stage?
Oh, thank you. A very good morning, everyone. And I thank Dr. Kohli to set the tone of discussions today. And we are privileged that we are hosting the first panel of the day. And I'm really happy to see the panelists. They're very experienced and they come from very diverse backgrounds. So we will have a very good uniform overview and perspectives about AI, how AI is shaping. So AI, I think we all know that AI is established in few things. If you want to have some information about a thing, AI is a go-to thing now. Even kids just type in on AI, not on Google these days. For diagnostics, AI is pretty established. In radiology, in pathology, in a lot of image-based diagnosis, AI is established itself. But we want to go a step further, that how AI is shaping decision-making or patient care outflows in clinical practice. And we have people from various backgrounds, from teaching, from private hospitals, from government institutions, from nursing, and so we'll have their perspectives on it. So, any opening remarks on how you say AI? Maybe a one line from everyone.
So, welcome everybody. It is a great opportunity to interact with everybody, and it is beneficial mutually to each of us. And our thoughts about AI and how it is integrating in our system. We all know that we are talking about here, if we are sitting about telemedicine also. Telemedicine version 1 was only remote consultation, and from there we started. And now, as has been mentioned by General, that we are now looking for not only remote consultation, saving time, not only that, but interacting and critical interventions. It is not scheduled visits which we are waiting and making. And it is totally changing because diagnostics have now also entered, machine learning has also entered into it, and also it is the time when it is not only digitalization. We talk about digitalization, but it is digital transformation. We have to understand that we are going into the phase of digital transformation where all are the components, as has been by Dr. Kohli initially mentioned rightly, that it is basically AI-driven clinical workflow. It is not one event. It is integrated process. Everything is happening simultaneously, and we should not be left behind in medicine, in healthcare, in telemedicine, in drug development, in critical interventions. So this panel is there. Various aspects will be detailed into discussion, and we will take home good messages from here. Thank you.
Anybody else wants to?
In a country like India, where we know and we have to acknowledge that there are gaps in the requirements and the availability, AI is going to help substantially. Right from clinical workflow optimization to also, we know that the real requirement in India is in expert healthcare. And for example, in a study, they found out that the top 10 causes of morbidity and mortality can't be handled by an MBBS alone. Requires expert healthcare. And expert healthcare can't reach out across the country. But AI is going to help it reach out to the masses across the country. So a very bright future in healthcare, and I think we have to look forward to how AI is going to revolutionize it, but it needs to be taken forward in the right manner, and that is what such conclaves are going to help in.
Exactly.
Quick two notes. I think if you look at from a technology perspective, I think it is very transformational. But as the panelists have already told, it is very important for us to take it in the right direction. It's something like a nuclear power. Right? Unless you use it for the right purpose and in a responsible manner, it may have more negative effects than positive effects. That is there. But the other piece is, as we look at emerging economies, where this transformation is going to help us is it will help us to scale faster, which is a problem for a large country like India, where you have a lot of infrastructure already in place, but because of various interoperability problems, we're not able to scale it up. I think that is where it's going.
Excellent. I think, Dr.
Very good morning to all of you. and very thankful to the organizers and to the committee members for inviting me a part of this eminent gathering. So if I talk about say AI, so first of all the thing is that AI is new to the healthcare, though it is not new to the other areas of the development, maybe engineering, maybe metrology, maybe traceability, maybe the data, etc. But yes, for the health, AI is something, a new subject, and something very important that now the healthcare is started taking up it as innovative subject. In fact, I have being a part of it, the few colleges, those who have started for the undergraduates, even some part of it as a curriculum. So it is something that we need to take an initiative, and especially as all of our eminent members were speaking, that the one is the population, the huge population, and the second is the data that we need to manage. So we can go ahead. Thank you.
I think you can keep the mic with you. I'll throw the first question to you only. So lab data, I think we all agree that AI has established role in lab. But in a country like India, where we lack a standardized data across country, across hospitals, even in one city, different hospitals will have a different system of data recording. So where do you think we should start? Where's the main gap where we can see AI leading the healthcare decision making in future? So what's the gap?
Probably Dr. Anurag has started with the same question. So I was just talking about the data only. So when we are talking about the population first and second about the healthcare, we know that we are generating a huge amount of data, but in case of AI or in case of any usable that from the various vendors, but may not be the standardized data, which can be usable across the country. But of course, as I see that the government has started taking initiative, that has also been started recently for the last few years. In fact, if you go by the data, then that ABVM has crossed almost 700 million registrations under the Pradhan Mantri Yojana from the patient care or the patient data or the registrations. It has become mandatory in many of the hospitals. Like if I say in our hospital in Mamsi and GB Pant and other many central areas, it has become mandatory. The new registration need to have a one unique ID, which is attached with that particular registration. How much it has been usable to the clinical usage into our clinics is none, frankly. So that means that we need to have some important standardized formats where we try to include that data, and that is available across the country to any of us. For example, if some patient has been seen in Delhi, the same patient goes to the PGI Chandigarh. Then the same data is available even in PGI Chandigarh with the same formats. Now, for example, if you have a huge data across Paila into the backstage, now how we can use that particular data? So there are softwares, there might be kits which were being designed, even FDA approved. Home-based kits can be used for the COVID testing, where the patient can put their sample, maybe the saliva sample or maybe the throat sample, and the outcome snapped by the photograph for your phone and submit it to the photo app, to the app-based technology. One can have been connected to your doctor even through the distance. Even there were some app-based techniques, even some radiological X-ray based techniques were also being available, where the X-ray being taken at one place, being evaluated by the doctor at a distance. So yes, AI has an enormous power where we can utilize the data and can make it standardized for a patient.
Right, thank you. I think we'll move to Dr. Hari Raju. Dr. Hari, you come from a cancer specialty background, and cancer, as we see, focuses on treatment. How we can tap into AI's potentials to focus more on screenings or preventive cancers? So maybe some light on that.
Thank you and good morning. And first of all, thanks for having me be a part of this very important panel and with these esteemed speakers. Thank you for the invitation. And yeah, as Dr. Anurag has mentioned, yeah, already the tertiary care centers are already overburdened with the patients. So NCI just came up recently, like after COVID, we started functioning, and right now even our waiting list is beyond 6 months. So establishing, like the founder of NCI, Dr. Raj says, establishing one more cancer center, it is not a solution for the cancer treatment or the cancer cure. So unless it has the prevention and the early diagnosis. And definitely AI can definitely play an important role. But at the same time, as Dr. Dabla is mentioning, so that those models and the data should be available to do that one. So that a lot of efforts has been done through ICMR. I think with the MIDAS data set, ICMR is trying to standardize those data sets. And the other important aspect is the lack of the Indian perspective to the data. So most of our predictive models and all comes from the Western data and other populations. So we don't have our Indian population data that is available, and most of the AI that are built algorithms are available from the open source databases, which we still lack from the Indian perspective. But at the same time, given it's a very much important for answering the rising cancer burden in India, definitely prevention, early diagnosis, and the behavioral change. These three aspects are very much important to address the cancer burden, and AI has an important role to play in all of them. So if we come to the risk stratification, because we can't screen the entire population, so we have to go with the risk stratified screening of the populations. So definitely AI models can help in the risk stratification, identify those high risk individuals, and then incorporate them into the National Cancer Program, where the ASHA workers or the healthcare workers can target those areas. We have a lot of national surveys with this HID, Ayushman Bharat data and all, but the data is not utilized to identify the high risk areas where the resources can be leveraged, where can be effectively used. So I think that is one of the aspects that AI can play a role when these models are very with the Indian person. But at the same time, we should also make sure we're identifying a lot of risk people, but we don't have the diagnostic infrastructure and those things, and we can't still burden the tertiary cancer. Till now, the diagnosis happens at tertiary cancer or in the other. So at least having these will reduce the burden. So coming to I will quickly go on. So the second is again the early diagnosis. A lot of AI is coming with the point of care technologies where we can diagnose at least the oral, breast and cervical cancer, most common cancers, and are included in our cancer control program. A lot of point of care technology, AI-based point of care technologies are currently in use, but again, are they validated for the huge population? Whenever I see a point of care technology, most of the time the validation comes from very few people, like 1,000 or something. But we need more bigger data and more. And India is a diverse population, so we need each region-specific also the data. But definitely that is useful, and they're already there, like AI-based colposcopy. We are doing it for the early diagnosis. Even Niramaya and other things are for the breast cancer. I think we had Dr. Geeta is also here. So yeah, definitely this. And the third important aspect is the behavioral change. The lifestyle and behavioral change is, I think, where AI can play a role. With now with the WhatsApp and everyone, the AI is incorporated. So just a small story. My cousin who lives in a rural area, uh, she just asked. She has a mild chest pain, and she asked the WhatsApp. So WhatsApp forced her to go to the doctor. And as soon as she entered the age, the tone of the WhatsApp changed. It was saying up, and then it says no, Didi. Up. As soon as she entered the age, the WhatsApp, the tone changed. Didi, आप तुरंत जाइए, hospital को जाइए. And then when she uploaded the report, it was even questioning how did the doctor let you discharge? You have to be admitted. Because she uploaded a wrong report or something. And then it said, no, this is done. And then it was taking from the prior searches also. My cousin searched for a good muhurt for a housewarming. So so the next statement is, दीदी आपका housewarming रुक सकता है अगर बच जाएगा तो आप जाके दिखाइए. So this is the kind of AI is coming on. So that the behavioral change with the lifestyle modification, tobacco cessation, physical activity, increasing the physical activity. Now AI has the nudge therapy. We can use those AI towards these ones to promote lifestyle and behavioral changes. I think that is the important aspect where AI can play a role, and not just in the treatment of the cancer, but in the prevention and early diagnosis.
Excellent perspectives. I think we move with the mic to Dr. Chhabra. You are an administrator and you are involved in a lot of accreditation and of hospitals. And obviously you see the health system from a very different perspective. And I'm sure you are given a lot of data, outcomes, outputs, and financial data, policy related data, sometimes the hospital mandates data, sometimes government mandates those data. How as an administrator you see the data overload, and how you think AI can help you in this? While there are a lot of people who run hospitals here, how to manage data using maybe AI or whatever tool you use.
So, as you said, as a manager, I need to look at how to improve the outcomes within the available resources. And we talked about India having limited resources. So we also need to learn from the experience of the West. Right? Today, if you see, the clinicians spend more time in documentation in the West than actual patient care. And if we can reduce that, administrative burden on the clinician, we are optimally utilizing them where their skill lies. So I think this is one challenge which is there in the present system, which AI can help. Then when you talk about clinical workflow optimization, right now the clinical workflow may be a bit fragmented, right? You need to go into EMR nodes separately, lab systems separately, imaging separately. And if AI can help in integrating this, that is going to help us also in looking at the data appropriately and managing appropriately. Then if you look into the present hospital systems, there are a lot of coordination gaps, right? There are delays in diagnostics, delays in OT scheduling, delays in discharge process, right? And which we all juggle across and try to sort them out, right? So there are lots of challenges. There's lack of integration. There's lack of real-time coordination. And I think this is where the real role of AI comes into. And it is possible. It is possible for the system to integrate across the departments, across specialities, and optimize the outcomes from the limited resources available. And that is where AI is going to come in a big way.
Right, thank you. So now we move to another pillar of healthcare, which is nursing. And they are very critical in all hospitals, how they work, clinical service delivery. So how do you think, where does AI help in the nursing work, or from their perspective, what is their role? Also, I will add, I am part of a study where we are exploring that a nurse with AI tools, is it as good as a doctor or not? I know this question will perturb many people, but we are actually exploring it because there are a lot of areas in India where there are no doctors but nurses are available. So we are actually using, can this be a rural tool? So I want your perspective on that.
Thank you, Dr. Anurag sir, and good morning, everyone. Nurses are truly the heart of the hospitals, but रियलिटी ये है कि नर्सेस अपना मोस्टली जो टाइम है वो केयर गिविंग की बजाय प्रोसेसिंग में वेस्ट करती है या उनका प्रोसेसिंग में टाइम स्पेंड होता है। और नर्सिंग पर्सपेक्टिव बिगेस्ट इनफिशियंसी ये है कि नर्सेज बेड साइड केयर से ज़्यादा टाइम पेपर वर्क, रिपीटेड मैनुअल एंट्रीज, डिस्चार्ज फॉर्मेलिटीज, लेबोरेटरी एंड फार्मेसी कोऑर्डिनेशन, इन्वेस्टिगेशन फॉलोअप, उसके अंदर ज़्यादा टाइम स्पेंड होता है। इसके अलावा कम्युनिकेशन डिले होता है, स्टाफ शॉर्टेज एंड इनकम्प्लीट हैंडओवर भी वर्क एफिशिएंसी को अफेक्ट करता है। मोस्टली ये देखा जाता है कि हॉस्पिटल्स के अंदर सभी डिपार्टमेंट्स के बीच में नर्स एक ब्रिज का काम करती है, जिससे उन पे वर्कलोड और स्ट्रेस बढ़ता है। आज के हेल्थ केयर सिस्टम में एक नर्स सिर्फ केयर गिवर नहीं बल्कि कोऑर्डिनेटर, कम्युनिकेटर, काउंसलर, क्राइसिस मैनेजर और मल्टीपल रोल प्ले करती हैं। लेकिन एक्सेसिव एडमिनिस्ट्रेटिव बर्डन की वजह से डायरेक्ट पेशेंट्स के साथ इंटरेक्शन का टाइम पीरियड कम होता है उनके साथ, क्योंकि पेशेंट्स को सिर्फ मेडिकेशन नहीं बल्कि उसको टाइमली ऑब्जर्वेशन, reassurance and human touch भी चाहिए। We say that hospital may run on technology, but healthcare truly runs on nurse, because when a nurse spend more time with the patients, the healthcare quality automatically improves.
So AI can work with the scut work, and then nurses can apply more time in patient care rather than doing.
Yes.
I think this is my criticism to all my nurses at my hospital. Yeah, बस केवल आप अपने register भरते रहते हो, you don't see the patients.
Yes,
Thank you for that answer. I think that was beautiful. We move to Mr. Subramanian. So I think you come from Elsevier and you represent publications, and now most of the publishers have moved online and digital, and I think with that there's loads of data available on fingertips. But somehow you will agree that there's all kind of data, good, bad, and ugly. All kind of data is there online, and whenever we search, it's very difficult to find out which is the right thing. So, how do you see AI helping doctors, clinicians in decision making, that we access the right information, which is well synthesized and in our language, which is usable, I think.
See, I think if you look at from a data point of view, I think many of our panelists have already said that we do not have lack of data, we have too much of data. I think where we struggle at this point of time is, are we able to create actionable insights from those data? That's one core piece. Now, if you get actionable insight, the next problem is, how is the infrastructure currently in our healthcare system that these insights reach the relevant user at the right point of time. If you take these two pieces, AI does it very beautifully. It is quite empowered. But again, it is very important for us to know that how do we guardrail this. Now, if you take, for example, one of the panelists said about US, right? If you take US, the adoption of AI has doubled in past 2 years. 2 years back it was around 25%, now it is around 50%. Now at the same point of time, if you look at the other kind of surveys, I think probably McKinsey did a survey, they said that 66% of them who are actually using do not trust the AI, right? So that there is a scope of doubt. So if you look at how Elsevier looks at it, right, from a point of view that we create actionable along with the trust. Because if you look at AI as a concept, or as a technology as we call it, it's not nobody questions the capability, right? It's the accountability, right? Where it, in terms, especially in the clinician sector, where you are technically dealing with human life, you cannot have a champion, right? And that also brings to the point that AI will be always a tool that will support, right? It is not going to replace a clinician. So the clinician has to be there in the loop, right? As you were saying, like it, where AI will help you identifying the right set of data at the earliest. You put a clinical query, it gives you an answer, but you don't just take the answer and apply it in an actual scenario. You will have to validate it. For that validation, how do you validate it? It has to be traceable. If I am giving you an answer, if I am giving you a referential diagnosis, where have I derived it from, right? And the derivative should be trusted, right? It cannot be a newspaper article. It cannot be a random. It has to be a well-researched, well-thought, established, audited, and good, right? So there is the ecosystem. If you look at, just by having a technology in hand, the ecosystem will not develop. You have lot of, various pillars that will help. If you look at some government should very strongly bring out a policy, right? They should establish the guardrails. Because if you look at AI, very powerful. What do you put in data? You cannot put a patient data. You have to anonymize and put it. There is a lot of data privacy that needs to be educated. And that is government. Now, if you look at from the publisher side, I think where we are working is we are trying to develop a product which is grounded on responsible AI principles, right? So that it does not hallucinate. So if you ask a query to any AI tool and it does not answer, or it is unable to give you an answer, the tool is not weak. The tool is responsible. I think that is something that we have to start looking at. It's not about weakness. As we tell to the children that if if you fail in an examination, please come and tell. Don't get scared. I think that is exactly what we have to do with the tool. Don't expect it to come with a magic. And that's where I think we set very wrong expectations from any transformational tool, and that is what we need to build it. Last point I want to say is, we at LJV, we do a lot of annual reports. One of the reports is clinician in the future. There were two insights which are very, very interesting. One of the tools was that everyone wants to adopt AI, right? But when you look at some clinicians, we interviewed around 2,000 clinicians globally. Around 30% do not want to continue in a clinician's role. They want to come out of it. Why? Because of burden, stress, and fatigue. Because that's the paradox that we are trying to solve. So
I think it is not about doing it fast, but more importantly, it is doing it right. I think that's the right approach. And I think how we design our prompt have a bearing that you can easily ask whatever value you give has to be from have a scientific value and not just any magazine article or anything, which as you mentioned. Excellent point. So I think in the first round, everybody talked about and agreed on that AI has a very clear role in various fields, be it diagnostics, be it preventive care or clinical care, be it management, be it publishing and data, or be it nursing and other clinical factors.
Quickly, I would want maybe 1 1 2 2 line that what is one key area where you think we should start working immediately so that the future is ready. So what's the biggest gap and what you would like things to happen? Okay, so you can start from the same order.
Thanks a lot again. After this, listening to the evidence speakers, the voice about their their knowledge into the specific field. So I think that what I can conclude, one important thing is about the data again. What I can heard that we all talking about the right amount of data. even if say you are putting your query, medical query to the AI model, and whatever the answer is coming to us, uh, is that answer is appropriate or not? Who is going to verify that? For example, a patient like Dr. Hari was talking about one case that some person was has given into the WhatsApp. Like in case of that, he was there to help and to interpret. What say suppose if it is a case of silent ischemia, what will happen in that case? Who is going to interpret about the same? Or otherwise say some challenges which are beyond the recognition of, as I said, the data is something that we can have what that AI in currently what it's doing. It is having a lot of literature available as much as onto the internet. They're giving it just interpretation calculated from that outcome, but may not be very specific as we were talking about the human touch, as we are talking about the human experience, as we are talking about the clinical experience. It may not have the same. I give a very simple example from my home itself. My teenage daughter was also looking into the AI and just trying to interpret her behavioral changes. So I was surprised that the answer and the outcome she takes to me. So I had to uh, correct her about the knowledge, the behavior changes that happens during those teenage. So the interpretation is very important. And now when we say the ethical or non-ethical, like we talk about the clinics, we say that yes, even if we give some the algorithm where the clinician has to record the statements, the finding, etc., while typing when they are talking to their patient, but it is going to reduce the interaction with the patient or may not give that proper interaction or time to your patient. Now in that case we can adopt what? We can adopt the AI, maybe like language processing or maybe the voice command where they can record their statement and give it a some legible writing. Even I was just remembering one study which was happened into the one of approximately 48 hours of the clinician time during a specific month. So data is very important for us. Yes, thank you.
Dr. Raj.
Coming to, if you want to, one tool that I can incorporate right now into the practice and all, particularly me coming from preventive oncology. Yeah, as I said, the device should be very well validated and established, like saying garbage in and out and the data, what Dr. Subramanian is saying, how the algorithms are based. So we should have that validation first. And a lot of things need to do that one. For examples of misthink, I mean like Bixomania, which is a recent thing. A Swedish researcher puts in a disease that is not existent. She published articles and she published it, and immediately the AI algorithm started to picking up and even suggesting the users also that this is the disease, you call Bixomania, which doesn't even exist. So it is all whatever you give in is what we get. So that's why you should be very careful when incorporating those things. And recent, I think I don't want to be political, but the recent shooting of the building of the high school in the Iran is also a miscalculation by an AI. So we should be very careful when we are doing these things. But if you say one tool that I can right now incorporate, again it is being developed by us and ICMR and with Indian Institute of Science, is Arohan app, which is an oral cancer screening app. So it is just using a mobile device. So it is very, these can be incorporated in a frontline health workers, where a ASHA worker can go just screen the image and at least tell it has, is it suspicious, should we go to the other center, higher centers for diagnosis. So such validated tools in the Indian population can definitely, we can, I think, go ahead and incorporate. But again, it should not affect the workflow. Again, it should not impact the workflow of the ASHA, and like again they're mentioning, we should not impact the workflow of the doctors or the ASHA workers or the frontline.
Thank you, Dr. Sabra.
So, if you were to ask me on one thing we would want to implement to have a clinical workflow optimization, which is the topic, right? So, I think AI should form a decision support layer which should help improve the outcomes, right? Prioritize decisions and improve resource utilization. So, for example, if it is able to predict the ICU load, the OT load, and help the administrators to have optimal resource allocation accordingly. If it is able to predict which are the patients which are likely to deteriorate, right? If it is able to predict which are the patients likely to be discharged today so that we plan the discharges and reduce the discharge time, right? If it is also able to optimize the staffing based on the number of admissions which are there. On the other hand, it should not lead to alert fatigue, right? That is the other danger which comes in with it. And to reduce alert fatigue, we could need to prioritize the decisions. We'll need to have it role specific rather than for everyone. And one strong recommendation at a time rather than too many recommendations. So again, in a few words, a decision support layer to prioritize decisions and improve resource utilization, something which is deficient in our system right now.
So I like how it is moving from data to validation to decision support. Mr. Subramanian, what do you think?
I think I will just take it from where Dr. Chabra has left. I think the biggest problem what we have is we are not using best of our resources in the best of the way, which is both clinician as well as the nursing community. So I think any system that helps them in terms of improving their administrative efficiency to start with, right? I think that is going to contribute a lot, because as multiple speakers have already said, the doctors are getting lesser time with the patients, so does nurse, because they are so much tied up in administrative work. So I think to start with, because if we want them to perform better, we have to give them space. I think currently they lack space, to be very fair, right? That's why you see 30% of nursing attrition in hospitals, and they cannot train them. They're not employable on day one. There are a lot of things. So I think if I have been given one choice, I think the choice will be we are able to help clinicians as well as the nursing community in terms of delivering patient care and not getting lost in administration.
From a nursing perspective, I suggested two main interventions. First is the AI assist nursing documentation, and second one is the smart patient monitoring system. Already Dr. Chawla discussed कि mostly times अपन पेशेंट्स के वाइटल साइन रिकॉर्ड करने में, डिस्चार्ज फॉर्मेलिटीज में और टाइम स्पेंड काफ़ी स्पेंड होता है. अगर जहाँ पे पेशेंट्स का फ्लो ज़्यादा होता है, लाइक आईसीयू में डॉक्यूमेंटेशन वर्क ज़्यादा होता है. एआई सपोर्ट सिस्टम ऑटोमेटिकली वाइटल साइन रिकॉर्ड कर सकते हैं, वॉइस इंस्ट्रक्टेड नर्सेस नोट्स रेडी कर सकते हैं, हैंडओवर समरी को समराइज कर सकते हैं और अबनॉर्मल पेशेंट कंडीशन के अलर्ट्स दे सकते हैं. इससे डॉक्यूमेंटेशन वर्क कम होगा, टाइम सेव होगा और नर्सेस का जो स्ट्रेस लेवल है वो भी कम होगा. एआई पेशेंट्स का डिटीरियोरेशन, फॉल रिस्क, मेडिकेशन एरर्स, इमरजेंसी वार्निंग साइंस में अर्ली आइडेंटिफिकेशन में मदद कर सकता है. एआई नर्स को रिप्लेस नहीं कर सकता, बट एक सपोर्टिव क्लिनिकल असिस्टेंट की तरह वर्क करेगा जो नर्स के फास्टर डिसीजन मेकिंग में, पेशेंट मॉनिटरिंग में हेल्प करेगा. एंड बिगेस्ट बेनिफिट्स ये होगा अगर नर्स रिपीटेटिव डॉक्यूमेंटेशन में कम टाइम स्पेंड करेगा तो मोस्टली टाइम पेशेंट्स के असेसमेंट में, कम्युनिकेशन में, इमोशनल सपोर्ट में, इन्फेक्शन कंट्रोल में एंड क्वालिटी केयर पे ध्यान दे पाएगी. AI will not replace nurse, but nursing use AI will improve or transform the healthcare. Therefore, the future of the healthcare depends on combining modern technology and AI intervention with compassionate nursing care to provide better healthcare services.
Excellent. So I think one thing which is emerging from all panelists is we need validated contextual data for us to start using AI in our clinical practice. And I would like to mention, I'm also part of a thing where we are making a generative AI platform, which is based on only established guidelines and high-level scientific data, not carrying anything else. So it's very filtered data so that clinicians can, without doubt, access that. And it's a generative AI, so it can use all in the workflows. So we are kind of coming to an end of this panel, and I would request our chairperson to summarize the takeaways from here and his thoughts maybe. So, Dr. Sudh.
Thank you, Anurag. We have discussed a lot and almost all the aspects have been covered. Our topic is beyond boundaries, and we have discussed a lot of local problems also, maybe regarding nursing or maybe other. Now what is required is that AI should be with the inclusive designs, working on different data sets, different communities, different sources, and so that there are no blind spots or biases left. So that is very important, that data should be clean. As has been mentioned, it should be validated, but at the same time, we have the problem of geographical differences, income differences, and also circumstantial differences. We have to address all at the same time. So when we are crossing boundaries, we are making it the universal thing which is going to happen in a year or two, and we can't escape, and we should not escape. We should get trained. So quality healthcare should never be determined by geography, economy, or circumstances. In sub-Saharan region, in a study, there was 18 million shortage of administrators in the healthcare, and 1 billion had no access. So these problems are to be addressed. When you were, we have to break down the barriers basically and to build the future. And when you were talking about nursing and the integration, I represent, I think, largest health university of the country, 300 institutions, and managing doctors, dental, nursing, paramedical, pharmacy, allied and health sciences. Our problem is a great divide. As I have discussed about the data, I'm discussing about this, like higher education institutions are totally divided under UGC and medicine, and in medicine, National Medical Commission, Nursing Commission, Dental Commission, Allied Sciences and all, totally fragmented. We have to integrate everything if we are talking about telehealth. If we are talking about AI in health, we cannot separately discuss everything separately, and therefore, when we are integrating the national education policy, basically where we are connecting everybody, every segment which I have told, with Indian knowledge system. When we were talking about integration, with the our moderator has mentioned that there is apprehension of whether nursing should be trained or not. We are actually in a very confused state which has to go. Integration, if you don't like the word integration, we should replace it with fluorotherapy, if not mixotherapy. So we have to be wise to integrate everything. We have to go for convergence, and therefore skills and telemedicine, along with the technology integration is also part of AI. AI, we had been using digitalization in the beginning, I told. It is not that you digitalize your hospital, you make e-hospital, you make e-resources, e-assessment and all. But actually you have to do the total transformation. So not the digitalization, but the digital transformation is required, and therefore there is now telepresence, telemedicine, telesurgery, telepharmacy, everything, and I'm in National Medical Commission at present, and we are framing the SOPs which are adopted now for even telemedicine also, telehealth also. And we should all go through that, and we should not be apprehensive that we are integrating. Recently, I just remember there was a doctor posted in the Allied and Health Sciences Commission, and doctor posted in different commissions. They started protesting. They want to remain actually segregated. They don't want integration. They don't want exchange. They say that remove this member from the commission. So this was not happening earlier. This is retrograde step. We are now going for this telemedicine or the AI integration and beyond boundaries, conversion. Boundaries are again at the end I am mentioning geographical, economical and circumstantial. And this is to be bridged, and everything is to be bridged. You don't like the word of bridge courses or all, you name them anything else, but we have to integrate everything. Converging everything is needed, and only AI is the solution for future. Thank you.
I think the applause says it all, that it's a perfect closure to this panel, and the wisdom of Dr. Sood will, I'm sure, guide everyone here. Thank you, all the panelists, and thank you, Dr. Sood.
Thank you so much, our esteemed panelists, for such engaging and interactive panel discussion. So everyone, can we please give them a round of applause? Clearly, workflow transformation in healthcare do not only depends on AI tools, but it also depends on thoughtful implementation, system redefine, and clinician adoption. And with that note, I would request all of you to please come forward, as we would like to felicitate each one of you. And I would like to invite on stage Dr. Kamal Kant Kohli to give a memento to each one of our panelists here, the chairperson and moderator. Everyone clapping should not stop, because that was such an insightful discussion we had. So that's a small token of appreciation from us to you. Everyone, please give them a round of applause. Thank you so much for coming here and for such insightful discussion. Everyone clapping should not stop, please. Thank you, sir. Okay, so let's have a group picture together. Everyone, can we please give them a round of applause all together? Thank you so much. Thank you. So, ladies and gentlemen, we now move to a special product showcase session by GoodMed. It's our pleasure to welcome Mr. Atul Tiwari, Director of GoodMed. Mr. Atul is founder and CEO of GoodMed, an emerging healthcare AI company started 5 years ago, which is working in AI and digitization through intelligent clinical automation. Under his leadership, GoodMed is building advanced AI solutions in prescription digitization, discharge intelligence, voice AI, billing audit automation, and ICU workflow intelligence. GoodMed is supported by premier institutions including IITs and AIMS and is rapidly gaining recognition across leading hospital ecosystems in India. He will be presenting GoodMed and its healthcare innovation solutions. So ladies and gentlemen, let's welcome Mr. Atul Tiwari on stage. Everyone, why there is so lack of applause? Come on.
Good morning, everyone. I am pleased to be here, and we are GoodMed, and we are here to present you the solutions and products that we have built so far in the world of AI. Now, as we all know, that technology is not just by speed here in the world of healthcare. It is all about trust, empathy, and human impact. And that's why the Indian AI journey is very important, and it is all about Sarvajan Hitai, Sarvajan Sukhai. India is entering a very powerful phase of artificial intelligence, and under the vision of Sri Damodar Das Modi, we are actually seeing that this is well positioned for public good. In healthcare, AI has to be handled with more responsibility, and because of trust, which is everything, patient, doctors, they all are part of the single ecosystem. Patients trust doctors, doctors trust their judgment, hospital trust their systems, and the society trust hospitals and doctors and the entire system. Our doctors are and the healthcare professionals are the cradle of trust. So the future of AI in healthcare cannot be about replacing any of them. It has to be about respecting doctors, respecting healthcare professionals, and building stronger intelligence systems which can work further. So today the biggest problem with the doctors are patients' trust and lack of it. Because doctors at times don't have a lot of time to treat, time to document, and a lot of clinical evaluation goes pending. It also comes across the challenges that patients are ill-informed due to the use of their own Google and own research and own AI. And that is exactly the problem comes in. The doctor writes a prescription, but after that patient leaves the hospital with no follow-up. And there's a lot of clinical records which goes missed. Hospital lose revenue and continue to be broken on the systems. And because the data is not present, there are issues. So that was the journey why Goodmed was formed. Let's look at the reality today, that what's happening across. There are close to 30 million prescriptions building up every day. 85% of the prescriptions in India are handwritten, and there are 40% of cases goes unreported on the data file. And it's close to 3 hours plus doctors do take on the documentation part. So what do doctors face? They face 40 to 60 patients per OPD session where they don't have time to think. Paper prescriptions are misread. There's no access to patient history. No structured discharge notes, and documentations are happening even after midnight. And what do patients experience? Prescriptions are misplaced. They don't have follow-up mechanism. There are duplicate diagnostics which are written in the documents. There are language barriers because English is the only language mostly people use while writing prescriptions and documents. There's a pharmacy confusion which happens. There is no guidance which happens for the patients. And there's a discharge disconnect. Hospital care, it ends where the patients gets out of place. The landscape of the doctors where world is heading is very different, wherein the likes of Google and Microsoft and OpenAI, they are deploying many use cases in the countries like US, Australia, and middle of the Europe. There are global AI tools which are available today, which are getting used out there. Ambient documentation, diagnostic imaging, which was even talked by the panelist here. There are clinical decision support systems also which are available. But then what happens in India? There are less tools to handle handwritten documents. There are multilingual supports which are not there, which actually requires Hindi, Telugu, or many of our native languages. And there's no OPD scale deployment. And for nurses, there are other issues as well. Nurses' chart are still prepared by hospitals. There's no shift handover automation which happens, and the reminders and protocols are delivered verbally, not digitally. That's how the data doesn't get transformed into the next range. So why AI is struggling in India? In India, AI is struggling because there are handwritten prescriptions. There are no digitized baselines. The HIS and the HMS which are there deployed in the hospitals are fragmented. Doctor resistance is complexity. Trust deficits in the AI output, which even some of the panelists were mentioning, that the AI which is currently obtained, we cannot trust all of them. And the language and literacy mismatch is always there. So the solutions which we are looking at is what India needs today is India, the AI which has to be there, it has to understand Indian doctors, it has to understand Indian prescriptions, it has to understand Indian languages, Indian habits, Indian OPD pressure, Indian hospital issues, Indian nursing workflows, and Indian revenue leakage which happens inside the hospital. And that's what Goodmed was meant for, and that's what the Goodmed thesis is. So I am introducing what Goodmed's hospital intelligence is. Goodmed offers OPD digitization. Goodmed offers patient WhatsApp integration where patients can get information on medicine reminders inside on their WhatsApp. Goodmed has their own AI engine, so there is no chat GPT, there is no Google where your data is actually going outside India or utilized by any public AI intelligence. It is made in-house inside India for India. Goodmed also helps in revenue intelligence for hospitals and institutions, and you can get discharge summaries and bill audit in seconds. I will invite my team just to showcase you the product. So ladies and gentlemen, I'm just going to showcase you that how GoodMed's one of the product which is Scribble that we have built so far works. In this, any of the pad you can write anything and it gets digitizes automatically. This is one of the product that we have built. Other than these products, we have also built some of the intelligent products which are about digitizing handwritten prescriptions, which has been a challenge so far, and we are the only company in this world which actually does that proper handwritten digitization of handwritten prescriptions. But out here we're going to showcase you how a typical digitization of document works. I'm typically copying how doctors are usually writing in the form of prescription. Don't count me wrong, this is just a practice exercise, so this is a test here for me. So here what I'm trying to showcase you all that this document will get digitized using our tool right away, and we will be sharing this digitized document not just to the patient but to the doctors on their portal as well as to the hospital HIS systems. Other than this, what we also offer is clinical support and intelligence system which actually digitizes and produces discharge summaries. So this is about how we are showcasing you one of our doctor's portal, and in this doctor's portal one can see that a doctor can have a list of their daily chores, which is about their appointments, their prescriptions that they have written so far, the test and the procedures and the things that they are doing, their patient statistics. And here is a tool where anybody can look at that this is the list of prescriptions they have been writing so far, and this is about faculties and their procedures also that can be bought out of this tool. And in this portal people can also look forward for their own voice based RX, so anybody can make prescriptions using their voice, the interaction between patient and the doctors. So see, the GoodMed, what we have done is we know how Indian conditions are, we know so much of chaos is there inside the doctor's chamber, and that's where we have built a tool which not just can understand the noise, the transactions and interactions. See, in US what happens is that ambient AI where a patient and the doctor's privilege interactions and discussions are there inside a cabin which is quiet, which is not full of noise. But in India a doctor's cabin is very different, it is full of chaos, there's so much of noise outside, there's so much of queues there. So such kind of tools which are there outside India are not prevalent in and as useful as in India. That is why we had to build something which can cater to this noise environment, and that is what I am trying to showcase you, that we are able to build tools which are meant for India, and that's where such product which can have prescription digitization not just on the handwritten one but also on the tab, we are able to build this. So ladies and gentlemen, we are trying to showcase you that this is just the prescription which I created just a moment ago, and this is how this prescription comes out and gets digitized right from the handwritten one to the digital one. The authenticity of such prescriptions works where what is written by the doctor and how accurate that it is, and such things are there which we can put it across to the tools. So this is where we are trying to showcase that digitization is actually an important thing, and why people like us have been building all this so far for you doctors and health professionals. So I'm going to showcase you further about the other tools that we have built. Alright. Okay, so here I'm going to showcase you that what exactly we are trying to do for doctors, nurses, patients and hospitals. And other than, as I said, that how sorry for this glitch. Okay, so sorry. Just the way I can show you that this is how our scribble works. We also have MRD to discharge summary solutions, which actually can convert the MRI to digital versions. We have, this is all about privacy and security that we have built so far. On the handwritten prescription, voice to prescription, we have built a privacy architecture across this. So there's no chat GPT, there's no Gemini, there's no Claude that we are using here. It is 100% secure and there's no third party LLM or any exposure to the data which is going outside. We want hospitals not to lose revenues. That's what it is important that they can achieve by recovering pharmacy revenues. They can have lab and imaging culture and doctor performance analytics around that. So it's important for hospitals to have that understanding of what doctors are writing and what's happening inside the hospital. We do audit for bills as well, whichever comes inside the hospital and being made. So what we are doing is we can scan all the MRD files and make a bill out of it and generate AI based bills so that audits can happen inside the hospital. Nothing can be missed, and we are ensuring that not all the data, most of every data is being captured on those documents. So this not just helps in TPA, this helps in manual audit, this helps in managing the billing and treatment mismatch, which actually is the cause of patient mistrust in every hospital. So this helps where the problems are. And what Goodman actually does is it actually flags severity and discrepancy, which also we also generate reports and surface that within seconds. And finally, what we build some of the other products which are there for ICU and ward, and some of the validations that we have done so far. So we have built this for this AI for India because here we are there for trust. Thank you, doctors. Thank you, everyone, for giving us this opportunity, and we look forward for any conversations for this session. Thank you.
Thank you, Mr. Atul Tiwari, for such great product showcase. We now move on to our next feature lecture. It is my privilege to invite Brigadier Dr. Arvind Lal, Executive Chairman of Dr. Lal Path Labs. Honorary Brigadier Dr. Arvind Lal is the Executive Chairman of Dr. Lal Path Labs, one of the India's leading diagnostic chains. A graduate of Armed Forces Medical College, he was awarded the Padma Shri in 2009 and became the first civilian doctor to receive the honorary rank of brigadier in the Armed Forces Medical Services. So he'll be talking on AI in diagnostics, opportunity over promise or transformation. Ladies and gentlemen, can we please give him a round of applause and welcome Brigadier Dr. Arvind Lal on stage.
Good morning, ladies and gentlemen. It is an honor and privilege to be here today to deliver the keynote address and chair the session on AI in diagnostics and clinical decision support. So, ladies and gentlemen, a thing to ponder over is that the diagnostics, that is the lab and the radiology, we are responsible for more than 70% of all clinical decisions which take place in clinical practice. And today AI is reshaping every facet of diagnostics. And perhaps now we are entering the most transformative phase yet, and that is the era of artificial intelligence. Therefore, question before us is not whether AI will become part of healthcare. The question is how we can integrate AI thoughtfully, responsibly, and equitably into our healthcare system. That is the question. At its core, AI brings one remarkable capability, and that is the power to process enormous amounts of multi-dimensional and data rapidly and generate insights that human beings alone may not be easily able to spot or detect. Take radiology, for example, and I'm glad the doyen of Indian radiology, Dr. Harsh Mahajan, is sitting here. So take radiology, for example. Today, machine learning algorithms analyze CT scans, MRIs, X-rays, and mammograms within seconds, not within minutes. And they sift out the normal report and identify subtle abnormalities that may otherwise would have gone unnoticed. Yet much of this data remains underutilized. AI enables us to unlock the hidden value within these massive data sets and convert information into actionable clinical intelligence and information, of course. AI's role extends far beyond imaging in pathology. Deep learning systems can analyze digital slides with remarkable precision, identifying cancer cells and unusual tissue patterns. In genomics, which is our latest field now, AI can interpret enormous sequencing data sets to identify mutations and biomarkers that guide targeted therapies and personalized medicine. Further, AI-driven laboratory automation is improving efficiency, reducing variability, and increasing throughput. This allows laboratory professionals to focus less on repetitive tasks and more on final interpretation and quality assurance. We at Dr. Lal Path Labs have emerged as one of India's leading adopters of artificial intelligence and digital pathology in histopathology and oncopathology, integrating advanced technologies to improve diagnostic accuracy, efficiency, and scalability. We started our digital pathology journey in 2018 with whole slide imaging, known as WSI, whole slide imaging scanner, followed by deployment of globally recognized AI platforms such as Visiopharm and breast biomarkers. May I have the first slide, please? So this is a slide for breast marker, Visiopharm, and also an IBX Galen for prostate cancer. So this is being, the AI is demarcating the cancer cells. So this is a case of prostate biopsy, and you can see how AI helps us. So far, we have reported over 90,000 digital pathology cases remotely, with more than 10,000 AI-assisted breast biomarker cases in over 2,000 AI-assisted prostate biopsy cases, which have been successfully analyzed. AI tools are being actively used for tumor detection, lymph node metastasis identification, tumor grading, cell quantification, detection of perineural invasion, and improving consistency in Gleason grading for prostate cancer. In internal validation studies, AI-assisted prostate cancer reporting demonstrated concordance levels of 99% with expert histopathologist consensus. So you can see where AI has reached. The laboratory also has implemented AI-assisted reporting for breast cancer biomarkers, including ER, PR, HER2-neu, significantly reducing equivocal HER2 cases and thereby lowering costs and improving treatment decisions for patients. In lymph node metastasis detection, AI is enabling faster and more accurate cancer staging, particularly for identifying micrometastasis and isolated tumor cells. In our lab, we continue to strengthen our precision in diagnostics by combining AI with expert pathologist oversight. Without pathologists, you can't still function. Ensuring that technology augments clinical judgment rather than replacing it. We are also exploring the next generation AI application, including prediction of molecular and genomic profiles directly from histopathology images, paving the way for the future of integrated precision oncology in India. Another major application of AI is the Internet of Medical Things. Excuse me, can you please be... Another major application of AI is the Internet of Medical Things, or IOMT. Wearables, remote sensors, and connected devices now continuously monitor heart rhythms, glucose levels, oxygen saturation, sleep patterns, and activity levels. AI analyzes these real-time streams of data and can generate early alerts for arrhythmias, deteriorating glucose control, or other emerging complications. This has profound implications for India, where there is a scarcity of qualified medical professionals. What makes AI truly revolutionary is its ability to integrate multiple streams of information like imaging, laboratory data, genomics, medical history, and real-time monitoring to create a more holistic understanding of the patient. This is the foundation of precision medicine. Beyond that, AI can also help identify subtle warning signs early, support personalized treatment decisions, and reduce delays in diagnosis. In many situations, AI-generated risk scores and alerts may outperform conventional calculations. However, while the technological potential is extraordinary, successful implementation requires much more than algorithms on the part of medical professionals. The real value of AI will depend on how effectively it is integrated into our clinical workflow. Clinical decision support systems powered by AI can assist healthcare workers and doctors in real time, suggesting differential diagnosis, flagging abnormal results, recommending evidence-based interventions, or identifying high-risk patients. But we need to be careful that these systems must support clinicians and not attempt to replace them. Healthcare institutions will need robust digital infrastructure, interoperability between electronic health records, laboratory systems, and imaging platforms, as well as continuous training of healthcare workers. Doctors and healthcare professionals must understand how AI reaches its conclusions, which is why explainable AI is becoming a more popular these days. Clinicians need transparency and not black box outputs. If an AI model identifies suspicious cellular patterns on histopathology slide or predicts the likelihood of malignancy, the clinician and the pathologist must be able to understand the reasoning behind that. AI systems are only as good as the data on which they are trained. India is an extraordinarily diverse country in terms of geography, socio-economic factors, as well as genetics. If AI models are trained on limited or non-representative data sets, they may perform poorly in certain populations and unintentionally widen healthcare disparities. Therefore, it is essential that Indian AI systems are trained and validated using diverse Indian data sets representing urban and rural populations alike. One must remember that the larger the pool size or sample size of the data to train the AI algorithm, the more precise and accurate the results will be. However, agentic AI is a tool that acts autonomously to achieve goals rather than just responding to prompts. That's also happening. When we discuss AI in healthcare, we must always connect it to real public health needs. And in India, our needs are immense. We are confronting a dual burden of diseases that include non-communicable diseases or NCDs or lifestyle diseases that include diabetes, hypertension, cardiovascular diseases, strokes, cancers, diseases of liver, kidney and lungs, which now account for 65% of deaths in our country. At the same time, India continues to bear one of the world's highest infection burdens in the form of rampant tuberculosis. It's not left us. In both cases, early detection is absolutely critical, and this is precisely where AI can make a transformational difference. Portable AI-enabled diagnostic tools are transforming community-level healthcare by enabling frontline health workers to conduct screening closer to where the people live, especially in rural and underserved areas where access to specialist and advanced diagnostic facilities is very limited. These technologies combine portable devices with artificial intelligence algorithms that can analyze data instantly, identify high-risk individuals, and facilitate timely referrals to higher centers whenever needed. A live example is our own. Where's Dr. Geeta Manjunath? She's my co-panelist. Doctor, please stand up. I want you to have a look at this lady. A live example is our own Dr. Geeta Manjunath, who is sitting right here. Her innovative breast cancer screening technology known as Niramai Thermalytics has revolutionized breast cancer screening. Under our own philanthropic initiative, which is known as the ALVL or Arvindal Vandanalal Foundation, we have partnered with Niramai in UP and Uttarakhand and screened more than 10,000 women using their or Niramai's Maitri thermal scanning device along with AI-based analytes to detect abnormal infrared heat patterns associated with breast cancer. So please give her a big applause for this, ladies and gentlemen. See, this is your own invention here, sitting right in front of you. Trained government frontline health workers and nurses conducted these screenings at our Ayushman Arogya Mandirs or health and wellness centers and camps. You would be happy to note that we have diagnosed 4 confirmed cases of breast cancer using this technology, which is 65% higher than the national prevalence rate of 2.6 cases per 10,000 women. So this is particularly valuable in India, where breast cancer is the #1 cancer for women and the current screenings are limited to manual breast examination, which is a highly subjective method. And this is, by the way, officially prescribed by Government of India. Manual detection, manual seeing of the tumor. Similarly, portable AI-assisted retinal screening devices are being used for diabetic retinopathy detection. Health workers can capture retinal images using handheld fundus cameras, while AI algorithms automatically identify early signs of retinal damage and refer high-risk patients to ophthalmologists for laser treatment before vision loss actually occurs. AI-enabled portable ECG devices also support early detection of cardiovascular disease. Community health workers can perform ECGs in villages, while AI interprets the readings in real time to detect cardiac abnormalities and arrhythmias that may otherwise go unnoticed. In infectious diseases, AI-enabled chest X-ray interpretation tools have demonstrated remarkable success in identifying TB cases rapidly and efficiently, especially in areas where radiologists are unavailable. In several public health programs across India, AI-assisted screening has significantly increased TB detection, including among patients who were originally undergoing imaging for unrelated reasons. Imagine a district hospital in rural India where a patient with chronic cough undergoes a chest X-ray. The AI system immediately flags suspicious abnormalities suggestive of TB or another abnormality like cancer. Further confirmatory testing is initiated, treatment begins early, and transmission within the community is reduced. But that's what our aim is. What previously took days may now happen within minutes. This is not science fiction. It is already happening in our rural India. These technologies are especially important for strengthening primary healthcare systems. They reduce dependence on specialist availability, improve early detection, shorten diagnostic delays, and enable targeted referral rather than being diagnosed at a specialized tertiary hospital only. By empowering frontline workers with AI-enabled tools, healthcare systems can move from reactive treatment to proactive and preventive care, which is what our aim is. Ultimately, this improves health outcomes at the population level. Yet technology alone cannot transform healthcare. We must simultaneously invest in people, that is clinicians, nurses, laboratory professionals, and community health workers. And all of them must be imparted training in AI in healthcare. How we are going to do it is what we should be debating here. Therefore, current medical education curriculum must include the latest AI-based digital technology. The healthcare workforce of the future must learn how to work alongside intelligent systems while preserving the human values like empathy and compassion at the core of medicine. We must also ensure that AI does not become concentrated only in elite urban areas or urban hospitals. The real success of AI will be measured by whether it improves access and outcomes for ordinary citizens in remote villages, small district hospitals, and underserved communities. The future of diagnostics will not be defined by machines alone, but by how intelligently humans and machines collaborate to improve patient outcomes. If implemented effectively and responsibly, AI has the potential to make healthcare smarter, faster, precise, and accessible. For India, this is no longer merely a technological advancement. It is a public health imperative. So let us work together to ensure that AI becomes not just an innovation, but a trusted partner in building a healthier India. Thank you very much, ladies and gentlemen.
Thank you so much, Brigadier Dr. Arvind Lal, for such informative lecture. Okay, so now we continue to our next panel discussion on the topic AI in diagnostics and clinical decision support. Diagnostics is perhaps one of the most rapidly evolving applications of artificial intelligence in healthcare today. But while AI promises speed, scalability, and improved decision support, Important questions remain around validation, reliability, accountability, and clinical integration. So I would once again invite our chairperson, Brigadier Dr. Arvind Lal, on stage. He is already there. And now I would like and invite the moderator for this session, Dr. Sanjeev Bagai, to the stage, please. Professor Dr. Sanjeev Bagai is a Padma Shri and Dr. B.C. Roy National Award recipient and a renowned pediatrician and pediatric nephrologist with over 35 years of experience in healthcare. He is the chairman of Nephron Clinics, managing partner at Bagai Ventures, LLP, and founder of multiple healthcare and wellness initiatives with significant contributions to clinical care, healthcare leadership, and medical education. I also get an opportunity to invite distinguished panelists to kindly join us on stage. Dr. Suchita Markan. Dr. Suchita Markan is scientist, and head of the Innovation and Translation Research Unit and mission in charge of the Medical Device and Diagnostic Mission Secretariat. So do we have Dr. Suchita Markan here? Ma'am, please welcome on stage. Next, I would like to call on stage Dr. Harsh Mahajan, the founder, Mahajan Imaging. He is an eminent radiologist who is founder and chairman of Mahajan Imaging and Labs, which runs a chain of integrated diagnostic centers in North India. He is a Padma Shri awardee 2002, former national president of Indian Radiological and Imaging Association. Everyone, can we please give them a round of applause? I would also like to call on stage Professor Dr. Anurag Agarwal. He is the Dean of Biosciences and Health Research at Ashoka University and a physician scientist. He has worked in pulmonary medicine and translation research, contributing to interdisciplinary approaches in health sciences. Everyone, please welcome Dr. Anurag Agarwal on stage. I would also like to call Dr. Geeta Manjunath. Dr. Geeta Manjunath is the founder, CEO, and CTO of Niramai Health Analytics, coming with over 30 years of experience in IT innovation. I would also like to call on stage Dr. Anupriya Gogna. Dr. Anupriya Gogna is the Journal Manager for Clinical Research and AI at Samsung India, where she leads clinical engagements across feature development, data programs, real-world evidence generation, and clinical validation. Everyone, can we please give them a round of applause to begin this amazing and insightful panel discussion.
So thank you very much once again, and we have a distinguished panel in front of you, and it is my honor and privilege to first invite Dr. Sanjeev Bagai to the podium for his remarks and his observations. Thank you.
Morning, everyone. I think everyone is very familiar with AI, especially with some topless oppositions in Pragati Maidan area and Bharat Mandapam, but that's on a lighter vein. But AI is a part of what we call as a digital journey for most healthcare ventures. I don't think we would have had a better congregation of healthcare leaders who are actually pioneers and innovators in digital technology in the healthcare platforms and AI. So very broadly, when you talk in terms of using these technologies, what are we looking at? So we are looking at better clinical outcomes. We are looking at better operational excellence. We are looking at better financial gain and escalation. Very often the discussion comes as what is the expense? And I very often give an answer that it's not an expense, it's an investment. And we did a study recently in one of the large corporate hospitals that the ROI as EBITDA margins in using this technology of X amount of money which you use is actually outbeating your clinical outcomes in terms of return on investment. These kind of technologies give you lower hospital-acquired infections, quicker turnaround time of diagnosis, better accuracy, both in terms of specificity and sensitivity. And more importantly, it's that outreach to the last mile connectivity. So if we have to go to the bottom end of the pyramid, these technologies help a great deal. Let's go straight into the discussion. Thank you, Arvind, and thank you everyone on panel.
So diagnostics is where AI has shown the most promise globally, as well as supporting guide in clinical decision making, but the final clinical decision that remains largely human driven due to complex scenario, individualized contents and accountability needs. So let me start the next, this context for all, and are we truly ready to trust AI in clinical decisions, or are we still in an assistive phase? So what are the challenges? And for this, I would like to request Dr. Suchita Markan on public health and data reality. So Dr. Suchita, you've been both promising and struggling with the AI tools. Why do many AI diagnostic solutions fail to move from pilot projects into real hospital workflows in India? So could you enlighten us on this, please?
Thank you, sir, for this question. So, just to give you a background on ICMR was earlier only doing the funding part of it. So we were just giving different kind of funds like small grant, intermediate grant, with the funding ranging from maybe 2 crores to 15 crores, and in fact 25 crores when it comes to NHRPs. What we realized that we need to now move forward and try to give guidance to the startup innovators, biomedical innovators in the country. And this is a good opportunity I thought I'll share with you that there are two leading initiatives which ICMR is now leading, wherein we do a lot of work for the innovators. One is called Medical Innovations Patent Mitra, by virtue of which we give hand-holding support to innovators, any bio-innovator across the country to file, to undertake patentability assessment, patent filing and tech transfer. Everything is being borne by the ICMR. So entire funding is given by ICMR. And this we are doing so that the innovators which come to us, we want them to join hands with the industry and then come to us. So once the innovator comes to us after technology being transferred hand in hand with the industry, then we have another initiative called MedTech Mitra initiative, wherein we sit with the regulators there, the Deputy Drug Controller, Device and Diagnostics sit with us, and we follow a whole of government approach and then help innovators understand the regulatory strategy upfront. Pre-IND kind of a discussion we do with them and give the regulatory strategy in writing to the innovators. Every innovator we talk, we give them a strategy which the regulators recommend. And then we also facilitate clinical study, preclinical study. In fact, the ones who have received manufacturing license, we also do cost effectiveness evaluation through HTA to see if we can recommend uptake of new products. Why I am telling these things is because this gives us a lot of idea and exposure to the kind of innovations which are happening in the country. And I just wanted to tell you that through Patent Mitra initiative in 1 year, we have transferred 32 technologies to different industry partners in 1 year, and 190 applications we have filed for all being borne by ICMR, all the funding support we have given. And on 25th, we are going to have a mega event wherein we'll do huge lot of tech transfers, do material transfer as well, which will be like news to the people here in the room that ICMR was not very clear on how to do material transfer. Now we'll be opening up our gates to do material transfer as well, technology transfer, material transfer, granted patent licensing. 30 plus deals we are expecting to do on this 25th of May. And many of you might have attended the webinar by our secretary yesterday. So this is just the base to tell you that how we get a great exposure to the innovations in the country. And in MedTech Mitra, we have talked to, in 2 years' time, we have talked to 800 plus innovators. And as ICMR team, we are accountable to each and every innovation which comes to us. While talking to the innovators like that in 101 in those meetings, we understand that the innovators are really bubbling to develop technologies. They really want to develop technologies which are SAMD software as medical device, standalone medical devices, and software in the medical device, integrated into the medical device, SIMD. So these are two kind of products in different forms and flavors which come to us, and we are accountable to those innovators when we talk to them. What we feel, as sir mentioned in the morning, that he has already set the stage, the kind of products which we are seeing today. There are wearable products, there are doctor's assistant kind of products, there are deep products which ICMR is hand-holding aligned with the national health priorities like handheld X-ray device or maybe CXIR kind of a product, or for a AI-based product for diabetic retinopathy for screening of patients. So those kind of products, we identify innovators and help them develop those products as well. So what we see now as a challenge is threefold. One, the products which we are trying to support, one, the innovator is not very much aware of how to develop the regulatory strategy for an SAMD. What are the quality standards for those products? There are three kind of things innovator needs to keep in mind while developing AI products. One, the product should be very, very robust. As sir mentioned, it should be validated in real life settings. It should be very accurate. It should be regulatory compliant. It should follow all the ethical guidelines which are required to be able to train the data. So these are the 3-4 things which we see, and for simple products like wearables, they may not even fall under the category of medical devices, and if they are categorized as wellness products, the problem is not that much. But if the product is helping you in clinical decision making, then the responsibility becomes very, very huge. So just to summarize 3-4 challenges which we feel we are facing, sir, in real life challenges that we are facing is, number one, although guidelines are coming up as far as regulations are concerned, for SIMD, regulator is comfortable, ICMR is comfortable in giving them a recommendation, because then you have to work more on the device aspect. The software aspect becomes secondary. The device is there, we are comfortable recommending the regulatory strategy. When it comes to SAMD, there are multiple challenges. One, the innovator, the regulator does not know very clearly where to stop. The softwares as such which is developed by the innovator is a code. They will keep on refining the code. So we always recommend the innovator that you have to give a hard stop. The test batch stage has to be there. When you come to the regulator, it's a hard stop. You can't change the software code after that. It should be robustly trained when you come to the regulator. If you train the tool after reaching to the regulator, which means it's a version 2, it's not the same product. So this is the problem, that there is a lot of version changes. QMS compliance is an issue. What are the standards applicable for that software? They are still evolving. In foreign countries, the situation is clear, but in India, this is an issue. The third very, very important challenge from public health perspective, which we believe we want to really inculcate that into the innovators' veins and minds, like Mera madam has done that very well. So statistically identifying what is the quantum of data which needs to be trained for the tool to be effectively implementing the intended use for which the product is being developed is very, very important. There are two kind of data sets. One is the training data set. You need a training data set to be able to train the tool. Then you have a validation data set, which is equally important. The diversity of the data which you should include in training the tool and then validating the tool becomes very important. The validation and implementation even needs to be done in a real life. It should not be a static data itself. So these are the things. And fourth thing is, the doctor is not very much ready as of now. They feel that maybe it's not very transparently made, they can't trust. Sometimes they may feel that the product will replace the doctor. But of course, in any stage, if an AI tool comes, it will definitely only complement what doctor wants to do. So, sir, I think these are 3-4 major issues which we feel if we are able to do that. And fourth, of course, is the ethical use of AI, which ICMR has come up with the guidelines also. The ethical guidelines for AI in biomedical research and healthcare, that's again very, very important. So getting the issue which innovators now turning tables on innovator side, the innovator knows that these are the things they need. where do they get this data set, which is authentic data set, which is a standard data set, which can be used for the innovators to train the tool, is again an issue. And on that perspective, sir, ICMR is trying to, knowing these issues, ICMR is trying to build that standard data sets. One institute is dedicated to developing those standard data sets, which we believe in the, we'll put it in public domain for anybody to use those data sets. And we'll of course start with national health priorities. Needs of the countries are huge. We'll start from somewhere and keep adding things in our wish list. So basically these are 3-4 things which are coming time and again to us, and we believe that from that perspective we are able to bridge those challenges. We can take things to the next level. Thank you, sir.
Thank you very much. So I now hand over the mic to our moderator, and that is Dr. Sanjeev Bagai. All of you know him. He's a very well-known nephrologist, and God bless him. The work which he has done is, I think, incomparable to anybody else. So Sanjeev, please take the session forward.
Thank you, sir. Thank you. Question for Harsh, who needs no introduction whatsoever. He's revolutionized imaging to actually imagining. Just day before yesterday, I was seeing a family in whose grandfather had difficulty in swallowing. He had seen GIs, he had seen respiratory physicians, and I said, why don't you go across and get a couple of imagings of the neck? And Harsh's center at SDA picked up a malignant thyroid nodule, who was then confirmed with a biopsy. They went back out of town to the hometown. So I think accuracy, reliability, the most important when you send a patient to a radio diagnostics center, the key word is trust, because we depend upon just that to clinch our diagnosis. Harsh, give me a brief overview of your experience on AI in radiology, imaging, and how you can convert that into better sensitivity, specificity for our diagnosis as clinicians. Over to you, Harsh.
Thank you very much, Sanjeev. We've been involved with AI, building AI, and also using AI for the last 10 years. 2016 is when we started building algorithms, and at that time we had deep learning, which had just come in, and so I think that is what spurred all the AI tools that got made. And just to tell you, in 2018 we presented at RSNA in Chicago, which is the largest medical gathering on earth, about 70,000-80,000 people there. An AI tool where if you gave me a CT scan of the chest using an AI tool which we built in-house in Margin Imaging and Labs, we were able to give you a PET CT without actually doing the PET. And this was, people say we are lagging behind in AI. I think across the length and breadth of the country, there have been small, startups, there have been academic institutions, there have been, centers like ours, hospitals, IITs, which have, and engineering college, regional engineering colleges, which have been building tools. It's just that, there was no means of putting it all together, which ICMR now is attempting to do. Second, what we built in the early days, by 2018-19, we realized that there are hundreds of tools globally available for AI, especially in the field of radiology. Why radiology? Because we've been digital since at least 3 decades. So it was low-hanging fruit. And what we realized is hundreds of imaging AI tools available, but nothing being used. Because, and partially to answer the question that was asked to Dr. Markhan just now, just to onboard a AI tool into a PACS system or a hospital information system used to take 6 to 9 months. And these are, pilot studies that were done in Australia, which we had done. And would take 50 to 60,000 US dollars to onboard, say, one chest X-ray algorithm into a hospital system. That's when we realized that there has to be a platform approach to deployment of AI in hospitals. And we were the first actually to suggest the platform approach, and then we went ahead and actually built that platform, which today is run by my son, who's a physician with an MBA. And I think the MBA helps because it changes the way you think. This is called Carpal.ai, completely built in Defense Colony not far from here, which today is the only AI platform in the world, and I speak with full responsibility, which is US FDA approved, which happened 2 years ago. The only one still, which is CE marked, which is approved by the Singapore, Australian, and the Brazilian governments for use. These are the 5 countries where this is used, and today being used at Harvard, Stanford, Thomas Jefferson, Emory, Yale. Only 3 days ago, it's gone into MD Anderson at Houston. It's used by the best centers. Why is it not there in India? Because of all the constraints that have been said. As we digitize, as we become more robust, and as the price differential which you can get by this deployment, it comes about, I think it'll come here. Someone said, I think Dr. Lal said, we need to build algorithms to solve our problems in our country, and we need to do that. Since we've been involved with this, and we work with the IITs, we work with AIIMS, and so many other institutions, collaboration is very, very important. And 2, we need to first identify a problem and then build a solution for it, and not vice versa. We have these youngsters coming and saying, we built this, can you use it? It doesn't work like that. So I would say we are proud of what is happening in this country. We are proud that this is, it's the largest, Carpal is the largest marketplace for AI in the world. Over 280 AI applications on it, and all can be used seamlessly, and you pay per use of an algorithm. So if there are 15, and someone also said, how do you build trust? That you build with validation and testing. Yeah, you said that. So, and that is also enabled through this platform, which is not just a deployment platform, but a platform for validation, testing, fine-tuning. You talked of sensitivity, specificity. You can actually move the needle and change that. I could go on and on, but I think I'll pause here.
Two quick questions, Harish. How, Delhi, especially Northern India, saw a deluge of HRCT, especially in COVID. How did AI help us to grade and specify COVID intensity, especially for patients who
So
were with
these were
severe COVID?
in-house algorithms that were built. The number of CT scans being done during COVID, rightly or wrongly, I did protest that too much is being done unnecessarily, but that's besides the point. We were swamped with the numbers. Radiologists just could not cope, and that's when in-house AI algorithms were built, which helped us in actually assessing the severity of disease. That score we used to have, and it was very, very helpful. As things stand today, our national TB program utilizes handheld X-rays, and more than 5 million have been already done. They are going from district to district, town to town, village to village with handheld X-ray and a laptop in which there is AI, which is doing just one thing, differentiating a normal chest X-ray from abnormal. The abnormals are taken out, and the percentages are small because this is a population level thing. And I think we've been leaders globally in the use of AI, even in remote areas of the country. And So I think we need to actually use it, and I'll leave you with one other fact, that the first paper on artificial intelligence ever to be published in the Lancet came from India.
I think that
Our
deserves a
group,
round of
along
applause.
with,
Can we have a round of applause for
along
all
with
Indian doctors?
you know, Cure.ai out of Mumbai, which is doing very, very well globally.
Thank you, Aj. My next question for Dr. Anurag, who is having a long-term experience in biomedical research on public health, is on AI models trained with limited data sets, and they remain reliable. Being such a diverse real-world population, take it forward.
Thank you very much. You know, as Dr. Harsh Mahajan just said, this is a challenge everywhere. Things are trained on data in one place, don't work well in another. I wish there was an answer that said it does not matter without any additional data. We can fix it. That's not true, but we can make do with a limited amount of data. I'll give you a very specific example using chest X-rays, which is where we ended. So we'll continue from there. When chest X-ray diagnosis for TB was built in Africa by a Dutch company, and tested in Pakistan and in India, there was a very poor specificity. Pretty much every fourth X-ray was being read as a false positive, presumably because of what we call dirty lungs in polluted area. All that was required to be done after somebody understood that specificities can be poor, shift the transition point between plus and minus, get the specificity right away, you lose some sensitivity, and you make the trade-off where it works for India. The correct answer, of course, is you retrain the algorithm with additional data from India, which Mahajan, ICMR, many other people provided, and with additional data sets, of course, we created even better ones. As of today, we are seeing this problem again because India is a very heterogeneous place. What worked then in urban data sets is not working right now very well in Northeast. So this will be a continuously running problem, but is there a way out of it fundamentally? And that answer might come from what are called foundation models. When you take massive amounts of data, the type that Mahajan Imaging has, which already represents a reasonable spectrum, and you train them in the path of understanding what an X-ray is, what it looks like, there is a greater degree of ability to handle things from more extreme distributions. You still have to fine tune. It is not zero data, but you can get to few shot learning on top of it. And for most things, you can do it well. And that's the best direction I can think of. And of course, you have engineers who can add to it.
Thank you. Dr. Geeta, we were just chatting before the session started. So they have an indigenous model for screening of breast cancer. Does anyone in the audience know what the incidence of breast cancer is? India is having, and what is reported, and India is not totally digitalized. And in tier 2, tier 3 cities, the population of advanced healthcare is still limited. In villages and in true rural areas, we don't have specialists. The specialist shortage is more than 50%. We are still clocking in 2 lakh new patients of breast cancers every year. That's adding on to the disease burden load, out of which 47% of them die in treatment or just at the completion of treatment. 1 in 22 women in metros are liable as a lifetime risk to develop a breast lump. Breast screening forms the most important fundamental screening and early diagnosis tool. Please tell us about your device. Keep it brief. I would also like you to tell us, because hers is a thermal scanning device, I would also like you to highlight how you differentiate temperature variations in different parts of the body to give better results. What is male versus female temperature difference, what you know of? How would you differentiate a temperature difference thermal scanner of breast versus an inflammatory nodule? Or indeed, if a patient has fever of any origin or unknown origin, and what is, I'm sorry, I'm asking a host of questions, but just so that you can keep it together. And what is the environmental temperature variation or impact on your device? Over to you.
Yeah, I'll try to sort of summarize, and thank you so much for the opportunity. First and foremost, I think Dr. Sanjeev gave excellent statistics already. Just one more statistics, which is what is very, very alarming in India. That is the screening rate. That is, if you take 100 women and ask this question, have you ever had a mammogram? Not have you had a mammogram last year, 2 years back. Ever had a mammogram? And the person is between 45 and 70 who qualify for a mammogram. The answer is 1.3% of women will say yes. It's alarming because the same number in US is 76%. And that explains the alarming 50%, 47% mortality that Dr. Sanjeev mentioned. That means they're not even coming to Mahajan Imaging to do the mammogram. So even if you use the AI, right, having such a wonderful thing. So how do we ensure that 98.7% of women don't detect their cancer by hand, but with a technology which is better than hand, and then enable a screening method which can bring people to further diagnostics, which are affordable, because there are affordability, accessibility issues, several issues why they don't do it, and we can take that up separately. So what we have done is to use, as Dr. Sanjeev sir mentioned, to use a thermal imaging device which measures temperature variations on the chest and converts, using AI, a set of 25 different machine learning algorithms which work in conjunction to generate a report which says, is there an abnormality or not? What is the probability that it's actually malignant, and also mark the area of likely malignancy so that a follow-up diagnostic workup can be done using an ultrasound, mammo, MRI as needed based on the age of the person and density of the breast. To answer specifically the scientific elements and also referring to the earlier conversations about the trust and clinical efficacy, it has taken us, we also started in 2016, we had some early results and so on. Tremendous amount of multiple clinical studies that we had to do in different type of population. So specifically, if I want to give a glimpse of the technology, just like there is a lump in the density domain, and lump can be benign or malignant, we define the concept. This is the first time ever in the world, by the way, that we're using AI on thermal imaging. Has been around. That's not our idea. But how do we make AI on thermal imaging so that it becomes a standalone screening modality? That is where we invented and got 40 patents around the world, granted even in the US and so on. So just like a lump in the density domain, we come up with a concept like a hotspot in a temperature domain. And that's completely unique and innovative way of determining what is a hotspot. And then once there is a hotspot, just like a lump can be benign or malignant, we have about 127 parameters which identify or tries to predict whether that hotspot is likely to be benign or malignant. So in this way, we are able to differentiate between, let's say, an inflammation, a benign condition, fibroadenoma, fibrocystic disease, and then we give a estimated Biret scoring. We call it B score. So the Biret scoring will tell you 1, 2, 3, 4, 5, like normally, and 4 and 5, or 3, 4, 5 would basically send them to a mammogram and ultrasound as a follow-up. So using these innovative AI algorithms, sir, that is the best way, and the way that we have innovated. We call it vascular radiomics, new type of biomarkers we can assume, right? Because we measure 4 lakh temperature points per person, identify these minute variations, which are called thermal biomarkers, and also we have a unique method of identifying high velocity blood flow. It's like a Doppler. So with the high velocity blood flow, we see that there is higher velocity, high blood flow happening in the upper inner quadrant.
Dr. Geeta, just 1 second. So what I would like to emphasize here is that in this country where you have rampant breast cancer, so please remember they have a device, and what do you call it? Niramide. Please remember this name, and this is going to cause a revolution in the detection of breast cancer.
Thank you so much,
I think we will leave it at that. And, and we ourselves screened more than 10,000 of them with their device. 10,000. We've already used the device for screening. So,
Yes, sir.
yeah. So I think we'll go ahead.
Happy to collaborate with anyone here. Thank you, sir.
Last and not the least, Dr. Anupriya, being a facilitator of AI devices, what are the barriers, what are the bottlenecks which you experience, and what would you like things to overcome so that the endpoint connectivity in terms of seamless connectivity is achieved? Over to you.
Thank you, Dr. Bagai. Hello, everyone. before I move on to the barriers, just carrying on with the theme that AI is here, AI is helping. We all know. So far, I believe what AI has achieved is being a good workflow assistant. It is there to support you. It can help with triaging. It can help with routine examinations. It can help with automated measurements. It can reduce cognitive loads. It can identify patterns very well. So AI has essentially handled to a large extent the problem of the big data. You feed it enough data, it will spit out enough insights and expertise on it. But that technology has still not penetrated everywhere, and I think those are the practical barriers. Those starting off with awareness and trust. What you don't know, you can't use. So the first thing is awareness of where AI exists, like this awareness that Dr. Digita has this tool of Niramai, or the CT scanning or the breast assessment that Dr. Lal pointed out earlier. So those things is the awareness that there is an AI feature which can assist in it. But also with it, the trust. You can't trust something that you don't understand. So you need not just know what is out there, you also need to know what is it doing, how is it doing that, and where that is have the potential to fail, because AI is not foolproof. So you as clinicians need to know where can it potentially fail, because you can't leave your patient into the hands of something that you don't trust yourself. So I think that barrier of awareness and trust needs to be overcome. Still there is a way to go forward. The other aspect that I think is a practical barrier is penetration. AI cannot just sit in fancy clinics in high-end cities in just the metropolitan like Delhi or in the most advanced of hospitals. The true need is where it can penetrate tier 2, tier 3 cities. It can go into the hands of the clinician who is still not as expert as, as let's say some of the panelists sitting here or some of you sitting there. So I think that penetration to mid-tier devices on the cost is a big factor, right? So cost is a big factor, spread is a big factor. So I think penetration is another potential practical barrier. But while we solve those problems in the deployment domain, technology has to move forward. It has to become from an AI workflow assistant tool to a second expert, to a second eye. And that I feel is the next milestone where technology should go. It should move to the small data problem. It can handle the routine examination. What about identifying an anomaly? Now, if you're looking at patient biology, for human biology, the normal is not a point, it is a wide spectrum. So to differentiate what is abnormal is not as easy as it could be for other domains, right? So I think that's where AI, technology-wise, needs to move forward. That barriers still exist, that it should be able to act as a second eye, as a second expert, help in identifying pathological cases, help in determining early diagnostics, early biomarkers for disease, so that we can actually stop the things from spreading and look at the imaging or look at the data in a way which a human eye may be missing. So I think those are the barriers which we still need to overcome.
Thank you. I'll request Arvind just to give a line as closing remarks.
So thank you very much, my fellow panelists, and it is, for all of us to understand that unless you diagnose, you can't treat. So you heard the problem, the number of cases in India. It is, humongous. So what I request each one of you to do in your individual capacity is to encourage more screening. And in that screening, well, there is, they have the best device as far as I know, that is Niramai thermal scanning for breast cancer. And especially all the ladies must remember, this is the #1 cancer for ladies. So please take the mantle and do something about it. Thank you very much.
So everyone, can you please give them a huge round of applause for such highly insightful discussion. The conversation clearly highlights that while AI in diagnostic holds tremendous promise, building trust, clinical validation, and interoperability will be critical for long-term adoption. So thank you so much, and I request all of you to please come forward. And I would request Dr. Kamalkant Kohli to please come up on the stage and felicitate all of our esteemed panelists, chairperson, and moderator. Thank you so much once again. Everyone, let's keep cheering and applauding for all our esteemed panelists, moderator, chairperson on the stage. Let's have a group photograph. Everyone, all eyes on the camera. Thank you so much. Thank you. I request panelists of this session to please head towards the media room to give a short media bye. We request the panelists of this session to please head towards the media room to give a small media bye. Okay, so we now move on to our next special lecture, The Future of Digital Health in India. It's my privilege to invite Ms. Sunita Verma, Group Coordinator, Research and Development at the Ministry of Electronics and Information Technology, Government of India. Srimati Sunita Verma is a Scientist G and Group Coordinator, R&D at the Ministry of Electronics and Information Technology. She oversees national R&D programs in electronics, information technology, communications, and broadband technologies with a focus on deep tech, semiconductors, and indigenous innovation. She will be speaking on the future of digital health in India. So we are just waiting for Ms. Sunita Verma to come up to begin this session. Yes. So everyone, can we please give her a round of applause, Ms. Sunita Verma, for her next special lecture on the topic, the future of digital health in India. So over to Ms. Sunita ma'am, please.
Good morning to all of you. All the important, I think, healthcare providers or the prominent and eminent participants in this conference who are taking care of the health of this country. I am proud to be part of this conference and to be associated and talk about the interventions of AI in healthcare. METI has been supporting research as well as deploying many services in the healthcare sector. You must have seen during the COVID also, there were apps which were developed with the help of METI for the traceability of the vaccines which were given, the platform for giving more information about COVID. So this is not a journey where it has started now. It has been there where the technology has always been assisting the healthcare providers. But now it becomes imperative that as AI is becoming more a part of daily life of everyone, it becomes just very important that healthcare being a very important vertical, that AI is understood by the healthcare providers. The power of AI, the technology which can be used by the doctors, the medical practitioners, and the medical innovators in this country. Now the effort has taken a very structured form with the India AI mission, which is being spearheaded by the Ministry of Electronics and IT, my ministry, where this mission, you recently must have heard about the AI Summit. There was a special vertical for healthcare there, in which we were trying to see how AI can become an enabler, a tool, a strength for the medical healthcare providers. The intent is clear that AI should not remain limited to few domains or institutions. It should reach every sector. And among all sectors, healthcare stands out as one of the most critical and sensitive of all sectors. From the government point of view also, healthcare has been given priority. The emphasis is on making the healthcare solutions reach the grassroots level with accessibility and solutions which are very easily adopted by the healthcare workers. AI has a potential to transform this in multiple ways. It can enhance the diagnostic accuracy, improve the efficiency in clinical workflows, support decision making, and expand accessibility to quality care, especially to underserved regions. But healthcare is not just another sector, it is a domain which is built on trust, responsibility, and human judgment. It is very critical or very important that when AI is used by the healthcare providers, by the doctors, professionals, the responsible and ethical use of AI comes into play. The algorithms, the large language models which are developed using the data sets from the patient data set, that data set needs to be properly annotated, curated, to be used by researchers. There should be no biasing in the database which is used. Otherwise, the tools and algorithms which are developed, they they tend to be biased and give not very accurate diagnosis. So this becomes, the AI technology becomes an enabler, and but only guided by the vision of the doctors or with intervention from the professionals and experts in this area. While the technology is advancing rapidly, the preparedness of the users, particularly the healthcare professionals, needs very focused attention, because ultimately the effectiveness of AI in healthcare will depend not only the solutions or the algorithms that we develop, but also on all the medical professionals who use it. In this context, the idea is that every doctor should be empowered to have the knowledge and the understanding and the use of AI responsibility to be, and it becomes very important. In fact, just before this lecture, I was just discussing with Dr. Prem Agarwal, and he said that the standards in the AI for healthcare is something which is very important. So while METI is looking into, from the AI mission point of view, into the various verticals where AI is required or can be adopted, standards in AI as in healthcare become very important. And I applaud the initiative which has been taken from Dr. Prem Agarwal's team. We see representation from National Medical Commission, National Board of Examination in Medical Science, Dental Council of India, ICMR. I saw some of my colleagues here from ICMR also here. So it is not only a one organization or one entity or one government department which is working together. It is all of them together working for the cause of how the intelligent adoption of technology or AI can be looked into for transforming the way medicine is being used for the people's benefit. Looking forward, there are several areas where collaboration can be strengthened. There can be capacity building among the healthcare professionals. METI runs a program, Future Skills, which is basically for adoption or the understanding of how AI can be used by various different professionals in different domains. So healthcare is also one of them. Future Skills gives a very, I'll say, a basic or fundamental understanding of AI. And I would invite you all to use that platform. It is run by NASCOM for METI. And you can specifically register for the sessions or for any courses that would be aligned towards the healthcare. Besides capacity building, development of validated clinical use cases, creation of ethical and regulatory framework, and strengthening of data and research ecosystem. This is what I feel is very important when we talk about AI for healthcare. These are not independent efforts, but we all move together towards bringing all of them together to make innovation without the integration remaining incomplete. The AI mission also emphasizes on public-private partnership. I've been told that there are various startups in healthcare which are attending this conference. So METI is looking into problem statements in healthcare domain from the startups, and there are regular call for proposals where we are looking at some solutions which are to be made. Startups are funded for these problem statements, and there is a close collaboration with ICMR, DHR, Ministry of Health for these solutions. AI mission also encourages collaboration between government, academia, industry and startups for not only development of solutions in using AI, but also in medical electronics. So most of the equipment, medical equipment at present is imported. And METI's efforts along with Ministry of Health and Family Welfare and ICMR is to develop our own indigenous solutions, and with the content of AI or smartness built into it. So I'll just need to name a few. METI has supported development of linear accelerator, medical linear accelerator for radiotherapy, 1.5 Tesla MRI machine, breast cancer screening vest, cervix cancer screening. Also, there are various platforms which have been developed by startups, by academic institutions, which have been widely adopted by the industry also, for healthcare diagnostic, personalized treatment, for health management, for hospital management, which I feel is a step towards development management and also solutions for healthcare. With the right alignment, India can develop solutions that are not only scalable within the country, but are also relevant globally. So we have many solutions which have gone global. India has this unique strength, and as we see, we have a very young demography at present, and in few years' time we'll have the same number of octogenarians. 65% of our population is below 35 years of age, and maybe as the time comes, we'll have the 65% population which will fall into octogenarian category. We need to develop healthcare solutions for these. I think we have all experts sitting here. I don't need to emphasize this point, but AI can help a lot in improving the lifestyle, improving the quality of life of our octogenarians who are 80 plus people, with the life expectancy been increased. And I'm looking forward to industry and startups coming out with the solutions, with close consultation of all the doctors, the hospitals, and the hospital management systems, which will not be adopted only within the country, but also can go global. There is a clear potential that such efforts would align with the broader objective of the India AI mission. To understand the model, there are 7 pillars in India AI mission. If you look one by one, the first is that the AI mission gives the compute. So when we say the compute, there is a centralized compute facility which is being given. The compute facility can be used by the researchers, by the industry, by the policymakers, by professionals to come out with large language models or research. There is another vertical where the repository of data sets with respect to all medical related research will be kept. This data set will make sure that it is curated, it is annotated, and the anonymity is preserved for it to be used by the researchers and the medical fraternity for furthering their decision-making platforms if they want to prepare. Another is the specific startup encouragement, the funding for the startups. That is there, I've already told about that. Then another is, fourth one is on the capacity building. We need specific focused capacity building in this area. And like the specialists, the various specialists which are there in the different verticals in the medical expertise, I feel the capacity building needs to be actually led by the medical fraternity, where they can see where the gap is where the technology can be used for furthering and bettering the solutions that they provide. So that capacity building program is there. We can invite the all the various forums and the mission, the AI digital mission of the doctors that is here to contribute in this. So, and the most important vertical I'll say is on the responsible and ethical use of AI. So like we have ethical committees for any research or clinical trials to be undertaken. It is very important that the data sets which we use are developing unbiased algorithms. And and AI is used ethically. While we say that, it is that AI in the medical sector is not something which can be automated. There has to be a very close human intervention or professional doctor's intervention when we develop these tools. For it to be effective, for it to be not biased, to give us proper and accurate predictions. And I feel that these pillars of AI mission will be able to enhance the knowledge, enhance the penetration of AI into the medical way of working, into developing more and more solutions, because you all doctors are the ones who actually work with the patients. You know the challenges, and you sometimes know the also always know the requirement, the need that is there for technology interventions which can enhance the personalized treatment of the patients. So I feel that AI mission, along with all the doctors, professionals who are sitting here and who are actually they have a say in the healthcare of this country. They come forward and work, and we all work together to see that we use the tool to be of assistance and not we become totally dependent on the tool. So the AI tools or AI technology is for assistance, for the betterment of the solutions, but I still feel we cannot make just all solutions using AI. There has to be a doctor in the center of all of it. Technology strengthens the core value of medicine and it can never replace it. So all the doctors, they are all still required, very much in demand, because I'll just give an example of the driverless cars that we have. So, but there are very few people who have confidence in sitting in the driverless cars, although the technology is much advanced, because they want a human driver sitting there all the time. So, but when the patient hands over his health or his life in the hands of doctors, so it is that with the technology intervention, the doctors comes out with the best of the solutions which can be there for the patients. So let me just conclude with a simple thought that AI is a powerful enabler, but its true impact will depend on how well we prepare ourselves to use it. In healthcare, that preparation must include not only the systems, but also the people. I'm confident that the discussions and the initiatives which are emerging from this platform, this wonderful conference that you are having today, will contribute meaningfully in this journey. I was very happy to note that this conference has the AI focus, and And there are so many doctors who are interested to know how AI can be used. And from the ministry, I extend all the support to the medical fraternity in whatever way the technology can be used for the policy interventions, for development of standards, for extending the data sets, for repository development, for researchers, and many more, any solutions which can you think that needs there, that is required for the country and globally with the AI intervention. And I look forward to continue the dialogue and collaboration in integrating the healthcare effectively with the India AI mission. I think this is just the beginning. We have a long journey to cover, and together I think we can do it. No more it is working in silos, that electronics is different, AI is different, technology is different, and medicine is different. It is that all of them are integrated, amalgamated to bring out the best solutions. Thank you for giving me this opportunity to share my thoughts. And Dr. Prema Agarwal, I'm very thankful to you to give me this platform to share the interventions of AI, and I look forward to more and more collaboration as we go along. Thank you.
Dr. Sunita Verma is a group director and is the presenting health AI mission of the country. In fact, she is the representative of Modi ji to bring out country as one of the foremost place for AI. And the DIA mission which he talked about is about the whole of the India into AI. But healthcare is different. Healthcare में टेक्नोलॉजी का यूजेज जो है उसमें एक ह्यूमन टच होना ही पड़ता है. Understanding that patient, the trust which the AI cannot give it, trust and belief and the relationship has to be created by a doctor. So what is more important is that we do not allow the random, uncontrolled uses of AI into healthcare. Otherwise, after some time, you'll find that technology and the marketers of technology will lead the system rather than the only doctor. So what is required with Madam's discussions and Dr. Abhijash's discussions and ICMR discussions, that we must have the minimal standards that should be adopted in healthcare, health education, medical research. These standards should be common to all. But there can be always some people who are doing better, who are doing best. That option is always there. But the minimal standards of practice should be always be there. And the other thing which has come up is a repository that we've got 10,000 or more postgraduate theses which are being done every year, and they go to trash, to place which is not known. And now all those theses and the medical research done in the country will be reposited into a repository, and that particular repository can be referred so that we can avoid plagiarism, we can avoid duplication, we can avoid, and one data can be used for other repository also. So with this and the patronage of the group director of IT Ministry, Methi, and the Secretary Methi, I'm sure that we will go a long way. This conference is basically to sensitize. This is a very great opportunity where we're finding a convergence of the stakeholders, the councils, the administrators, and the visionaries and the executionists of the country, policymakers. So we together can definitely give a new line. This conference is just not one another conference. This is going to be a direction creating conference where we can go a long way. Thank you very, very much, madam. Can I go for this? We will say that there is going to be a long way.
Everyone, the clapping should not stop. And thank you so much, Ms. Sunita Verma and Dr. Prema Agarwal. Okay, so now we move on to our next panel discussion. As healthcare systems increasingly adopt AI, the conversation is no longer just about innovation, but about readiness. Without interoperable digital systems, structured EMRs, and integrated workflows, the full potential of AI cannot be realized. In this session titled, Are Indian Health Systems Ready for AI? Interoperability, EMR, smart hospitals and automation, we are truly going to explore are hospitals AI ready? This panel discussion will have distinguished luminaries from healthcare system. To chair this session, may I invite Dr. Sunil K. Khetarpal on the stage, please. He is the Deputy Director General of the Association of Healthcare Providers India and a senior healthcare administrator with over 38 years of experience in hospital administration, healthcare quality, accreditation, and digital health. Everyone, can we please give him a round of applause? I would also like to call once again on stage the moderator of the session, Dr. Sanjeev Bagai. Professor Dr. Sanjeev Bagai is a Padma Shri and Dr. B.C. Roy National Award recipient and is a known pediatrician, a pediatric nephrologist with over 35 years of experience in healthcare. I would also take an opportunity to invite distinguished panelists on the stage. I would take an opportunity to invite Dr. Gurpreet Singh. He is Executive Vice President Operations at Max Healthcare, one of India's leading hospital networks. He oversees operational strategy, clinical efficiency, and patient care delivery across multiple facilities. With a strong background in healthcare management, he has played a key role in optimizing hospital workflows, improving quality metrics, and scaling healthcare services while maintaining patient-centric care standards. I would also take an opportunity to invite on stage Mr. Bishnu Panigrihi. Dr. Bishnu Panigrihi is a senior healthcare leader and trained cardiac and neuroanesthetist with over 40 years of experience in clinical practice and hospital administration. He played a key role in establishing anesthesia departments at leading institutions including Indraprastha Apollo Hospital, Max Hospital Saket, and Fortis Hospital Mohali. Currently with Fortis Healthcare, he leads medical operations and strategic healthcare initiatives focused on clinical governance and outcome. Everyone, can we please give them a huge round of applause? So let's begin with this panel discussion.
So it's good afternoon now. So unfortunately, one of our panelists has someone in the family unwell, was unable to join, but we'll make this as informative as possible. So I'll begin with Dr. Khetarpal. What is your take when you talk in terms of AI in a digital platform? Very often people consider digital platform as just being electronic medical records or partial medical records. And there are many verticals in it. So can you throw some light for the audience? Over to you.
Thank you, Dr. Bagai, for asking this question. First of all, I would like to thank the organizers, Medical Dialogue, Dr. Prem Agarwal and Meghna, for inviting me for this very important session where we are going to talk about the readiness of our country as far as AI is concerned. So I think your question is that, about the AI, the digital platform. See, let me tell you, AI actually, when we say AI digital platform, it sounds very simple. It sounds very simple, but it is very complex. When we are talking of the digital platform, because AI tools are enablers, and we are not, say that if we talk of the AI tools, it is the human which controls AI tools. And AI is not the only solution, as we are now also going to talk about the AI co-pilots. where it is human which commands, which controls, right? So over the last decade, we have seen remarkable progress in our country for the digital transformation which has happened. And we have seen increasing adoption of EMR and growth of smart diagnostics, command centers, telemedicine, digital public health infrastructure, that is Ayushman Bharat digital mission, and there is greater willingness among the hospitals to adopt this technology. But however, if we talk of the readiness, we are still, it is very uneven, and we are partially ready, I should say. Yeah.
Thank you. Dr. Gurpreet, being in large corporate hospitals of large scale, how do you integrate AI in different centers under the same platform of a flagship corporate chain? And how do you inculcate an organizational culture to inculcate AI into your day-to-day operation?
So first of all, good afternoon, everybody.
So just to give, just in Delhi NCR, how many hospital setups would you have?
So Max has about 16 hospitals.
16. So just give an overview as a macro view as to how this kind of technology helps you manage these 16 in terms of operations.
So good afternoon. First of all, thank you for having me here. As you had kind of put in across, how does technology kind of helps it, right? So as it is, intelligence is very low these days, and you top up with artificial intelligence, it compounds effect, right? So most importantly, for a large chain like any chain like Mac, Fortis, or whatever you have, the most important part of artificial intelligence integration into hospital system is if you have the workflows which are flowing pretty much decently, which means the data entered into these workflows, which are your various working pathways, clinical pathways, is put into the system very accurately. Only then will artificial intelligence top up on that layer and help you out. So when you have multiple hospitals, the basic problem is of interoperability, right? Interoperability comes into play only when all the hospitals are pretty much connected with each other. And it's not just a connection. The connection has to be at par. You cannot have one hospital or two hospitals, big hospitals, where the culture has been set in, technology is available, you have kind of chipped in everything, data is being regularized, whereas the other hospitals lag behind. If that lag is there, then you cannot bring about the benefits of artificial intelligence and the scale, the care, the outcomes that we expect it to drive. So most importantly, all these hospitals first have a uniform workflow. Once you have uniform workflow, the data entry of this into these workflow is pretty much regulated. So for this regulation, you need some accountability at the top, because what happens is most of these fail if you don't have an accountable system in the hierarchy or per se across. So once you have that accountability, everything's scaled in. Now, once you have scaled in and you have this interoperability, data is fine, governance is good, that is when you start reaping the benefits. And those benefits translate into patient outcomes. It helps in better diagnosis. That is from a clinical side. Other side, you have command centers which optimize your workflow in the outpatient, in the inpatient, helps you on the OR workflows, and all this radiates into financial outcomes. So that's the ROI which you practically
So say if a patient is in South Delhi, visits a hospital of yours in West Delhi, North Delhi, East Delhi, and doesn't carry the reports, with your UHID or with a patient identification number or a patient's name, would all the data of the patient, including the imaging films and the reports, be accessible in another hospital in another part of the city?
Absolutely. So we have a unique UHID. You go to Saket or you go to a Patparganj, you give it your unique ID, the unique ID fetches the data, and you get all the data available to you, your last consults, your visit, your limbs, the x-rays and everything, they start coming in. We have kind of layered it on a Max app, which is for the clinician as well as for the patient, and the patient himself can just have every access of his or her reports, his discharge summary, his outpatient values, inpatient values available on the go on the app for any hospital to go in. And if he is admitted, the system flows in and you can see the data there.
Excellent. Doc, over to you now. Vishnu has been doing a lot of good work in large corporate hospitals. According to you, in terms of operations and clinical teams, where do you see the biggest misconceptions? Where do you see the biggest misconceptions within the medical fraternity towards adapting to this or accepting this? And where do you see the misconceptions amongst public at large with regards AI or a digital platform?
Good afternoon, everyone. And first of all, thank you to the Medical Dialogues for inviting us here. And Sanjeev, I knew you for so long. What I'd like to say is that AI is a buzzword, not only in India, globally. But Indian healthcare has a lot of data. It's not that we don't have data, but it is poor quality data, fragmented data, and non-interoperable data, which he was mentioning about. So I think that this is the basic thing that needs to come in. And to get it going forward, the clinical workflows have to seam into this, number one. And people have to start using the standard format, whether it is the coding that ICD coding that happens, SNOMED CT that happens. And two important things which has not been discussed actually in the earlier sessions also is the HL7, which is the health level 7, and your fast healthcare interoperability resources. This what happens, it's sort of on a platform, it helps pick up data and sort of helps the provider to analyze and move ahead. Otherwise, when you have data from multiple systems, this becomes the issue. And now, a lot of hospitals are rolling out EMRs, left middle records, or EHR, what do you call it. But the formatting has to be standardized. So if what I mentioned was the SNOMED CT, the FHIR, HL7, if these things are integrated, then what happens, all the data that flows in has to come in, and it has to be real-time data, not PDF data then plugged in and then. So once this comes in, this will help. It is built on the AI doesn't fall from heaven. It is the data sets which pile up, and from that it starts capturing the trends and gives you an idea.
So I have two questions for you. So you are using the same software as a platform across all your centers?
Yes.
Okay. Are you using a separate software to be integrated for the online platform, for let's say for e-consultations or video consultations?
Yes.
So you're still relying on the
So what we have done, because if we step by step we are moving ahead. So like whether it's the cath lab data, PACS is there, your investigations are online. So all these are integrated into the EMR now. And then to make it more comfortable for the clinicians, an MD online has been created. So on a mobile app, everything goes right from there. They can do the discharge summary, look at the discharge summaries, they can look at all the reports, even your investigations right from a CT scan, MRIs, that comes in here. So that helps the clinicians to work. So how do you also, you have to make the AI functional and to make the entire IT ecosystem functional, you have to get the buy-in of the clinician. So the most important thing is that while they are seeing the patients, treating the patients, we have to see that it falls into their workflow instead of becoming an impediment in their workflow.
Okay, so is everyone familiar with what MIS stands for? Is everyone familiar? Management Information System. So right at the palm of your either a laptop or an iPad or your cell phone, you get every bit of real-time data across all verticals of a hospital. And I'm beginning with you and then going this way. How does that help you in terms of minute-to-minute decision-making, be it seeing the flow of patients in the OPD, or indeed utilization of hospital beds or turnaround time in the OTs, or indeed hemodialysis machines, casualty waiting room, or in terms of lab data, things like that. How useful is MIS for hospital operator?
We call it HIS, Hospital Information System. In fact, it's very nice to share this thing because Fortis started off in one.
So I'll ask the same thing. So I'll get across the board.
See, because I'm saying, for example,
views,
the learning that we had one hospital in Mohali, then second came in Noida, then there were a lot of acquisitions. So there were multiple HIS systems. The first thing that happened 5-6 years back, we got a standardized one HIS. You are answering a question. Now that is standardized across the 36 hospitals.
Which platform do you use in terms of your software?
I don't know the name, but it's there. It's a single, and it is all cloud-based. So that's another advantage. It's important. When it's cloud-based, you don't get into any disruption. And any across the network, the data is entered, anyone can pick it up. As you asked me to pick also, if someone goes from Saket and goes to Palpadgan, they can pick up it. Similarly with us. So all the admissions, once you enter, whether you're admitting in a Gurugram hospital or a Mohali hospital, it comes in the system. So it's easy to do it. And then every hospital, what's the bed strength, the occupancies are existing there, everything is available in the system. So you can predict that these are the vacancies there. So if anyone is asking for an appointment for admission, you can say that it's there, or if it's not there, you can say that please come tomorrow or after a few hours. So these things help the patient experience.
Would be MIS in day-to-day, minute-to-minute operations, and what kind of course correction you can take if you have data ASAP with you?
So let me run a scenario.
Yeah.
So patient comes into the emergency with pain abdomen, gets a registration number. The moment he gets a registration number, he gets logged into the hospital system. There is a command center at the back end which is working for various aspects, and it's an integrated command system. So there's an ER workflow which gets activated. The patient is started seeing in the ER workflow as his name, UHID, and phone number, everything. And it shows in the, it's admitted under the emergency physician. And it shows the first order which has been issued by the emergency physician, right? So it gives you the time frame. After the time frame, there's some investigations which are said, which are fed in the system by the ER physician. The investigation goes, and after the investigation report or in between, with the acumen of the physician, he diagnoses that it has to be admitted under, let's pick up gastroenterology, right? If the patient gets fixed up on the on-call gastroenterologist, he clicks the button, the name of the gastroenterologist chips in. The time window is continuously moving, right? For how long the patient has been in the system. That command center is visible to two people, the ER physician as well as the operations head. So it gives you the lag time of the person if he skips over in the ER. After 45 minutes, it starts changing the color to red, right? So that the patient is waiting in the ER for some time. We have a bed available. With the bed HIS, the patient is allotted a particular bed. So you have a floor, the patient's request, whether a single, double or economy is chipped in. The automated system gives a flashback that this is the beds available. You admit the patient. Click of a button, the patient is admitted into the system at that floor. The moment it is clicked in, it is visible to the nurse on the floor that there is an admission which is happening. Now, if it is an insurance patient, the revenue cycle chips in, right? The card of the patient is taken. We have our own TPA algorithms wherein once the history of the patient in the ER is fed, it will give you an estimate online, and it will give you by the pair, which means by which insurance company the person belongs to. This would be his estimate, which will be covered by the insurance, and this would be the co-payment. We have reached that stage. Now, after this is given, the signature happens, the patient is transferred to the floor. Now, once he's on the floor, the nurse picks up, the doctor comes in on his iPads in the CPRS, which is our system at the back end, puts in his notes and enters the medication as well as investigations. As he puts in the medications, they don't go anywhere. They go straight to the pharmacy. The pharmacy checks out the medicines, whether they are for stat or they are a routine medication. As per the TATs defined, they start picking up the pharmacy samples and sending them on the floor. The nurse, in the meantime, picks up those samples and puts a barcode entrance on top of it and clicks on the button, they are visible to the lab. Once they are received in the lab clicks, the automated system gets activated, the nurse sees they have been received. In the meantime, the medicines come in. The patient has a barcode. The nurse scans a barcode. The barcode is visible on the screen that this is the right patient, this is the right dose, which at the back end, when the doctor has prescribed, has been checked by the clinical pharmacist online and has approved the order. That is when the medicine is dispensed. And in the meantime, the sample reports, as they start coming in, they are visible on the screen to the nurse, they are visible to the patient on the app, they are visible to the doctor on his app or on his iPad, that this is where the reports have started coming in. That's one part of it. This way, seamlessly, radiology, discharge, everything happens on this seamless process. That's how it is.
So did everyone get a flavor of what he was saying? The leading cause of death even in US a decade back was human error. Either in terms of miscalculation of dose or misrepresentation of symptoms, operating on the wrong side, wrong part, wrong organ. With the digital technology, the right medication, the human error has come down to less than 1%. This is documented, published data. The second more important thing is, a lot of us are exposed to seeing patients in critical needs in ICUs. At any given point in time, an average micro drip which is going on in one single patient is more than 4, especially in life-saving situations. If you don't have a digital technology to help you calculate it when you are actually seeing the patient, you waste a lot of precious time in micrograms per kilogram per hour or minutes or drops per minute. This actually helps you to reduce the error, give the correct dose to the correct patient in the correct formulation. I'll ask the same question to Doc here. How does this kind of technology help you in real time?
Thank you, Dr. Bagay. See, the real-time dashboard, I'll give you a very short, crisp and specific answer. It will improve the operational efficiency. There is real-time monitoring of the dashboard. The doctor can view the patient reports, the medical condition of the patient, all the parameters. Doctors can have the access, and accordingly, doctor will take prompt action. So once the operational efficiency is improved, workflow will be improved, and there will be early the detection of any alarming or any signal. It will give you the signal of any alarming reports or alarming condition, and there will be prompt action by the doctor. Ultimately, what matters in healthcare is the outcome. So with the real-time dashboard, there is improved monitoring, there is efficiency will be increased, and ultimately improving the outcome of the patient and reducing the morbidity and mortality.
This is rapid fire. I'll ask the same question from all three so that it keeps it interesting. What are the 1 or 2 red flag signs which you would like to be highlighted to you as an administrator through a digital app or through your hospital MIS system or AI platform which gives you better clinical outcomes? So Gurpreet just mentioned waiting time, right? Now when you know in a critical emergency, if a patient, especially a cardiac, is waiting for more than an hour or 2, you've lost that very precious window. Or in a internal bleeding, you lose a lot of precious time. So what are the 1 or 2 things which you would like to catch on ASAP, minute to minute, hour to hour, when you're in the hospital or indeed at home?
See, most important is the bed optimization. When the patient comes to the ER, how quickly you can provide a bed, how quickly you can get the investigations done. So because
you're saying quick response.
Quick response.
Gurpreet?
I would say a private hospital, 2 things matter. One is revenue, and that is the patient cost. So revenue cycle optimization, and as Sir put it, bed management optimization.
I'll say reduction in medication errors. Reduction in medication errors and improved turnaround time.
So the greatest issue which we face is discharge of a patient. And the greatest difficulty patients face is discharge. and the maximum number of asses being kicked in administration is for the discharge of the patient. How is this technology, beginning with you, going to help us linking hospital as a platform, PPAs and the insurance, especially if you are having a planned discharge the next day, so that the patient is not told of a discharge at 8 o'clock at night today, but the patient doesn't go home the next day till 8 o'clock purely because the delay in TPA or in hospital billing or clearance from an insurance, or a query comes and then it is going to and fro.
The most important is the process that needs to be followed. So you, as they say, the discharge starts at the time of admission.
Excellent.
So,
Excellent.
so you know, suppose tomorrow morning, some patients are likely to be discharged. So in the by having your cutoff time, whether it's 4 o'clock, 5 o'clock, 6 o'clock, so by that time the discharge summary should be ready. Because if that is done, then what happens at the night? There's a lot of back-end things happen which people don't know.
Just pause. So the delay is on two parts. Delay is a part of the hospital because a lot of hospitals who are not following a digital format start filling up. First of all, they start finding a senior resident somewhere or a data entry operator. And then the process of filling in the data begins post-lunch, whereas the poor guy is waiting for a discharge at 8 o'clock in the morning. And then it goes to the TPA, then the queries come, then the insurance says part claim, and therefore the anger. So if the data is filled in at the time, what Doc mentioned, at the time of admission, 80-90% of your paperwork is already on a digital platform, so you really don't waste time.
So just coming to one point.
Yeah, please go ahead.
Because I think that tomorrow morning's discharge, if the discharge is entered, it's fine. If it's not entered, then someone from the medical admin immediately calls the treating consultant, sir, your patient's discharged. Because now, irrespective of whether in the hospital or outside, it's on your tablet, on your phone, you can check it and they can make the course corrections there. So they guide and see that this is done quickly.
Repeat yours quickly.
Yeah, so quick, I'll take 1 minute quick. So first I'll throw in some numbers, right? So before we kind of worked around on this, and this is, as you said, a perpetual problem, we had a cash discharge timing of 240 minutes and TPA insurance discharges of over 440 minutes. Today with automation and everything, our cash discharges happen at 135 minutes average, and insurance discharges come down to 310 minutes.
Excellent.
That's a huge movement. Now the movement happens, as sir pointed out, it's on a previous day. What we've taken from is, we've taken ALOS, right? We have a calculated ALOS average. So after the ALOS of a patient happens, there is a pop-up which comes up that this patient's ALOS is completed. And the system starts generating, working towards the discharge. The billings are updated every day. So at the end of the day, last day of the discharge, the billings are not to be updated. It takes 7 minutes precisely for us to update the bill on the day of the discharge. Now what we've changed here is that our EMR, the CPRS which is there, has a button. You press it, it will give you an automated summary. The resident then has to do is just filter it out and put in the important things, send it to the clinician, the person whom it is admitted under, and there's a digital sign. So we cut out on the summary key. And then the insurance kicks in. We have an HIS system where we have already on admission, we know how much the co-payment is to happen, and we quickly run the summaries across it.
30 seconds.
Yeah, question. Sure. I'll be very short. See, discharge is a gray area. It is a universal problem. So many steps are involved. So many people are involved. And ultimately, it has to be signed by the treating doctor, who is sometime busy in OT. So discharge, that is different for the cash patient and different for the PPA patients. But with the technology, as he mentioned, and Dr. Vishnu very rightly mentioned, discharge process starts at the time of admission. We can improve the workflow. The discharge process can be expedited. And also the discharge delay is not always because from the hospital side. It can be from the patient side also sometimes. Patient don't want to leave. He wants to have the lunch and go. And if the patient is informed at the time of discharge, when the doctor is visiting the patient and informing him that you are going to be discharged, if he is informed that it will take 3 to 4 hours, patient is fine. Otherwise, a lot of issues, patient dissatisfaction.
Okay, one last question, yes, no. Yes, no question. Everyone has heard of Lancet. Everyone has heard of New England Journal of Medicine. Everyone has heard of JAMA, everyone has heard of various international journals we all read online or a physical copy. And you would have often wondered why Indian doctors, researchers, scientists don't figure that often as in the Western countries. And the real answer rises in data. Data is the new gold. 5 seconds, then we'll have lunch. With this technology, we have a load of data and assimilated data, cultured data, filtered data. Have you seen more interest, especially amongst people who are junior consultants, associate consultants, who are now more interested in publishing papers? Because that's the key for doctors. Research, publication, and being in active academics is the core.
Yes, in fact, because of the structured manner of capturing the data, now we are finding a huge resurgence. I'm talking about the young students, the DMV students that we have. They are now started publishing, which was not there earlier because everything was in paper format. It's very difficult. So now with the structured data coming in, and we have a separate research vertical in, and with biostatistician who help them to structure the data.
You all also have an academic section to help in research or in publications or in writing papers?
Yes, so we have Max Institute of Medical Education which
Excellent.
does this for us. But most importantly, we have created a data lake in which we have kind of digitized the data for the last 10 years in a digital format. So it becomes very easy for physicians as well as the, as you said, attending consultants, DNBs, to just put in what they need. A 55-year-old female with diabetes with chronic kidney disease, and you will have an upload of data for all the patients that are admitted with us for the last 10 years.
Excellent.
So that really helps.
Doc, same question.
I think I would echo what Gurpreet has said. Digitization of the data is the only answer. If you want to, place your article in any of the renowned journals like Lancet and what you mentioned. So I think digitization of data, if you have, you can responsibly use the data, and it is not that if you want to publish an article, you can just go haywire and you don't have you have fragmented data. So I think it is the organized, structured, and responsible data.
Just say something.
Thank you.
In fact, now I'm an administrator, but just before that, Max, I was a clinician there also. Plus,
do Max and Fortis talk to each other?
Yeah, 187.
Before lunch or after lunch?
187 octogenarians were operated on cardiac surgery patients. 187. And this was, we captured this data because we are capturing it at the beginning. All each patient that were operated, we captured the data, and 187, the data was presented in EACTA at Edinburgh, European Association of Cardiothoracic Acid. It was humongous data. And because of keeping it in a structured format, we have to put up SPSS thing. We could know who's the diabetic, who's having renal dysfunction, after surgery, what will happen. So I think what the message I want to give is that if you keep structured data from the beginning, it becomes very easy for publications. I think that is something that India was lacking. And as I see, like where China is now the leader in publications because of having a structured data.
Excellent. Thank you, everyone. Thank you, the panelists. Wonderful discussion. Thank you.
Everyone, can we please give them a huge round of applause? Thank you so much for the important discussion. The conversations today clearly reinforce that AI readiness is not merely about technology adoption, it's about systems, standards, governance, and leadership. So now I request Dr. Kamalkant Kohli to please come up on the stage and felicitate our honorable speakers. I request all of you, sir, I request all of you to please come forward. Thank you so much, our chairperson, moderator, and our esteemed panelists. Thank you so much. Thank you once again. Let's have a group photograph. Thank you so much. And now I request all of you to please kindly move to Hall B because we have National Medical Commission address there. So I request everyone to please move to Hall B. Followed by lunch, and we request all of you to be here back at 1:55 because we're going to start the afternoon sessions at 2 p.m. exactly. Hello, mic check on. Good afternoon, everyone, and welcome back. We hope you had a pleasant lunch and networking break. We now resume with the second half of the Medical Dialogue Presents Health AI Con 2026 Summit and Phoenix Award for Health Innovation. We now have the privilege of hearing a special lecture that takes us into one of the most important and often underexplored aspects of AI in healthcare, the ethical dimension. It is my honor to show you a recorded lecture from AI in Ethics, Consent and Accountability in Medical Education and Research by Professor Russell D'Souza. Professor Russell Franco D'Souza is an internationally renowned psychiatrist, academician, and bioethics, currently serving as Dean and Professor of Organizational Psychological Medicine at the International Institute of Organization Psychological Medicine, with campuses across Australia, the United Kingdom, and the United States. He also serves as chair and head of the Asia Pacific Division of the UNESCO Chair in Bioethics at the University of Haifa, a position he has held since 2011. Okay, so let's keep the eyes on the screen, please. So ladies and gentlemen, we are moving forward to another exciting product case showcase session. We now invite Dr. Vidur Mahajan, CEO of Carpal.ai. Dr. Vidur Mahajan serves as the Chief Executive Officer of Carpal.ai, an enterprise imaging AI platform that brings 250 AI applications from 80 plus vendors into radiology workflows. So everyone, can we please give it up for him? Carpal.ai has emerged as a significant platform in AI-enabled radiology workflow integration and imaging innovation. So let's welcome Dr. Vidur Mahajan.
Thank you, ma'am. Thank you, everyone. Thank you, Dr. Kohli, Dr. Agarwal, Meghna, for having me here. Thoda sa, it's a little, different what we do. So, but हाँ, मतलब हम यहाँ दिल्ली की गलियों से all over the world AI बेच रहे हैं, and I'll try to tell you that story. It's sliding. No. यार मेरी slides ला दोगे? अच्छा, back भी नहीं जा रहा. But basically the problem that we are all trying to solve, I think collectively, is not a new one. Okay, there are not enough doctors for the patients that are out there, right? And radiology में अगर हम देखें तो the rate of growth of imaging is between 10 to 15% per year, right? And why that is the case is because people are living longer, older people need more imaging, diseases are being detected earlier, so again more imaging. Then subsequently people are, new diseases are being detected. COVID did not exist till many years ago. So the rate of growth of imaging is increasing. But the rate of growth of radiologists who are supposed to read each of those imaging scans is not increasing at the same pace. Right? So उसमें क्या हो रहा है कि आ गई शायद से. So उसमें क्या हो रहा है कि rate of imaging is growing at 10-15%. Number of radiologists is growing at 2 to 4%. So there is a perpetual mismatch, and that mismatch, appears in different ways. मतलब इंडिया में तो स्कैन होते ही नहीं है, आपको मिलेगा ही नहीं सर्विस. यूएस वगैरह में it is increased cost, हजारों डॉलर के स्कैन होते हैं. Is it okay if I do हिंदी इंग्लिश मिक्स? है ना, ठीक है. So basically या फिर मतलब it may appear as कि 2 हफ्ते लग रहे हैं स्कैन की रिपोर्ट आने में, 4 हफ्ते लग रहे हैं. इनफैक्ट यूके, मतलब we look up to their health system so much. यूके में मैमोग्राफी रिपोर्ट्स come in 300 days, right? कि अगले स्कैन के पहले आ जाती है मैमो की रिपोर्ट. That is the situation. So it's a very, very bad situation. But the problem is कि now AI का role in imaging is established beyond doubt. Right, what you are seeing here on the left, this is a list of basically all the FDA approved AI out there. Right, तो 1000 से भी ज़्यादा है. And ये सारे AI कर क्या रहे हैं? They are improving clinical outcomes. भाई error reduce हो रहे हैं, quality audits हो रहे हैं, बड़ा कुछ हो रहा है, faster time to delivery हो रहा है, better operational outcomes हो रहे हैं, faster report turnaround time, door to needle times. आपको बहुत सारी चीज़ें सुनने को मिलेंगी अगर आप देखोगे ना यूट्यूब पे या फिर नेट वगैरह पे पढ़ोगे. या फिर बेटर फाइनेंशियल आउटकम्स, मतलब एआई लगा लो, रेडियोलॉजिस्ट प्रोडक्टिविटी बढ़ जाएगी, फॉलो अप रेवेन्यू आएगा आपको, आप और केसेस डायग्नोस करोगे, बड़ा कुछ होगा. सो इतना सारा एक एक्टिव इकोसिस्टम है, हजारों कंपनियां हैं, हजारों प्रोडक्ट हैं, पर रियल वर्ल्ड अडॉप्शन इज नियर जीरो. राइट, अगर इफ यू गो टू एनी हॉस्पिटल एनीवेयर इन द वर्ल्ड एंड यू आस्क देम जी इस 1000 में से आप कितना एआई यूज कर रहे हो, राइट, आंसर इज टिपिकली 1, 2, 3, 4 और 0. राइट, इट्स नॉट कि भाई हम 15 यूज कर रहे हैं. तो ये क्यों होता है? भाई ये इसलिए होता है क्योंकि हम सारे हैं हेल्थ केयर प्रोवाइडर्स. अब हमारा काम दुनिया में जा के सॉफ्टवेयर ढूंढना तो नहीं है. सॉफ्टवेयर मतलब अगेन 1000 कंपनियां हैं जो 1000 अलग चीजें कर रही हैं. हाउ डू यू इवन फाइंड देम? Right? Do you go to conferences? Do you read research papers? Do you come here? मतलब it's just too much to consume, right? And all of these solutions are very niche. जैसे अभी मैं बात कर रहा था, एक फ्रैक्चर डिटेक्शन का अलग ही सोल्यूशन है, फिर हेड सीटी का अलग सोल्यूशन है, चेस्ट एक्सरे का अलग सोल्यूशन है, बॉडी पार्ट मोडालिटी पैथोलॉजी, इस ट्रायड से एक सोल्यूशन बन रहा है. सो इट्स जस्ट टू मच फॉर हेल्थ केयर प्रोवाइडर्स टू हैंडल. देन AI खरीदोगे, उसका इंटरव्यू तो लोगे ना, आप देखोगे ना काम भी करता है या नहीं करता, वैलिडेट करोगे। आपको आके कोई बोल देगा जी 99.9% सेंसिटिविटी स्पेसिफिसिटी है, कुछ है, यू कैन नॉट जस्ट बिलीव इट, बिकॉज AI मे बी इट इज ट्रेन्ड इन कोरिया। अब कोरिया का AI सैमसंग की मशीनों पे चला होगा, हमारे पास पता नहीं फिलिप्स की मशीन है, अब वो चलेगा नहीं चलेगा, उसके लिए यू हैव टू डू वैलिडेशन स्टडीज। नाउ इमेजिन डूइंग 15 वैलिडेशन स्टडीज, वन फॉर हेड, वन फॉर चेस्ट, वन फॉर प्रोस्टेट, वन फॉर नी, वन फॉर हैंड, मतलब बहुत ही मुश्किल है, राइट। एंड द थर्ड प्रॉब्लम इज द आईटी प्रॉब्लम, कि मतलब इतना मुश्किल है इन सारे एआई सिस्टम्स को इंटीग्रेट करना आपके लाइव आईटी एनवायरनमेंट में। दे ऑल हैव डिफरेंट वेज दे टेक इन इमेजेस, टेक गिव आउट आंसर्स, दे ऑल हैव डिफरेंट वेज इन विच दे शो देयर रिजल्ट्स। कोई कहता है जी इंटरनेट पे जाओ, कोई कहता है हम ईमेल भेजेंगे, कोई कहता है हम एसएमएस भेजेंगे, कोई कुछ। इट्स अ वेरी ब्रोकन सिस्टम। सो इसकी वजह से होता क्या है, मतलब अच्छा हाँ, एंड ऑफ कोर्स नोबडी इज टॉकिंग अबाउट एआई सेफ्टी, राइट, कि भाई ये एआई डालने से एम आई एक्चुअली मेकिंग थिंग्स वर्स। सो उससे क्या होता है, वी कॉल इट अ कॉम्बिनेटोरियल एक्सप्लोजन। सो व्हाट दिस मीन्स इज दैट एवरी टाइम आप एक एआई लगाने की कोशिश कर रहे हो ना, आपके लिए और मुश्किल हो रहा है उससे वैल्यू निकालना, क्योंकि आपकी मेहनत बढ़ रही है हर एआई डालने। ऑब्वियसली इसका सोल्यूशन हम बना रहे हैं इतनी बड़ी प्रॉब्लम का, कि what we have created is a central hub. So central hub for radiology AI, what does that mean? Well, we have gone out there and partnered with almost 90 different companies, जिन्होंने मिलके हमें 250 different applications दी हैं। एक बार ये zoom हो जाए, हाँ, जिन्होंने मिलके हमें 250 different applications दी हैं। ये सारा एक लोगो जो है छोटा छोटा, these are all companies जो अलग अलग प्रोडक्ट्स बना रहे हैं, कोई ब्रेन एमआरआई, कोई चेस्ट एक्सरे, कोई चेस्ट सीटी, कोई मैमो, कोई कार्डियक, ऐसे करके अगेन बॉडी पार्ट मोडालिटी के कॉम्बिनेशन पे। दीज आर ऑल कंपनीज दैट आर मेकिंग दीज टूल्स। वी हैव गॉन आउट देयर एंड पार्टनर्ड विद दीज टूल्स, राइट, लाइक ऑलमोस्ट लाइक थिंक ऑफ इट एज अ Amazon फॉर रेडियोलॉजी एआई। उसके बाद वी गिव आवर यूजर्स द एबिलिटी टू टेस्ट ऑल ऑफ दीज सोल्यूशंस। आप लो यार इंटरव्यू, आप डालो अपने 500,000 स्कैन इसमें, खुद देखो कि काम भी करता है नहीं करता, क्योंकि 5 अलग कंपनियां हैं, पांचों कहती हैं कि हम बेस्ट हैं। आपको कैसे पता? लाइक यू नो, जस्ट बिकॉज यू हैव गॉन टू आई डोंट नो एम्स डज नॉट मीन यू विल नॉट गेट इंटरव्यूड फॉर अ जॉब। सो सिमिलर सेम थिंग अप्लाइज, बिकॉज इंटरव्यूज आर मोर अबाउट फिगरिंग आउट योर कंस्ट्रेंट्स, फिगरिंग आउट व्हाट यू मे बी आर नॉट गुड एट, एंड देन you know doubling down on the others. So we give that entire platform कि आप benchmark कर लो AI को, आप उसको validate कर लो, बाद में monitor कर लो deployment के बाद, and once you have done the test, then we do the deployment of the AI where we become almost a single user interface. तो आपको अलग अलग browser windows ये वो में जाने की जरूरत नहीं है, आपको अलग अलग IT integrations करने की जरूरत नहीं है, आप एक सिंगल प्रोक्योरमेंट कॉन्ट्रैक्ट पे सब करते हो। अगेन जोमेटो समझ लो, मतलब जोमेटो ने कितना इजी बना दिया ना हमारे जैसे आलसी लोगों के लिए, बट बटन दबाओ खाना आ जाता है, आपको फर्क नहीं पड़ता। वो यू नो आप निरूला से आइसक्रीम मंगवा लो, यम चा से मोमो मंगा लो, और कहीं से कुछ मंगा लो, यू डोंट हैव टू एक्चुअली गो टू ऑल 3 प्लेसेस। सो दैट्स द पोस्ट लंच रेफरेंस। सो वी आर not selling AI, right? Carpal.ai is not a seller of AI, we are an enabler of AI. मतलब हम जाके अपने कस्टमर्स को ये नहीं कहते कि हमसे AI खरीदो, हम जाके कस्टमर्स को ये कहते हैं अगर आपको AI यूज करने की प्रॉब्लम है, आप हमारे को यूज करके AI खरीदो और यूज करो। एंड लकीली ओवर लास्ट 4.5 years पहले वी वर incubated at Mahajan Imaging, and you know then we became a separate company in 2021, and since then now we are like these are our paying customers, which are some of the world's top institutions. So MD Anderson in US, RadNet is world's largest radiology group, फिर बड़े सारे और हैं, ब्राज़ील के largest groups, again these are मतलब ये करोड़ मरीज करते हैं हर साल, ये इस लेवल के प्रोवाइडर्स हैं। मेडिका इन यूके, यूनिलैब्स, अबू धाबी गवर्नमेंट, M42, बिलीव इट और नॉट ड्यूरिंग द पूरा यू नो वॉर इनकी टीबी की स्क्रीनिंग नहीं रुकी, तो हमें तो बड़ा अजीब लग रहा है। देन साइनैप्स इज सिंगापुर गवर्नमेंट, ऑस्ट्रेलिया, सो ऑल ओवर द वर्ल्ड, एंड देन वी हैव पार्टनर्ड विद सम ऑफ द वर्ल्ड्स टॉप PACS companies. So PACS is the workstation जो radiologist जिस पे लगे रहते हैं और अपनी images देखते हैं. So Agfa, Deep Health, Fuji, Intelerad, these are all the world's top PACS companies that we have partnered with. So we are basically building in India for the world. हम अपनी यहाँ की knowledge, insight, medicine and engineering का ना एक बड़ा interesting मेल मिलता है इंडिया में. मतलब we have the world's best doctors, we have the world's best engineers. तो हम ढूंढने की कोशिश करते हैं उन्हें एंड ये सब करने की कोशिश करते हैं. मतलब हार्वर्ड हमारा सॉफ्टवेयर यूज़ कर रहा है, कोलंबिया हमारा सॉफ्टवेयर यूज़ कर रहा है, येल हमारा सॉफ्टवेयर यूज़ कर रहा है. So moving on, these are just some case studies. This is RadNet. RadNet again, like I said, world's largest radiology group. 10,000 MSK X-rays per day are being processed here. इन्होंने जो वैलिडेशन स्टडी करी, बिलीव इट और नॉट, 1 लाख एक्सरे 10 AI से चला के इन्होंने चूज़ किया कि इनको किसके साथ काम करना है, राइट. फिर नेक्स्ट इज MD Anderson. ऑफ कोर्स MD Anderson यूज केस इज वेरी इंटरेस्टिंग. सो MD Anderson already has 6-7 different AI that they are running. They are using us to consolidate all of those and to say कि यार हमें ये जानना है कि इस AI की परफॉर्मेंस क्या थी, पिछले हफ्ते क्या थी, पिछले साल क्या थी, काम भी कर रहा है कि नहीं कर रहा. क्योंकि एक बार आपने खरीद लिया उसके बाद बेचने वाला तो गायब, तो आपको खुद ही फिर एस्टैब्लिश करना पड़ता है. देन Vesta Teleradiology, again one of the largest teleradiology companies in US. यहाँ पे stroke patients are being automatically run by AI and are being reported first, fracture AI, etc. Singapore government, कोई भी मरीज सिंगापुर में जो होता है उस पर अगर AI चल रहा है तो वो हमारे थ्रू चल रहा है. Whether it's mammo, whether it's chest X-ray, fracture detection, इन्होंने भी 1 लाख मैमो चलाए डिसाइड करने के लिए कि सिंगापुर में कौन सा मैमो AI यूज होगा फॉर देयर पर्पसेस. So Latin America, largest hospital in Latin America, Albert Einstein Hospital, वहाँ पे भी हम हैं. And then this is what I am actually most proud of. This is, thank you ma'am. This is basically every day around 3,000 Indian citizens, patient भी नहीं है, citizens are being screened using portable X-ray and AI. मतलब अगर आप इसको देखें तो इस इमेज में this is the X-ray tube, X-ray source. It's like a DSLR camera. In person के पीछे ये X-ray की wireless, everything is wireless, cassette है, और यहाँ इस आदमी के पीछे एक लैपटॉप है. So the X-ray is taken, laptop पे it goes, and then on the laptop our software sits. We don't build any AI, right? We are a marketplace. We are Zomato, we are Amazon. So हम Cure AI का AI चलाते हैं, Deep Tech का AI चलाते हैं, 2 leading Indian AI companies, उसी लैपटॉप पे, and within 15 seconds this technician gets to know TB suspected or not. If yes, तो swab ले लो या sputum sample ले लो, swab ही निकलता है मुझे. So very amazing thing. India is actually the leader in public health screening with AI. Again, it's the TB initiative. ICMR itself has driven a lot of this. So I thought, I must share this. कि almost 15 लाख लोगों को हम screen कर चुके हैं अभी तक last 2 years में, and the number is only increasing. So in summary, there are certain high ROI use cases: stroke, pulmonary embolism, aortic dissection, acute abdomen, cervical spine fractures, chest fracture, MSK fracture, pneumothorax, pleural effusion. In the ER, ये सारे ER use cases हैं. फिर screening use cases हैं: mammo, lung cancer, thyroid cancer, breast cancer. Opportunistic screening है. This is coronary artery calcification on non-contrast CT. तो opportunistic screening is a very interesting thing. I'll spend 15 seconds on it. आप गए तो स्कैन निमोनिया का कराने थे, पर इनसाइट आपकी कार्डियक हेल्थ पे मिल गई, राइट? आप गए तो सीटी स्कैन लंग्स के लिए थे, आपको कोरोनरी आर्टरी कैल्शियम की भी इनसाइट मिल गई. आप गए तो स्कैन एब्डोमेन पेन के लिए थे, आपको इंसिडेंटल पल्मोनरी एम्बोलिज्म मिल गया. सो लाइक दिस देयर आर मैमोग्राफी पे कार्डियक रिस्क, इमेजिन, राइट? सो दीज आर द थिंग्स दैट एआई कैन डू, एंड देन ऑफ कोर्स देयर आर मेनी अदर एप्लीकेशंस. हमारा क्या काम है? वी हैव स्टार्टेड विद रेडियोलॉजी, हम बड़ा कुछ बना रहे हैं रेडियोलॉजी में, बट देन वी वांट टू गो इनटू अदर डायग्नोस्टिक्स एज वेल. जैसे धीरे धीरे और इमेजिंग और एआई आ रहा है, डेंटल इमेजिंग, डिजिटल पैथोलॉजी एट्सेट्रा. उसके बाद जनरल मेडिसिन, पॉपुलेशन हेल्थ, जो भी सब धीरे धीरे आ रहा है. एंड फिर आगे जाके एक दिन इफ देयर इज अ रोबोट दैट इज रनिंग एआई एंड डूइंग सम सर्जरी, we would like to be the technology partner for that. So with that, I thank you for your attention and thank the organizers as well.
Thank you so much, Dr. Vidur Mahajan, and we please would like to felicitate. So for felicitation, we would request Dr. Kamalkant to be here on the stage. Everyone, can we please give him a round of applause? Thank you so much, sir. Thank you. So ladies and gentlemen, we are pleased to inform you that we have Dr. Ajay Swaroop Mathur, Chairman Board, Sir Gangaram Hospital, among us. We welcome you, sir. It's an honor to have you here. So, welcome. So as healthcare increasingly becomes data-driven, conversations around ethics, privacy, governance, and cybersecurity become absolutely essential. We now move on to our next session, titled Data Protection, Cybersecurity, and Ethical AI Policy. To discuss exactly that, to chair this important session, may I invite Mr. Prakash Atili to be here on the stage. So Dr. V.S. Prakash Atili is Associate Professor at IIM Lucknow with over 24 years of experience in technology, leadership, IT service delivery, and digital transformation. Everyone, can we please welcome him on stage? May I now invite the moderator for this session, Dr. Seema Singh. She is a journal surgeon and IIM Ahmedabad alumnus with over 20 years experience across clinical practice and healthcare innovation. She has spent last 10+ years working closely with several AI-driven healthcare organizations as co-founder, head of product, and strategic advisor. Everyone, let's welcome her on the stage, please. May I also invite our distinguished speakers on the stage, Dr. Saurav Basu. He's a senior scientist and public health expert, currently serving as Scientist E-Medical at the ICMR National Institute of Research in Digital Health, New Delhi. I would also like to call on stage Dr. Charu Malhotra. Professor Charu Malhotra is an expert in digital governance with over 35 years of experience. She had led India's advancements in e-governance, public policy formulation, and digital capacity building, driving global conversations around digital innovation for inclusion and for citizen-centric public policy formulations. I would also like to call on stage Dr. Rahul Amritraj. He serves as Chief Executive Officer, Center for Medical Innovation, GIMS Foundation, a Government of Uttar Pradesh Section 8 company established with Public Medical Institute to promote healthcare innovation and incubation. I would also like to call on stage Mr. Atul Tiwari. He is the founder and CEO of GoodMed, an emerging healthcare AI company started 5 years ago. Also, I would like to call on stage Mr. Arun Goyal, CIO, Sir Gangaram Hospital. Okay, so we don't have Mr. Arun Goyal with us, so we can definitely welcome you all. Everyone, can we please give them a round of applause? And we can begin this panel discussion.
Good afternoon, everyone. It is my pleasure. I just want to set the context for the discussion. And as AI rapidly transforms healthcare, especially in India, the promise of AI is real. AI is being deployed at all the places. At the same time, the risks around AI are also real. You can see that sensitive patient data that is cutting across all the ecosystems, first of all, that we call it as a data layer, and subsequently complex algorithms with limited transparency are there across the industry that we try to refer it as a model layer. And the most importantly, the knowledge layer is the validation that was done by the clinical, and this is called validation layer. So when the data transforms, it gets standardized to information, information to knowledge. All the three layers poses unique challenges at each and every layer. And adoption of anything, either technology or artificial intelligence, without a dialogue or proper education may not result in an innovation or a transformation. So this dialogue is predominantly not to just adopt AI, but predominantly to make best use of AI at a context and thereby looking towards a transformation journey. And what happens during this transformation journey is a flip. Today, some of the doctors might be having a thought that what happens if I make use of AI and the decision goes wrong, I may be penalized. The flip will happen in such a way, probably 10 years down the line, that if I didn't use AI and provided suboptimal service to a patient, will I be penalized? So this flip happens soon is what expected. So everyone should have a dialogue focusing on the transformation and innovation rather than just an adoption, because adoption already took place in the AI. So it is very important for us to discuss the critical areas like trust, governance, ethics, and data protection. Are they evolving enough for that context? So that we would like to have a dialogue on these particular things. And this session brings together the perspectives from multiple dimensions: technology dimension, clinical practice dimensions, and policy dimensions. And with that context setting, I would like to hand over to the moderator. Thank you very much.
Thanks, Dr. Prakash. Thanks a lot for setting that context. See, we all realize how important this discussion is today, and we are lucky to have some eminent panelists who span the breadth of healthcare, from regulatory to clinical to industry participants. Starting with Dr. Basu, since you work very closely with the regulatory aspect of it, in your opinion, from your experience, where do you see the largest gaps in the healthcare governance today in terms of ethics, accountability in the Indian ecosystem? So what are the largest gaps that you are seeing?
Millions of patients. Then we have the DPDP Act, the Digital Personal Data Protection Act from 2023, which again has very stringent norms in data protection. We have the strategy for AI in healthcare in India. So going forth, and the ICMR has already brought out ethical guidelines for AI use in healthcare. So if you look at it, I don't see the gap in policy. The gap is in implementation. And this implementation gap exists because the sheer scale and magnitude of the India. If you look at it, we don't have the single health market, right? We have hundreds of healthcare markets. We have small private facilities, we have we have rural facilities, we have big hospitals, tertiary care hospitals, etc. So because of this heterogeneity, these gaps exist. For instance, and another element of the gap which comes in forth is the data sets that are informing the AI, which we all know that most of the AI models have been trained on Western or Caucasian data sets. And among Indian data sets, the data has mostly come from some localized urban data sets. So the generalizability of the AI models that are being created, there is some gap, and there can be, a lack of accuracy due to the same. So I believe that we need to further improve our data sets, and already that is happening. ICMR is creating biobanks, for instance, with the help of other institutes of national importance. And as this AI technology will become mature, I'm sure that with larger data sets, better foundational models, we will be able to bridge these gaps in a far better manner.
So, if I may rephrase what you just said, I think the policy readiness is just reaching where it should be. With DPDP Act coming in, I think a lot of distance has already been covered, but as we all know, there's still a long way to go. So coming to Professor Chalu, ma'am, you have been working in this system, in digital systems and AI for a long time. Picking up from where Dr. Basu left, what has been your experience? What gaps, how is it progressing in terms of whatever gaps have been there?
Thank you, and thanks to Dr. Prem, thanks to my co-panelists for making it possible for me to be here. I'll not start with the gaps. I'll start with the fact that let's look at Indian context first. That itself is such a vast landscape with diverse demographic profile. And as my co-panelist said, when we think of using technology, AI is just one technology. The reason is to kind of bridge the gap between doctor-patient ratio in a manner that everybody, even on the outliers, are able to have that facility. So once I have my end goal clear that technology is going to be a kind of equalizer or is going to be a kind of support system to the current medical landscape, my concepts will become very clear. Okay, and this is where we need to look into that the reason a patient comes to a doctor would now should be as comfortable with a doctor with technology. AI is just one. So what our policy regulation is, yes, I will not repeat what Dr. Basu said. I'm a big proponent of what Government of India is doing in terms of its regulation spaces. But I would also say there is a very particular need to look at the realization that trust deficit is still there. When DPDP Act came, and we celebrated, all of us, after 5 years we finally got it. But if you would look at it very closely, it doesn't particularly address health issues. So ICMR data bank issues, yes, data bank events are very good. Policies are very good, but what is throughout missing is the implementation strategy to not just reach to 1.4 billion, but also to ensure that the trust deficit is bridged. And now this trust deficit is coming not just because of the algorithmic bias, but is also what I call as accountability vacuum. Accountability vacuum is if my systems go wrong, which they would because it's still artificial in nature, whom do we pin it to? Do we pin it to the doctor giving diagnosis? Do we pin it to the laboratory where it was undertaken? Do we give it to the value chain? Do we give it to AI platform? Do we give it to algorithm? Or do I give it to the limited data set? So this accountability vacuum where third-party vendors are also there when you look at IT/OT and IT/MT implementation in this is one reason. Second, I'm very concerned about the expanded threat surface. The more data I'm picking up, it's not just privacy which is important, it is also how well guarded these data sets are. And this is where I would say high time for Government of India, very senior government officers are sitting here, and my warmest regards to them, let us not look at centralized approaches. And we cannot shake off that AIMS ransomware attack, fear, and ICMR data breaches. So let's look into federated data structure where I give full brownies to Government of India by giving DPI to the world. So DPI, digital public infrastructure, follows federated data structure. This is what is required in medical realm. So to build the trust gap and to get over the accountability vacuum, policies need to be retweaked, particularly for health. Thank you.
Very well articulated, ma'am. A very pertinent point you made is that while policies and frameworks are one side of the coin, other side of the coin, that is actual implementation and building trust, is probably what would take this further. So since you talked about implementation, I think I'll have to go to Dr. Rahul, who is much more closer to the implementation of AI. Dr. Rahul, you come from an ecosystem where AI is actually being implemented, and JIMS has done a lot of commendable work in this direction. And ma'am talked about trust. We talked about infrastructure policy. What is your experience, and especially in terms of gaps in trust, doubts on accountability, and other things?
Thank you. I come from Government Student Medical Sciences, Greater Noida, and we were the first one to establish a medical incubation center in a government hospital. With a lot of accountability, I'll not have bias for the government or for what we come here. Let's be very, very clear on things that if things go wrong, who is to be held accountable is clinician. There is no gray zone. There was an article in Times of India. A patient took the prescription, edited it through AI, got the narcotics, went to court, the doctor was punished. Doctor is the final voice when it comes to clinical care. And it has been since ages and will remain since ages. That's one part of it. Second, AI has become the new electricity and we all are still adopting it. The way I am using WhatsApp, my father is also using WhatsApp. It's like new WhatsApp in the ecosystem. But then we'll have to understand that a lot of quackery is coming down in the ecosystem in the name of absence of processes. I almost hear 15, 20 ideas every day. Out of those, and we also fund ideas. I see a lot of people will come down and will fall play with the word called validation. To the doctors in the house, I request, it is very, very important. Even Government of India is doing events, programs to make our doctors aware that we have to understand that what is validation, what is the right way of validation, because startups want to enter the market at any cost, and this cost is at the cost of doctors. There are people who come down to our center saying that हमारे सॉफ्टवेयर 10 अस्पताल में लगे हुए हैं, 10 लोगों ने वैलिडेट किए हैं. ये सब ओपिनियन है, ये वैलिडेशन नहीं है. मैं बहुत जिम्मेदारी से कहता हूँ. Validations are institutional. It has to have a PI, it has to go through the GSRC, it has to go through the ethical committee, it has to have a CTRI number. और गवर्नमेंट ऑफ इंडिया भी पढ़ा रही है डॉक्टर्स को AI, हम सब भी पढ़ा रहे हैं. कल भी हमारे यहाँ एक प्रोग्राम है where we are focusing that all doctors should know that what is right AI, what is wrong AI. और क्या कोई सिस्टम आपको यूज कर रहा है, ये बहुत इंपॉर्टेंट. आपको लगता है कि आप डॉक्टर साहब हमने आपको सर्विस आपके क्लिनिक में फ्री में दे दिया, आपको लगता है कि मैं तो टेक्नोलॉजिकली इनेबल्ड हो गया. लेट मी गिव यू अ वेरी क्लासिक एग्जांपल. वन जेंटलमैन कॉल्स मी फ्रॉम लंदन. आई एम इंडियन क्लिनिशियन इन यूके और मेरे देश के प्रति बहुत प्यार है. एक सॉफ्टवेयर है, तो जो भी मेंस्ट्रुएटिंग वुमन है, वी वांट देम टू डाउनलोड दिस एंड स्कोर देयर पेन. तो आप क्या करेंगे, बोला जब आप स्कोर करते हो तो फिर ना कुछ वीडियोस आती हैं मेरी खुद की, क्योंकि मैं खुद ही क्लिनिशियन हूँ, तो मैं चाहता हूँ मैं वो एडवाइसेस दूँ. तो बड़ा नोवेल सा आइडिया लगा हम लोगों को. फिर जब हमारे डिपार्टमेंट की हेड से जब उनकी बात हुई तो उन्होंने कहा कि मुझे एक बात बताइए, ये तो अच्छा इरादा है आपका, वेयर इज द डेटा? डेटा यूके में है. आपको एज क्लिनिशियन पूछना पड़ता है कि डीपीटीपी एक्ट क्या हमें समझ में, और अगर हमें समझ, ये हमारी जिम्मेदारी भी नहीं. हम मरीज देखना पहली जिम्मेदारी है, दूसरा जिम्मेदारी मेडिकल एजुकेशन है, तीसरी जिम्मेदारी अच्छी रिसर्च करने की है, और चौथी ये कोशिश करनी है कि हमारा रिसर्च इनोवेशन में ट्रांसलेट हो जाए. लेकिन डीपीटीपी एक्ट ये कहता है, नया मॉडिफिकेशन, द डेटा बिलोंग्स टू द पेशेंट. पहले डीपीटीपी के पहले ये था कि डेटा ऑल्सो बिलोंग टू द हॉस्पिटल. इसका मतलब आपको डेटा यूज करने के पहले पेशेंट से कंसेंट लेना है. बहुत सारे स्टार्टअप जो ये वर्ड्स इधर से उधर करते हैं कि वैलिडेशन हो गया है, वी हैव टू आस्क देम कि सही वैलिडेशन का तरीका ये है, और आप जो कह रहे हैं उसको ओपिनियन कहते हैं. और एक आखिरी चीज, बहुत सारे इंस्टीट्यूशन अपने लेटरहेड पे लिख के देते हैं कि वी हैव वैलिडेटेड. इंस्टीट्यूशन वैलिडेशन नहीं होता है, वो ओपिनियन है. थैंक यू.
Dr. Rahul, a very, very pertinent point that you made is whatever, whether we like it or not, the onus lies on the clinician. To be able to trust an AI, the final onus is on us, the clinicians, because we who have to ask questions. This is something which, whenever I speak to clinicians, I always emphasize, learn to ask the right question. For clinicians, the knowledge of AI is all about asking the right question. We should not be blindly trusting any AI that comes to us. Satul, I think you must be feeling all these clinicians and policymakers have come together, and now there is a voice of the industry and the maker of AI. So coming over to you, what are the challenges that you have faced in terms of maybe some hazy policy as of now, or maybe some issue with the data or anything? So what has been your experience as somebody on the other side of the table who's actually building and then taking the activity?
So first of all, thank you very much for this opportunity. I agree to all of you to begin with. But then just to give a perspective about the industry and how things have been in terms of security and data, you see, security has been the hallmark for a reasonable data protection which is required for all the institutions as far as current possibility is. Any industry, be it in technology, be it in manufacturing, be it in healthcare, everybody needs IT security and technology security. But protection of security inside the hospital mostly lands to people like CISOs and CIOs who actually owns the understanding of the hospital system. There are three factors to this. One is somebody who's data owner, we call it data principal. Second is the data fiduciary, and the third one the data processors. We come as people who are data processors, and something like the things that we have to take care, which primarily into where we are using data, how we are using data, what type of approvals and agreements we have in place, how we are protecting that institutions whose data is there. We definitely have to fall in line with all the current policies which are there. Now, companies like us have to understand that we don't go ahead and use public LLMs and public AI solutions out there. Dr. Rahul definitely said the exact thing that is exactly why people like us have to build everything from the scratch for India inside, and the data has to be inside India. So in GoodMed, we could find out that this was the first impediment, that create everything inside India and make sure that it is falling in line with the policies and perspective. Make sure that externally we are also using certificates such as ISOs and certain certifications which are an SOC, so which are actually has been laid down since ages for security. And then lastly is we also do ethical hacking for our systems in order to see that how the data is taken care, whether the data is going out or not, and how the advisories are taking place. So there is something which we have to own responsibly, we have to act responsibly, and make sure that the institutions, clinicians and doctors and patients' rights are all taken care simultaneously.
I think as a clinician who has been working in this space for 10 years, I have a lot of respect for the makers of AI in this country. With the kind of data sets we have, we all know how incomplete our data sets are. Still, you people have been able to create, kind of magic, I would say. It's really commendable. Dr. Prakash, would you like to add something?
I would like to just bring another slightly different perspective. Everyone is using AI, and to understand the risks associated with AI, we need to really understand how AI works. We need to really understand a little bit of the nuances, because someone might argue that AI don't think, someone might argue that AI don't logically conclude something. AI cannot do research. But nowadays, are these myths? Or someone need to know a little bit about AI? Just want to throw some thoughts subsequently, because the moment that you are trying to understand the risks associated with it, what is the capacity that AI was having, and what is the potential capacity gap that poses the risks? I just want you to tell for the subsequent discussions.
So we all spoke about the risk, the gaps. So I think let's move on to the more constructive part of it, as to how do we bridge this gap? How do we build trust in AI? And I think I'll have to circle back to Dr. Basu. Since you have been working in the public health space, you have had the chance to use AI across public health in NCDs and all other things. What are some of the guardrails that you would recommend for hospitals or other healthcare sectors who want to implement AI?
So the first thing to see is that there are multitude of AI solutions now available, and it can be for the same basically the same problem or the same outcome. Like for cervical cancer screening, there are multiple tools now available. for diabetes screening. At one of the IITs, I just had the opportunity to witness a tool being developed to detect type 1 diabetes, a qualitative yes/no marker, which can be a game changer in the field. We think in terms of more of public health applicability, right? So, of course, when earlier we spoke about validation, just now Dr. Rahul spoke about many clinicians automatically don't understand the idea of validation, especially large scale or real world data validation for the AI. So often, yes, you will have AI companies who will try to sell their products saying that this has particular sensitivity, particular specificity, and they will give you an accuracy figure, the area under the curve. While some of it may implicitly, yes, most clinicians have some idea about these numbers, and especially the higher it is, probably the better it is. But what needs to be circumcised, in which populations have they been tested, and under what circumstances have they been tested? Have they been tested in the field, using which machines, etc. So unless you have large-scale real-world validation, a particular guardrail that you could keep is that you could test it, within, you can do some shadow testing within your own hospital setting. That just initially don't deploy it directly on the patient. If you're deploying it, the clinician should, or the treating clinician should not be aware that an AI is being used. So this way you will get some idea about what is the quality of the intervention being used. The second is that if you see the AI ethics, one major thing is human in the loop or human in command. That is one fundamental principle of AI ethics. So, but in the real world, being in command can be challenging for the human, especially due to this, if there is an automation fatigue can happen. Eventually, the physician might feel that AI is always correct. Also, there is a risk of de-skilling happening, but that is something long term. I will not immediately. But when all this is happening, so other issue is again of explainable AI. Many a time, so one of the guiding principles again of using AI strategy is that all AI tool should explain that how it has arrived at the conclusion. But fundamentally, all these convolutional neural networks, the deep learning networks on which modern AI is built, it's fundamentally a black box. It is very difficult to today identify how sometimes AI get answered. Even in imaging, for instance, many a time you would not know how the AI has arrived at the answer. So the counterpoint which is being raised by some researchers is that there are many drugs where we don't know the exact mechanism of action. Even for metformin, a very old drug which we are using for type 2 diabetes, we don't exactly know the mechanism of action, but we know it works. So if AI does work, and even if some explainability is lacking, probably you could use it. So as guardrails, we need to keep some things in mind, but I also see that, coming back to your first question, that we need some revision of these processes. Some ethical processes like explainability, etc., may be difficult, and when we say human in loop or human in command, probably it is something most vexing and challenging in certain respects, that when you feel that AI is superior to, if you feel that AI is at par with, your best case human, then at that moment it may become really challenging. So I will say always rely on large-scale national level validation, that is one thing, but also do some testing in your own hospital data set. Right? So that could be a good way to avoid getting blamed if somehow you are missing out.
So I think it all again comes back to the same idea of validation and asking questions. But ma'am, you have a lot of experience in actual implementation. If we keep asking questions, won't it slow down the progress of innovation? Then how do we find that balance? You don't actually slow down the innovation part.
Thanks for all the credit coming to my gray hair. 35 saal is definitely being Buddha, but of experience, not my age. Okay, so I agree with you that to a large extent, when I say agree with you, I agree with Dr. Basu to a large extent. There are issues which are leading to what we call as notification fatigue. Okay, it's not just something, it's like when you have an extremely flawless system, it is inconvenient also. But flawless is a very generic term.
So, Dr. Saab, what I've come out is, I call it as an acronym. You might laugh your heart out, but that's how I've enjoyed my studies, by making a humor of it. I call this check in medical lingo, I call it as FAT PSCB. I come from PSCB, Punjab State Electricity Board. So if you look at these aspects of FAT PSCB, which I'll explain you, is fairness, accountability, transparency, privacy, safety, E is silent, and B is benefit to whom. Okay, a lot of times benefits come to the doctors and not to the patient. And that is where, and sir, where I differ from you, Dr. Basu, is that let us not forget that I'm a cyber expert also to a certain extent, and I'm a trained CISO. And in this case, in your medical case, it's not financial data at risk. It is not your ID at risk, it's your life at risk. Even one stray case of misdiagnosis through technology could alter somebody's life forever. So please, I think fairness comes only when you look at the vast data sets. I just got very good cases where this is a good example, because you've come to the good part. The good examples is Google's retinopathy AI, which was pioneered by Arvind Eye Hospital, tested for 1,28,000 images before bringing it to the market, and already it has come up with 98.8% perfection. There's Open Safety, Oxford's Bennett Institute, where 58 million NHS patients were checked before it was released, and now it is relying totally on federated structure. My last take on this. Let's not forget, innovation has never been stifled by regulation. To the contrary, if you have regulation in place, the trust factor improves. Okay, instead of delaying the regulation part, you are actually to a large extent losing out on unreached customer. And the reached customer is also not very sure of your credibility, because they don't know whom to turn to. I'll just rest my case there. Thank you.
That's a very interesting take on things, that regulations actually facilitate innovation. So Dr. Rahul, from the experience of actually implementing these things, you must have put some frameworks in place in your hospital. So if you could enlighten us on what you're practically doing on ground, I think that will go a long way summarizing kind of.
परफेक्ट। हम क्या करते हैं उत्तर प्रदेश में, हर किसी को ना सरकारी अस्पताल के साथ काम करना है। दैट्स पॉइंट नंबर वन। Luckily we are an incubation center as well, so whenever people come down to us with a very but I want to put on record, a startup pitched to us, showed me a certificate validated at AIMS. I clicked the picture, sent it to a friend of mine at AIMS, a fake certificate. I also sit on the evaluation committee of government of UP where we fund the ideas. अब हम करते कैसे हो, क्या करें? इस केस में जो हम कर रहे हैं शायद यही एक अच्छा रास्ता है। हम ये कहते हैं कि आपके पास जो भी सर्टिफिकेट्स है, कम एंड डू अ sort of जिसको हम कहते हैं कि परफॉर्मेंस इवैल्यूएशन टेस्ट विद अस। वी विल हेल्प यू आउट। वी डू अ परफॉर्मेंस इवैल्यूएशन टेस्ट ऑफ योर पर्टिकुलर सॉफ्टवेयर, और ये भी समझने की कोशिश है कि क्या वो सॉफ्टवेयर मेडिकल डिवाइस है, ये सॉफ्टवेयर मेडिकल डिवाइस नहीं है। बहुत बार आउट ऑफ रेगुलेशन कंसल्टेंट कह देते हैं कि आप सॉफ्टवेयर को अलग वैलिडेट कर लो, हार्डवेयर को अलग वैलिडेट कर लो, और जब आपको बेचने आते हैं तो कहते हैं कि हमारा वैलिडेटेड है, ये सॉफ्टवेयर का सर्टिफिकेट या हार्डवेयर का है। बट ये समझने की ज़रूरत है कि अगर इस माइक में आवाज़ आ रही है और इसमें एक बैटरी भी है और इसमें एक सॉफ्टवेयर भी है, तो इस माइक को अलग से वैलिडेट करने की ज़रूरत है। दैट्स पॉइंट नंबर वन। वी वुड जस्ट नॉट कंप्लेन, वी हेल्प विथ एवरीथिंग। दैट्स वन पॉइंट। दूसरा एक और अच्छा चीज़ है, डिप्लॉयमेंट कैसे बढ़े, ये सबसे बड़ा सवाल है जहाँ हम सब जिम्मेदार भी हैं। उसका तरीका है कि अभी वी हैव टू डू डेमो डेज ऑफ वैलिडेटेड सॉल्यूशंस। अभी मंडे को वी आर डूइंग अ 15 startups we have filtered across country. Come and display at our government hospital. हमारे गवर्नमेंट के लोग भी आएंगे, और अगर आपने पायलट करना है तो पायलट करेंगे, और अगर आपने हमारे साथ वैलिडेट किया तो हम आपको पहला पीओ ऑर्डर भी देंगे। अगर ये जेन्युइनली अच्छा है, हमारे अस्पताल में टेस्ट हुआ है, वी विल गिव यू द फर्स्ट परचेज ऑर्डर एज वेल। हमें ह्यूमन सेंट्रिक चीज़ें सोचनी होंगी। अगर वो आपका स्टार्टअप होता तो आप ये नहीं करते क्या? वी हैव टू ब्रिंग गुड सॉल्यूशन टू द मार्केट, but ethically safe, clinically validated, and of course regulated. ये तरीका है।
thanks for laying out that process so clearly. So, Mr. Latif, industry's perspective on this.
So, coming to what Dr. Rahul just said, yes, we had to follow in line with, as I said, ethically safe, as he said, proven solution. We have to be tried and tested around that. Now, the industry of AI, the world of AI inside the healthcare is definitely a tough way to get into. After all, there are so many of all the things which everybody will understand. People did said that financial data is fine, this data is fine, but when Dr. Charu ma'am said that it is life, everything goes that level. And when you talk about that level, then people start getting concerned for everything, right from the patient rights to doctors' rights to hospitals' trust level and own self-regulation. And we all think that the vendor or people like the startups or the companies who are building, they are the real people who will be doing those risks around it. It is not only us. There are other stakeholders as well who are putting data at risk. And I would like, I'm not calling it out in that version, but the type of risk everybody is sitting on, we all are participant to it. I can control the processing part and manage the level how AI should work, the norms which has been laid for me. We will be able to take care of it. Physicians are there, billing systems or hospital systems are there, CISOs are there, but there are other ways where these data security breaches will occur, and that has been happening so far. So I'm saying that if each of the stakeholders do their bit, that is how it will be secured for the future.
So the bottom line probably lies in shared accountability and shared responsibility. I think we can go on and on discussing this, but in the interest of time, I will hand it over to Dr. Prakash.
So as we close, I completely agree and believe that the traffic signals are there to facilitate cargo faster. So regulations always facilitated faster adoption of digital transformation, as the studies always tell, no exception to artificial intelligence. And as we close, I just wanted to ask one insight, very brief, like as we close, if there is one change India must prioritize in next 3 to 5 years, like to build a trustworthy AI, predominantly an ecosystem, very context to healthcare. Just one takeaway the participants can take, you can very brief so that you can conclude the sessions. We'll start with, yeah.
One line it would be, go to the customers, hospitals are the customers, validate with them, make doctors co-creator of your technology, then only India will adopt this. So that's one of the shortcut or probably one of the
wonderful. Thank you. Co-creation is actually very important. Thank you very much. Yeah, please.
I feel, and what we are actually working on is creating a validated AI registry, which will include all the tools which have been validated to an extent, and this, the hoster of this registry must be the government of India.
Yeah, definitely. Trust through validation. You were always emphasizing on that one. Absolutely. Thank you very much.
My take is that as everybody is a stakeholder, so train everyone, inform everyone, and let them know about their rights.
Okay, absolutely. Very, very interesting perspective. Yeah, thank you very much.
I'll differ a little bit. I'll say let the co-creation be done more at edges, because safety gaps occur at edges. So my take is focus on outliers where AI would generally work for mean, median, mode kind of data. But it will always focus on those atypical cases. So while we co-create, focus on edges.
Yeah. Thank you. Thank you very much. It's a wonderful session. Thank you.
Once again, thanks to all the panelists and thanks to the audience.
Thank you so much, everyone, for such engaging panel discussion. As AI adoption accelerates, conversation around ethics, patient trust, cybersecurity, and responsible governance will become increasingly central to healthcare transformation. So everybody, can we please give them a round of applause? And I request all of you to please come forward, and I request and invite Dr. Kamalkant Kohli to please come up on the stage and felicitate all of the panelists. The chairperson and the moderator, please. Thank you so much, everyone. Thank you, sir. Thank you so much, everyone. For a group photograph, yeah. Thank you so much. Okay, so now moving on to our next panel discussion. AI is no longer confined within hospitals, clinics, and clinical settings. It goes beyond. From remote monitoring and virtual consultations to digital health ecosystems and global healthcare delivery, AI is reshaping healthcare access beyond physical boundaries. In this session titled Beyond Boundaries, how AI is connecting telemedicine, remote monitoring, and global healthcare access. We will discuss various other uses of AI in healthcare. To chair this session, I would like to invite Dr. Mahesh Shirke. He's a Chief Digital Officer and Scientist G at Andhra Pradesh MedTech Zone. He's globally accomplished healthcare and digital transformation leader with over 31 years of cross-sector experience. He leads the enterprise-wide digital health strategy, technology modernization, health IT ecosystem development, governance frameworks, and regulatory enablement for India's leading medtech and innovation platform. So let's welcome Dr. Mahesh Shirke on the stage, please. I would also like to invite the moderator for this session, Dr. Charu Dutt Arora. Dr. Charu Dutt Arora is a consultant physician specializing in geriatrics and palliative care and currently heads Emory Health Home Healthcare at Asian Hospital. Everyone, can we please give it up for him? I would now like to invite our distinguished panelist on stage, Dr. Saurabh Gupta. He's Associate Professor of Biomedical Engineering at National Institute of Technology, Raipur, an institute of national importance. Everyone, can we please give a round of applause to Dr. Saurabh Gupta? I would also like to call on stage Brigadier Arun Pandey. His Vishesh Seva Medal is a military veteran from the 1985 batch with 37 years of distinguished service in the Indian Army. I would also like to call on stage Mr. Ashish Singh Chandel. He is a product designer and academician with over 2 decades of experience in design, innovation, and entrepreneurship. An alumnus of Indian Institute of Technology, Bombay, with a master degrees in design. He has contributed to projects in transportation, sustainable design, and product innovation. So we welcome all of you on the stage, and let's begin with this panel discussion.
So good evening, everybody. First of all, at the outset, thank you to the team of Medical Dialogues and Dr. Prem Agarwal sir for organizing such a beautiful conference which intersects an ecosystem of artificial intelligence, technology as well as human-centric care. I know post-lunch sessions are a little lazy, and definitely talking about technology the entire day can get too much, obnoxiously busy in your head. But as the time says, and as the conference goes on, in today's time, we stand at a very beautiful intersection, an intersection where technology, medicine, and artificial intelligence all cross paths with each other, and in ways we cannot even imagine. It is a space where geographical boundaries really don't matter. Exactly 10 hours ago, I was at a place 7,000 kilometers away. And we were discussing almost the same thing, how India is transforming AI in elder care space. And now we're discussing with the gentleman here. So that says that people are doing a lot of innovation, a lot of models, a lot of new things all across the world, but still learning at the same point, because at the end of the day, if one thing which continues to stay, that is quality-driven care to the patients, which, as the master of ceremonies also said, is not confined now to the boundaries of the hospital. It is way beyond that. It has to be smart, it has to be quality, and it has to be increasing, always upwards and rising. So I think without wasting time, we should definitely aim at explaining how technology is truly demonstrating the role of healthcare access for millions across the globe. And I would start with Mr. Ashish Singh Chandel, sir. We'll start with you. Now, you are a business innovator, you're an idea pad. Is your mic working, sir? Yeah. So, Mr. Ashish, you have worked, you've worked deeply with AI application processes all across. Where do you see is basically the biggest breakdown today, where healthcare organizations try to move from AI pilots to real-world situations?
Well, I have, first of all, thank you, Medical Dialogues, for having me here. I have two takes on this. One is I must give it to the Indian healthcare system in general and Indian doctors in particular. Calling your doctor in the middle of the night and doctors showing up at your son's birthday party, and next day he's playing golf with you, and the kind of empathy levels which are there built into the Indian healthcare system is unbeatable all across the world. So whenever the Indian healthcare system tries to, like we have been facing this problem at our own institution, and you try to bring in an AI system with a notion to replace, it doesn't work. You have to work with the highly empathetic healthcare system which is already in place and which is unbeatable. I don't see any, and especially after dealing with some, especially after dealing with the American healthcare system, I don't see AI, that whole concept of replacing happening. What will work in Indian healthcare system is basically reinforcement, or you can resolve issues. You cannot replace. The second breakdown, which is not exactly happening right now, but you will see it in very near future, and this is very important for healthcare professionals also, is the concept of sustainable AI. The AI ecosystem works at very lot of levels. Right now we are we're talking about the softwares and diagnostics and all. But there's a power grid which feeds the system. Already 30% of the world's power is running the AI systems. It's consuming large amounts of water, it's consuming large amount of fossil fuels, everything. It needs large number of programmers, it needs large number of policy decisions, it needs largest number of implementers, and especially I can see 2, 3, 4 areas, healthcare being one of them. Doctors are going to be the super implementers of this ecosystem, and we are actually now only at the 5% level of AI deployment. Imagine what will happen at 100%. So what we are looking at, optimization of AI, we are looking at sustainable AI. You cannot look at AI as a free for all. It's going to be a very costly affair in very near future. We have to get sustainable both financially and resourcefully. That's the concept of sustainable AI which is evolving. Besides many other, like you talk about generative AI and agentic AI, the new buzzword is sustainable AI. So these are the two areas I can think of right.
Now, moving from sustainability, I would jump to Dr. Gupta. Now, you come from technology and an intersection with academics. How do you feel that with an experience of AI in innovation and research and also academics, how mature do you think the artificial intelligence, the buzzword, is for remote monitoring and healthcare technology as of today, especially when it comes to Indian healthcare settings?
Thank you. Medical dialogues for this. So yeah, I think the AI is pretty much sorted in few areas, like we have seen a lot in imaging and other related areas, where the ecosystems are quite confined and the things are disciplined. But when you talk about the remote sensing, or like when you talk about the remote telehealth, telemedicine kind of thing, then mostly we are addressing the rural or the underprivileged or the low resource settings in India, and there it is not reached yet. And I don't means even I think it will take still lot of time to reach there. So just I want to mention here one of the projects that I'm doing with government of Chhattisgarh, and there we are trying to get the BMI of the kid just by the picture. Just by clicking the picture, we should get the BMI of the kid. Okay, getting the height is okay, we can get, but getting the weight from the picture is a challenge. And even today, like we have doing lot of things in AI, but there is not a single AI solution to this kind of problem. And on the other hand, government is putting so much money on nutrition, on malnutrition and all that. But even like if we can get some AI solution just for this problem, then we can solve a lot of things. So that is one thing. But I think to be positive, Demis Hassabis had just told a few days back that healthcare is the best use case of AI. So whatever the challenges we are seeing in AI as of today in healthcare, I think exponentially they will get the solution over time. So, yeah.
We'll definitely come back to the project with Chhattisgarh. I think I'm very interested personally because in 2017, when AI was still in the developing form, we did a research with the Linda Lopez Foundation in Los Angeles, wherein we were able to see in pediatrics, we were able to create an app called as Face to Genes app. Not promoting here, so don't download it. But Face to Genes app, if you download it and see, you click a picture of the child who comes with a facial dysmorphy, different features of the face, different features of the hands. Sometimes if doctors are sitting here, they'll understand that when a patient comes, there are certain phenotypical features, how he looks, how are the eyes, like a typical trisomy or a Down syndrome baby. Now, most of the diagnosis of genetics is still under research, so you don't get to know where is the genetic issue. Now with millions of copies of data entered, I'm talking about 2017, millions of copies of data entered, just by clicking the picture of a child sitting in Haiti or in Hawaii, we were able to diagnose that which chromosome is expected to be deranged, so that we don't do a complete genome analysis, but just a part of it, which is cheaper, more economical for sure, and definitely helps in the doctor in making more conscious decisions. So we'll definitely come back to this for the BMI thing. It's very interesting. Jumping to Brigadier Saab, India is definitely the third largest market for cross-border tourism, medical tourism, as I would say. Do you really think AI can actually create a different niche or a change of cross-border tourism as well as globalization in medical facilities when it comes to India?
It's a privilege being here among such distinguished panelists and such a wonderful audience. I might be the least qualified to speak about AI as such, but then I've had some experience in raising a medical tourism company from the scratch, wherein we created that company, interacted with NABH, got accreditations, raised a website, interacted with a large number of hospitals, and started the process. Now the easiest part was getting on board with hospitals because all they wanted was patients. And we went to embassies, we went to various diplomats, and there was a lot of disconnect with various agencies that were trying to regulate this vast ecosystem. It's a given that medical tourism in India or medical treatment facilitation is a very, very
lucrative aspect both for the Indians and for the patients abroad, because we give wonderful and very low cost, high quality treatment to the foreigners. But the biggest problem is the trust gap that exists. Now suppose I'm a patient sitting in Africa or Bangladesh or Nepal, then the entire scenario is very foggy. I will want to either get onto the web and make a few queries, and then you are flooded with a lot of data which is badly regulated, driven by algorithms, and it is a chance that I might land to one of the hospitals. There are agents, and the whole system is also driven by what I may very strongly put by touts as such. So these people sort of give a bad repute and create that mistrust between the clinical treatment part and the getting of these foreign patients inside. Now, what can the AI do? Firstly, the platform that launches the AI would want to do it, portray their own version. If a hospital has got an AI bot and a system, explaining its own facilities, then it will do it in a way that the patients are seduced into coming to that particular hospital. If there is a medical value tourism company doing it, then it will try to promote itself. So AI becomes more of a marketing tool in the hands of people like us. And there has to be a larger body, the framework of which the AI sits, compares all of it, and then gives sort of a filtered information to the patient who wants to come to you. So I'll keep it at this. In case there's any further clarification required, we'll move on.
No, absolutely, absolutely. I think with permission of Chair, sir, we can obviously move to the next set, wherein I would jump to the commands of Dr. Saurabh, sir, with the recent one that Mr. Chandil, sorry. So you have always, in your transitioning, we have seen that you follow a lot of AI applications very closely. And I'm sure there are, with the new evolution, with an ever-evolution of AI happening in the healthcare system, there would be certain applications, or I would say projects in terms, which you see as the most promising when it comes to delivering quality care for patients, especially in remote monitoring or within the boundaries of the hospital as well. Do you think that can be helpful for the newer technologists across the country in what is very promising?
Well, one of the most promising thing which I can see which is going to happen in very near future is where quantum computing merges with AI. Now, just to set the context for the non-technical people here, it's like in the digital world you have everything is between zeros and ones. In quantum computing, there are a lot of new variables between 0 and 1. So what happens is the kind of problems, the kind of variables which can handle multiplies 2 to the power n, and being the number of qubits to be introduced. So when this case of very complex computation will merge with AI, then you will have a complete new revolution, and then you will see convergence. And this convergence is going to start happening very soon, because quantum computing is growing by leaps and bounds, and AI infrastructure, like I already said, is already falling in place. So you will see this change happening. Now, what will be the repercussions? For example, Brigadier Pandey's case, for example, somebody is looking for a heart transplant somewhere in Botswana, and it's available somewhere. So he will be able to provide a solution where some logistic company in some part of the world with a spare cryogenic capacity traveling from that part of the world routed to that area and come to this hospital which is closest, and that doctor which is nearest available, and they all converge and everything falls in place, traffic falls in place. Now this is a huge riddle which existing systems and AI together cannot solve. And when this convergence happens between quantum and AI, we call it hybrid AI systems. When this hybrid AI comes in place, then the second revolution phase. Now, AI being the first in recent context, the second phase will start, and that's exponentially more complicated and more capable. You will see massive convergences between systems. You will see complete integration in hospital management systems, the kind of complications and you know the records and the kind of variables which when you were ignoring earlier, that can also happen, and it's going to happen at grassroots levels also. The second, which I can think of, is which is also happening very soon, is AI. Right now you are interfacing mostly with screens. You are interfacing with robotics, which you are controlling, semi-human control. You are now looking at AI jumping the border and completely autonomous robotic systems, which can be performing both clinical and non-clinical services also at the hospitals, in the healthcare system. So that barrier is also going to be crossed very soon, and that also will require integration when it comes to areas where you need super sanitation and non-stop services and 24-hour protocols, Those kind of integrations are also going to happen very soon. And that's a very exciting area. A lot of startups are evolving and working on it. Yeah, so these two are two exciting areas, I think.
No, absolutely, because if there's anybody from the rehab, theme, rehab department or the vertical of healthcare, the new thing in AI or the new thing in rehabilitation is not just working through the screen, as you said. It's basically creating an expressive art form wherein we have a robotic hand technology for stroke patients. We have color therapy and music therapy, which is working for patients who are sitting at home, who don't have a caregiver, who can't afford a caregiver physically, but through a system. We are doing expressive art so that they don't have mental health issues, they don't suffer from dementia, they don't suffer from, I would say, lack of interest in things. So patients who are bedridden as well, now they are sitting at home and gaining access to not through a screen but through a system which is making them move their hands, making them more mobile, making them more independent, and also helping them to kind of have more cohesive thoughts in the brain for a better functionality. So I think absolutely, but if I understand it correctly, sir, is quantum more complex? Does the system shouldn't be easy? I think it's a little, so it just, I'm a technically retard guy, so maybe that's the reason.
Complex, quantum thinks complex, but slower. AI, it makes it faster. And so together they can solve very complex problems. So quantum actually allows you, for example, a leaf falls in Delhi and a earthquake happens in Bhutan. So quantum and AI working together will be able to somehow figure out what happened in the field. They will find some correlation from somewhere. So they have been solving problems, 150-year-old mathematical problems are now being solved by hybrid AI systems. So in that same case, when you're talking about rehab, why do we need rehab in the place? So the variables will start moving in all directions across that child, like why he needed rehab in the first place, where in his genetic lineage that error occurred from, and how far it will go, and what will be repercussions, how will it cope with. So he will measure all possible kinds of variables around that child and maybe suggest a more comprehensive, something which a human brain cannot comprehend.
So we are trying to say that a retrospective model to help in preventive healthcare.
Both retrospective, perspective, everything. So, because you're just increasing the number of variables which you have been using earlier to process this condition. Now you multiply socio-economic factors, or the
X number of
factors, everything. Yeah.
And how do you feel is the sensitivity and specificity of such a quantum system? Because I'm sure it has to be tested against the gold standards regularly.
I won't be able to comment on that because that's still evolving technology and we are following it closely. And India is also developing. We have a national quantum mission which is focused on a lot of areas and laying out the infrastructure and bringing the technology to India, which is happening very rapidly. And then that convergence will start happening. Integration with AI will also start happening. And then it's all up to us to start using it. The doctors will be giving us variables, giving us very case studies which have been kind of given upon, and we'll take it up all as problem statements and try to solve them using this new systems. So we are looking at very exciting times coming up.
No, absolutely. More power on the implementation phase, sir. Now, moving to Dr. Gupta, I think we'll come again to the Chhattisgarh project. I think that was very interesting. But also, in those lines, I would want you to enlighten our audience on how do you feel that telemedicine, AI-based technologies, especially for controlled remote monitoring, because we are seeing that India is an aging population, and by 2050, every fourth person in India is going to be a 60-year-old requiring more comprehensive, holistic healthcare, especially in a place wherein our joint family network is converted to the nuclear family network. So most of the kids are either out of city or not physically present with the parents. So controlled remote monitoring, telemedicine, as well as an on-ground, which creates a more integrated healthcare system. How do you feel is that AI is at a center space of all three perspectives?
Yeah, so when we look at the Indian healthcare system as a whole, it is very complex. When we talk about different people with different demographics and different areas. So it is about like mostly giving the continuity in healthcare. So let's say whatever the data we have coming from the variables, still there are not like we need such kind of standards that the data from the variable should make a ultimate predictive sense to the doctors, and that channel has to be made smooth. The other important thing is that we need to take the AI to the people. It is not easy to cater the population at scale at India to bring people to the AI. That's what is happening at most of the places. Developed countries, they have less population, we can bring the people to AI. But in India, we have to take the AI to the people. In the sense that, okay, just for an example, if we are saying the elderly people or the people who are not very well educated and literate, when we talk them to interact with AI, this is not that much possible because they don't have that kind of practice which we see in the developed world. So as myself as a researcher and to other researchers, we have to develop the technologies, we have to develop the more smart algorithms using mathematics and all that, so that even with the less data, we can make the sense of the AI. We don't need a lot of computation when we talk about the AI. Means we should not have a lot of computation when we talk about the AI. DeepSeek has done that, but more or less we are also conditioning that we need more and more computation, which is not necessary if we have smart algorithms, if we have researchers working on good things of AI. So the point is, yeah, things can be integrated smoothly in the sense that if we can change our strategy to take the AI to the people instead of the other way around.
So if I'm understanding it correctly, you're trying to say that a simple model which integrates and comes inside the houses of people is going to be more sensitive to people and better reciprocated rather than a complex system where people have to be trained and reach to them. Is that correct?
Exactly.
So as per you, a biovariable is the easiest form of an AI that can integrate everything, because I think almost every third person in an urban setting in India has some form of biovariable on their body. So do you think that's a simple system? Okay, perfect. No. And now moving to Brigadier Saab, although आपने बोला that you think you are the least knowledgeable in this panel, but मेरे हिसाब से आप सबसे humble इंसान हैं यहाँ पे. So I would have a question for you. When it comes to international patients, I think हम लोग generally as a medical doctor, I generally see most of the corporate hospitals, they promote their best facilities when it comes to robotics and PET CT for international patients, because they know that it's absolutely affordable for them, but it's also a business strategy for us as a corporate hospital, providing affordable healthcare. Now, but most of the companies, most of the organizations who are working with international patients, they face two challenges. One is navigating through the process, and one is cost of the treatment, because unfortunately it has become a cafeteria. The hospital business, the healthcare business is becoming like a cafeteria. Why? Not because there's a lot of competition, but because there's a lot of choices to make. And everybody has a different appeal to that choice. If I need a cappuccino, I can go and find it at 10 places. But I need a hip replacement, again, I can find it the same at 10 places at different costs. So how do you feel that definitely doctors and entrepreneurs, they keep on promoting AI for their medical treatment, how do you feel when it comes to doing the cost navigation and the process flow? Does AI help you and your patients with that as well? Have you felt any difference?
So firstly, there is a tendency of hospitals to seek big ticket treatments, and that is what they try to sell because it is attractive for them, and the procedures are defined, but they have to be high in cost. So you are absolutely right as far as that is concerned. Now there are three major challenges. First is transparency, because every hospital will have a different menu and a different rate list. The next one is integration, because there are a number of hospitals and agencies, and it involves a logistic chain, starting from visa, currency change, travel, stay, navigation into the hospital, the treatment, post-treatment scenario in case they have to go back, arranging finances. So this entire chain of procedure that takes place has to be integrated, and the third factor is transparency. The patient has to be very confident in knowing that these are the comparable type of treatments that he can get from various hospitals. These are the costs. In case he has to upgrade the patient experience and the quality of healthcare and treatment, then this is the escalation in price that will take place. So, yeah. So what AI can do is sit on top of all these processes and seamlessly, as Mr. Ashish had brought it out, can connect these various silos, and for a patient he'll get a complete layout of various options that he has, starting from travel, stay, the type of healthcare he wants, and what all will be there in the post treatment and post-operative. But who runs this system will have to be the, it has to be something like a SEBI of the stock market. So that particular agency has to be a centralized government agency, and that has to do a audit of all the hospitals that are accredited to it, and continue to sort of update their database and keep itself aware of what is the latest cost, the latest issues that are going on as far as the medical tourism and this sort of thing.
But isn't it so, I would say, it's absolutely very encouraging to have such thing, because it would create uniformity, it would definitely create access to quality, and it will also create a lot of transparency, as you said. But what about the grey market? Unfortunately, in the business of international patients, grey market takes 76% of the patients. How do you feel? Can AI actually take over that? I'll just give you 1 minute for that.
No, you see, AI is a system that gives you information. It's a digital system, whereas grey market is a brick and mortar and a hardware-based solution. So unless the people go and tackle the towns and these various centers that are mushroomed illegally, you cannot ask AI to, it can make you aware of these centers of illegal medical practice, but it cannot eradicate unless there's an enforcement agency that comes and physically and in a legal way, in a enforcement way, resolve.
Absolutely. So we have, before I give the mic to our esteemed chairperson for his closing remarks and question, I would like to open the dais for one question or two questions where I can take 1 or 2 minutes for our speakers. Do we have any questions? Yes, please. Can we have the mic to the lady, please? Please introduce yourself and also ask the question.
Good evening, everyone. My name is Sonal, and I head the operations for AmeriHealth. My question for the panel today is, can AI deliver remote monitoring realistically reduce the admissions of hospitals in India, especially in the elder care?
I think this question can go to Dr. Saurabh Gupta.
So yes, in elder care, I think as of today, not, because a lot of research needs to be go to there. But yeah, in the future, if everything goes good with the AI research, then yeah, means we can provide a lot of solutions at the home itself, and bring hospitals as close to the individuals and at homes. Yes, that only I can say.
Yes, Dr. Mahesh, I was looking.
I think I'll answer for this for you. With the advent of the entire post-COVID, I think we have been enhancing the home healthcare systems. And in this home healthcare system, COVID itself brought the two extreme ages, that is the pediatric and the geriatric. So with that, now you might have noticed since last one and a half year, hospices are increasing. With increase in hospices, thankfully the technology is adapting to increase in geriatric care. And especially even including the medical education, geriatric care is increasing. There are degrees and diplomas. With that, a simplest solution, a bed which helps you to understand you're falling. Its sensor-based beds are already available. There are glasses, example glasses, which a person is able to trip or fall because of his neurosensory deficits or anything. Those are all existing. But because of the cost effectiveness, they are not into the market. But I'm 100% sure with predictability and predictivity of AI solutions, which will 100%, there are solutions available, but it is unable to reach last mile because of affordability. I do not to take this in detail, but yes, 101% geriatric care will be the next level of care with increasing aging population across the world. And that is one of the low-hanging fruits.
And I think very well, sir, very well said. Even post-COVID, we have seen that a good home healthcare model with collaboration with technology and artificial intelligence, with as basic as a controlled remote monitoring or a fall prevention or a bed sore management care, has decreased hospital admissions by as big as 40%. So because it gives kids a peace of mind that their parents are healthy and being taken care of, it gives a quality of care to the families and also reduces the caregiver burnout. So I think that when these three verticals are well taken care of, hospital admissions are meant to kind of fall. I'm sorry if I hurt anyone's sentiments coming from the hospital background here. Okay, so I think we'll move to the final chair's message and remarks. Dr. Mahesh.
Thank you very much. I think Dr. Chari, you made a well lively moderation, that is what I can say. And before that, having these three wonderful panelists across us, I'll be very honest here, we had practical operational aspects spoken by them. And they did not speak only what is good, they spoke the best challenges ever you could have. And I being advisory myself, I face this every day in, day out. But there are some thoughts which I will mix it up so that the audience can easily perceive it as a layman understanding. Coming with Mr. Ashish, he gave a beautiful thought. Everybody is talking of AI, but nobody is speaking of sustainable AI. So the first and foremost, anybody wants to do any AI, first be very sure whether you can sustain. For any business to grow, you need sustainability, scalability, and expansion. So if this doesn't, don't make an app, don't make an AI application, please, because it will be a failure by itself. And for that, very simple, we are talking of AI. I have been in the session since morning for 3. Everybody, where is the device? Can your mobile handle AI device? It's only handling few part of it. The latest. Now, I think I'll just put an add-on. We were talking of quantum as well. Now, to handle AI, we need supercomputing. To handle supercomputing, we need data centers. To need those data centers, now Google and everybody is launching their data centers across in India with quantum and supercomputing capacities. They are doing, what do we have? Do you have a laptop which can run an AI? It is still browser based. Now, thankfully, because of the greater adoptions of the AI, the entire technology is going as an offline AI. The simplest being, I don't know how many of you are aware, the simplest being Google, GEMA or GEMMA4. It can be on your mobile, it can also be, and now I think ChatGPT wants to run away with say that now I will be offline too. So understand, AI let anybody talk in any session till it's a cycle. The software improves, next the hardware improves. Hardware improves, software improves. Even if you give me the best AI, no hardware available, it's of no use. And that is where we mean designing itself doesn't mean AI application. It means the whole system by itself, which is a unit, both hardware and the software. So to close that as an important remark. And coming to the very important part of medical tourism, I think I'll just put in a simple words which everybody understand. Today we go to a hospital, rightly said by its cafeteria approach. Nothing but we talk of service delivery. I would say, sir, very importantly, can I change the word to the whole country? I'll say service discovery. It's time with AI to use service discovery as in digital health, where it doesn't matter. I am giving this open thought to anybody in the platform here. Go ahead, build a service discovery digital platform. It can be better than, or it can be a better than Amazon in the today's world. And please, another important thing to this, to add on to it, if you are making it costly or non-affordable, it is purely. Most importantly, anything should be affordable. If you make it, it's like telling me, I think you all are hearing about Claude. Claude came, competitor came. Then Claude Code came, competitor came. Claude Cowork came, some part of Cowork became free. So what are we leading to? So anything, think over that there is something which you need to give back as a technology transfer across the globe, not only keeping to India itself. We have to global picture, and that is where I came up saying that we can have a service discovery, but at the same time, any AI application we make in medical tourism, can I also say AI application medical tourism as well? Because we are only making patient medical tourism, but we have an application developed in every corner of India. But where is that application? It's only in the corner of last mile of somebody else. So why can't there be an AI tourism by itself? So, and another important point made here, as a system here, very importantly what for the research. Currently, to be honest enough, we are only dealing, the AI's most concentrated system is only in two important things, imaging. And anything in imaging you feel, like rightly said, whether it is BMI or whether it is anything related to imaging, it is made possible because of the data set being available, which is easier. And second part which comes is very clearly, apart from the imaging, is now prediction. That is clinical decision data making system. It is not that it is not available. We have algorithms, we have workflows in place, we have standard treatment. Only thing, it is easier with the speed, it can give an immediate result. Otherwise, it exists since, I think, I don't know how many of you are aware, AI is since 1950. Now, we are only seeing the evolution of AI. That's all. And probably I have been dealing with AI since last, I think, more than 10 years, and in MCH and RCH across India for certain programs. And we just called it algorithm. I never said it AI. So that is the key part of it. And ultimately, to close it off, I will only say that whatever you do in AI, make it disruptive possible with a sustainable, scalable option.
Thank you to all the speakers for such insightful and future-focused discussion. Everyone, can we please give them a round of applause? Today's conversation have clearly shown that AI is not just transforming healthcare delivery, it is redefining access, scalability, personalization, and patient engagement itself. So I would request all of you to please come forward, and I would request Dr. Kamalkant Kohli, Chief Editor of Medical Dialogues, to please come up on the stage and felicitate all of our speakers here. Please come forward. Thank you so much, each one of you. Everyone clapping should not stop. Thank you so much. A group photograph. Thank you so much once again. Thank you. So, ladies and gentlemen, we will now break for tea for the next few minutes. We request all delegates to please reassemble shortly for the next exciting segment, the launch of NAIDM, the National AI Doctors Mission, followed by the much-awaited Phoenix Health Innovation Awards at 4:15 p.m. So we request all of you to please come back by 4:15. We're going to start with another segment. Thank you. we request everyone, because we need this hall for the arrangement. So we request all of you, you can definitely go and have tea or coffee, which is arranged for all of you. Thank you. भैया 1 मिनट दो. कुछ बोलूँगा. Sir, after 15 minutes we will begin this hall. So please step outside and have tea and coffee meanwhile. अच्छा मैं कुछ बोलती हूँ ताकि थोड़ा कैंडिड लगे. आया एक अच्छा. Hello, mic check on. Ladies and gentlemen, a very warm welcome to all of you. Hope you all had a good break. We now move on to one of the most important segments of the evening, the launch of the National AI Doctors Mission, NAIDM. Having included insightful discussions around one of the most important challenges and opportunities of our time, the integration of artificial intelligence in healthcare, medical education, research. We now come together for another significant milestone, the launch of NAIDM. Today we have gathered here to celebrate the transformative power of innovation in healthcare and the remarkable minds driving the revolution forward. Today marks a special milestone with the launch of NAIDM, an initiative aimed at strengthening healthcare innovation, collaboration, and the growing AI ecosystem in India. We also come together to celebrate the Phoenix Health Innovation Awards, honoring the pioneers, innovators, and institutions whose work is redefining healthcare and creating meaningful impact through research, technology, and AI. For this next segment, it's my privilege to invite our distinguished dignitaries to kind us join us on stage. First, we invite Dr. Abhijat Sheth, is chairperson of the National Medical Commission and president of the National Board of Examinations in Medical Sciences. A renowned catheteric surgeon with over 2 decades of experience in India and the UK, he has made significant contributions to medical education, healthcare leadership, and academic research. I also request Dr. Prem Agarwal, Chairman Medical Dialogues and President NAIDM, to escort Dr. Abhijat Sheth. Everyone, can we please welcome them on the stage? We are also honored to welcome Srimati Sunita Verma, is Scientist G and Group Coordinator R&D at the Ministry of Electronics and Information Technology, Government of India. She oversees national R&D initiatives in electronics, information technology, communications, and deep tech innovation. I request Meghna A. Singhania, founder and editor-in-chief, Medical Dialogues, to escort Srimati Sunita Verma. We are privileged to welcome Professor Dr. Sangamitra Pati, is Additional Director Journal at ICMR and Director and Scientist G at ICMR RMRC, Bhubaneswar. A renowned public health leader and physician scientist, she is widely recognized for her contributions to public health research, pandemic preparedness, infectious diseases, and healthcare policy in India. I request Honorable Brigadier Dr. Anil Kohli, Chairman NAIDM, to escort Professor Dr. Sangamitra Pati. So we now begin with the address segment of the evening. It's my honor to invite Dr. Prem Agarwal, Chairman, Medical Dialogues and President, NAIDM, to deliver the welcome address. So everyone, can we please give him a round of applause?
Dr. Abhijat Sheth, sir, Chairman, National Medical Commission and National Board of Examination. Srimati Sangamitra Pati ji, our Additional Director General, ICMR. Sunita Verma ji, Group Director at Ministry of Technology. And Anil Kohli sir. And more not the less, the distinguished people sitting down there who have contributed to the medical profession enormously in the past. This morning, when we began this conference, we reflected on the fundamental question. Will we guide artificial intelligence or will simply understand and adapt? Throughout the day, there had been a number of perspectives from policy, from research, from education, from clinical practice. And one thought was very clear.
that AI is no longer the future of healthcare. It is a part of our present system, our day-to-day activities. The only question that remains, the AI is coming, but are we prepared for it? On behalf of Medical Dialogue and Health AI Con 26, I extend my heartfelt welcome to all of you on this important question and the important moment of the launch of National Artificial Intelligence Doctor Mission. I also take this opportunity to express my sincere gratitude to the institutions who are given this vision and shall be extremely important in implementing the vision. That is Indian Medical Research, Indian Council of Medical Research, National Medical Commission, Ministry of Electronics and Information Technology, Dental Council of India, and also the next ones which we're going to talk about is a Pharmacy Council, Nursing Council, Homeopathy Council. Their presence here is not symbolic. It is a shared responsibility. Because when we talk to one, he is making program only for that particular segment. But a convergence of this thought on this platform tells that we have to do something that is common to all. In fact, we are addressing this today cannot be handled in silos. It requires alignment of policies, of education, of research, and clinical practice. This morning, we spoke about artificial intelligence as a powerful force, but we also acknowledged a reality that artificial intelligence is entering healthcare, whether we are ready or not. The question is not about adoption. Question is how to give a direction to it. At Health Icon, during the discussion, we have a clear need that artificial intelligence healthcare must not grow randomly. It must be structured, standardized, regulated, and most important, it should be guided by doctors. This thought has led us to the concept of National Artificial Intelligence Doctor Mission. NADM is not a program, it is not just a platform, it is our national intent. An intent that every doctor must understand artificial intelligence. Every doctor must be able to use artificial intelligence responsibly. And no doctor should be left behind in this transition. We often speak about technological transformation, but transformation does not happen with the technology alone. It happens when people are involved, when people are prepared, they accept the technology. AI will not transform healthcare. I'm confirmed that prepared doctors shall perform. If doctors are not prepared, if the system is not prepared, then AI will become more distortional. It will become inequality. It will become harm to the profession. And it will become like using AI is harmful for the patient. This is the foundation of National AI Doctor Mission. Through this mission, we aim to build awareness among doctors, create structured learning pathways, enable responsible clinical use, and align healthcare with national artificial intelligence initiatives. India has already taken a significant step towards India AI mission under the Government of India. NADM is envisioned as a natural extension of this effort. This bridge between the AI capability and clinical application. If AI builds the engine, NADM will be acting as a driver. Today, we are extremely fortunate to witness a convergence of these institutions. that will shape the future of healthcare in India. With education to research to regulations to technology and to the stakeholders, the teachers, the clinicians, together this convergence gives me confidence that what we are initiating today shall evolve into a structured national movement. But this opportunity comes with a responsibility also. Artificial intelligence healthcare has to remain ethical, safe, validated, patient-centric. Technology must strengthen medicine, not redefine its values. The values of doctors are known. The technology cannot redefine my values. That is, has to be patient-centric. Today is not the end of the discussion. In fact, it is the beginning of direction. A direction where doctors shall lead AI adoption. Institution shall guide integration. Policy shall guide safety. And technology shall enable the scale. Today morning, we asked, will we guide AI or will we adopt AI? This afternoon, we answer, we will guide it. We are not preparing for future of artificial intelligence. Many innovations are going to come. We are not concerned about the awe that artificial intelligence creates in the mind of people. We are concerned about that the basic intelligence is known to all. What is required as a basic draft should be common to all institutions, all faculty, all research, all postgraduates, all even policymakers. They can be better. They can be best also. But basic requirement must be common to all. We are preparing doctors for future. And if we prepare well, India will not just adopt AI in healthcare, India will define how it has to be adopted. Thank you very much.
Thank you so much, sir, for your inspiring words and warm welcome. I now invite Honorable Brigadier Dr. Anil Kohli, Chairman NAIDM, to share a few words with us and speak about the vision behind NAIDM. So everyone, can we please give him a round of applause?
Good afternoon, each and everyone. And we have on the dais very renowned President of the National Medical Commission. So we are lucky to have him here because more than almost 1,000 medical colleges in the country, which was the vision of the Prime Minister, has been made to reality. Dr. Prem Agrawal told you how AI, whether doctor have to adopt or the system has to adopt. Very rightly said, in coming time, if we don't adopt, that can be detrimental to the medical profession. India being the population of 1.4 billion, we have a huge burden of various diseases in the country. And AI and all is going to give us a solution to reach to the each nook and corner of the country, what is the aim of us as a doctor towards the society. So we are working on that so that each person who passes out from the medical college or dental college or pharmacy college or nursing college or allied sciences, he should be prepared to adopt it, to give a better quality of the treatment and better predictability and faster. We have lot of research material in this country, but it is not, data is not being properly documented. So that will help us in a better research and give us a better reach and better solution to the problems which are coming, like during the COVID. We were the nation which provided the maximum vaccination in the world. So same way, there are various diseases coming up, new variants are coming up. So to overcome all those things, I think this is a beginning, and we are looking forward to have a healthy nation, a strong nation, and the best nation in the country. I think that will be enough. We have short of time. So I'm very happy, and thanks to all of you, and my congratulations to each one of you who has contributed to make it a big success. Thank you very much.
Thank you so much, sir. So now I invite Dr. Sangamitra Pati, Additional Director, ICMR, to address the gathering. So everyone, can we please give a round of applause to her?
Namaskar. A very warm evening to each one of you. On the dais, as already my predecessor have told, we are extremely fortunate to have none other than Chairman NMC, said sir. So I think all of us really not only give a big round of applause, but also feel fortunate that we have the commitment from NMC, who are the regulatory body for medical education, and this shows that today's mission, which has been set into this platform, is not only going to be successful, but also is going to be sustainable. So thank you, sir, for your presence and for your inspiring words in today's morning session. Dr. Prem Agarwal, thank you, sir, for making me a part of this historic and landmark initiative. Ma'am from MAITI, from Dental Council. Today morning when we were discussing with Agarwal, sir, he told a very strategic statement. Each one has got vision. Each one feels about that we should do something about AI. But the convergence rarely happens. And today at this platform, all of us can see that convergence, that horizontal integration, and that commitment that India must show the world. And all of you, the stakeholders, the innovators, and the users and creators of AI in healthcare, India as a largest country, one of the largest demography, we should not only be the largest consumers of AI, we should also be the largest creator of AI. And when we think about using AI in healthcare, I will just share my one experience during COVID pandemic. Because each one is thinking that AI is going to replace doctors. It's not that AI is going to replace doctors, but yes, the doctors who are going to use AI may replace the doctors who are not going to use AI. So during COVID pandemic, all of us were extremely careful about maintaining the social distance and mask and everything. And it's my own personal experience. My son got high fever and cough. And I took him to the physician. And the physician asked him questions around from 2 feet. And everything he advised was from 2 feet. Let me be very honest, I didn't like it. How much we say that we should maintain social distance, it's the human touch, the healing touch of doctors that also matters. So when you think of using AI, it's equally important to have that empathy the physicians are known for, the healing touch that can make miracles in patients' life. And also it is a responsibility that AI must be used not only intelligently, ethically, and responsibly. Because AI is considered to be the leveler of inequity, it should not create more digital divide. So towards this, today's launch, I'm sure, is not only going to bridge the divide, but also it is going to create the roadmap how AI can act as the enabler and empowering tool for each physician, each healthcare professional, be it a frontline health worker or be it a super specialist working in a tertiary hospital. And at the same time has also come that how do we see AI can be used for making research more relevant, more effective, and more importantly, more cost efficient. How can AI be used now that we are going to have every district medical college? How can we leverage on AI for improving the quality of medical education so that each future doctor not only is confident but also competent? And more so, how AI can see that we are on the right track to Viksit Bharat and healthcare is affordable, accessible, available, and more importantly, equitable. I congratulate the team for not only launching this mission, but also showing the path for all of us that how India can be the global leader using AI for health with healthcare professionals and create the path to Viksit Bharat. Thank you everyone.
Thank you, ma'am, for your valuable thoughts and insights. I now have the honor of inviting Dr. Abhijat Sheth, President, NBE and NMC, our guide, philosopher, and visionary behind the whole concept, to say a few words. Everyone, can we please give him a round of applause?
Once again, namaste and very good evening now to all of you. And I extend my gratitude on behalf of NMC and NBE to Dr. Prem Agrawal and Medical Dialogue team to invite me for this interaction. I won't say much because I already said what I felt it in the morning. Just by participating in this sort of conferences and talking AI all around, everyone feels that why we talk AI so much. And I will tell the simple progress of AI. AI has made a huge leap forward in all other disciplines of our life. Although we are lagging behind compared to industries and other areas. I'll give you one example. That I've gone to one temple in the south where there is a waiting of 36 hours for the devotees. And the bureaucrats starting using the AI system, and they reduce the waiting to almost 12 hours, and they are determined that eventually they will bring this waiting to 6 to 8 hours. The reason I am telling you that these are some of the good effects of AI which we have to adapt it, and that is the purpose why the healthcare, because healthcare profession is not only about giving medicines or treating patients. It's a holistic care, and which requires a lot of aspects. The operational discipline, the universal access, also it requires effective delivery of the healthcare. It requires organization, capabilities. So a lot of things are required these days in a complex healthcare delivery, and that's why AI has become so important. The only problem is the machines work with machine works with IQ only, while we doctors have to work with IQ, EQ, which is emotional quotient, and SQ, which is either social quotient or spiritual quotient. And certainly at the moment AI is not having that two quotient. They are working, but they are not having. Hence we have to understand that we shouldn't become too much of dependent on AI. The message in the morning was clear that we must adapt AI for the benefit of the healthcare delivery and healthcare excellence or quality, but at the same time we shouldn't become blindly dependent on AI, and that is why we constantly use this, that AI cannot replace the human being, or AI cannot. I'll give you another example, that we had one inquiry from the to the NMC from the one of the organization, that someone was doing surgery from USA, and surgery was done through this machine, through whatever they used, robotic combination of artificial intelligence and everything. Now, who is this going to be responsible if surgery goes wrong? So, see, these are the ethical issues which comes in AI. Obviously, at the end of the day, the local surgeon or local physician who has admitted and treating, but do they have enough counsel their patients about this spatial arrangement? So, lot of issues creates a more complexity in framing the regulatory network regulations for this AI. And hence is a big challenge, and this can be only done if we connect with each other. As I told in the morning that India has the biggest advantage. India has AI experts in the world, and India is one of the best doctors in the world. So we must integrate this function in a way that we bring it to the best advantage of our healthcare. Simultaneously, we regulate it adequately, not in an over-prescriptive way or not in a too restrictive way. That is the responsibility of this new NAIDM mission, and we are committed to bring positive changes. When people ask about quality and excellence, I always say one thing simple, that we are not going to be static and we will be progressive, and we have to ensure that we should move from where we are and we should move in the progressive path, because that will help the further generation of doctors to take it to the next level, and that is our commitment. And my best wishes to all of you who are very actively involved in this subject, and at the same time who are very ready to contribute to all of us. And my special compliments once again to all the leaders of AI and Medical Dialogue and Dr. Prem Agrawal. My best wishes to all of you. Thank you so much.
Thank you, sir, for your inspiring address. Finally, I invite Srimati Sunita Verma, a person representing the Ministry of Information Technology, to share her thought with all of us. Can we please give her a round of applause?
Thank you. And once again, good afternoon to all the dignitaries on the dais, off the dais, all the medical fraternity who are here, the stakeholders. Since morning, I've been going through the various halls and looking at hearing the lectures given by the experts in the area of AI and how it can be relevant or tuned towards the betterment of the healthcare professionals and the society at large. So, at the risk of repeating what I had said in the morning to the larger audience now, METI has the India AI mission with 7 pillars in it. And in each of the pillars, we have taken care of the medical or the healthcare sector. That the focus in each first is on the compute. The AI compute which is available will be available for the researchers, the startups who are developing healthcare platforms, healthcare solutions in the country. And within the AI compute, it is very essential that we keep the data sets within the country. The sovereignty and the data not crossing the border is of utmost importance to us. So from the AI mission point of view, we appeal to all the researchers here that let the data which you are using or which you will be generating through the research be kept within the boundaries of the country, and for that AI compute is being provided under the AI mission. There is a DPDP Act which was mentioned in the morning, and the DPDP Act provides for the personalized data protection. The data of the patients need to be protected. So that data set also repository is available under the AI mission. That is one of the pillars. The annotated and the anonymized data can be is made available. You can also deposit your data there for the researchers at large, which can be used for developing various algorithms and LLMs. There is another topic which was discussed, I think, at large, and in one of the sessions in which I was sitting was on the ethical and responsible use of AI. It is very important from specifically the medical point of view that the algorithms or the LLMs that are developed, they are using the data sets, which are very, I'll say, unbiased, where the age, the gender, the geographic distribution of various population or the patients, that is all taken into account when the algorithms or the LLMs models, AI models are generated. So the accuracy of the models increase, and this also takes care of that while we take data of the patients or the population, which is generic from one maybe geographic or from one generation. It should also be applicable for a community of a smaller or a lesser known community, so that there is no wrong prediction in it. There is a provision in the AI mission that all the data which is being used for developing the algorithms, the traceability of the data needs also to be conformed to, so that when some other user sees the algorithms, they know where the data has been picked up, what is the basis of the algorithm development or the solution development, which is very important, because if there is any improvisation to be done, if there is any further changes to be made in the algorithms, the data sets either need to be retained or they need to be enhanced according to the various data sets which have been taken. So the traceability is very important in this. The traceability, the source, the demography, the distribution, gender balancing, auditing of the data are few, I think, important aspects which need to be kept in mind while we are developing algorithms. So there are a lot of more, I think, things that I would like to tell from the ministry point of view. The India AI mission is there for the skilling also. For the future skills, AI in AI is open for all the doctors from the government as well as from the hospitals, who can have the fundamental or the basic understanding, and as they go along they can go for the higher skilling courses. And ministry from time to time is also running some courses, some programs, some projects which can be taken help from. There is an R&D program in the ministry. In the morning I forgot to just tell about it, where ministry is funding research along with ICMR, Ministry of Health, DHR, and Department of Biotechnology, where the research is going on in genomics, in medical electronics, in health informatics. So we are funding research also. Any startups or academia who are looking forward to research using AI or in medical electronics, they are welcome to it. Because ultimately the government is looking at developing technology stacks. It is hardware stacks or software stack to completely build the ecosystem within the country. The various missions of the government, maybe One Health mission, the AI mission, the India Semiconductor mission. So all of them are looking towards how we can enable our researchers to come out with more and more solutions, not only for
within the country, the customized solutions which are needed for the ministry, for the country, but also going global. DPI is one of the very good examples that we have. And I think I am very thankful for again being given this platform to share my thoughts. Thanks to Dr. Prem Agarwal and the excellent team here. I think, and I really am awed at the participation, the interest which has been shown by the medical community. I, as an engineer sitting here, standing here in front of you, I can tell that no more there are silos. There is technology with the healthcare coming together to for the betterment of the society, of the people, to take all the solutions in healthcare to the grassroots level with the cost-effective and very efficient manner. So and again, to just wrap up, I'll say AI is artificial intelligence. The real expertise still lies with our people, with you all doctors. This is just an assistive technology. As you say that you have all the assistive technologies for various sectors. So this is one of the assistance which gives the doctors all the tools to come out with more precision and better healthcare services. I again congratulate Dr. Prem Agarwal for this national AI. So when we say D, for us D means digital. So this is a doctor's mission, a national AI doctor's mission, which is a very good amalgamation between the AI and the doctors, and kudos for this. Thank you.
Thank you so much, ma'am, for sharing your inspiring thoughts with all of us. So, ladies and gentlemen, we now move to a very special moment of the evening, the launch of the National AI Doctors Mission, NAIDM. This initiative marks an important step forward in strengthening innovation, collaboration, and the future of AI-driven healthcare in India. To officially unveil and launch NAIDM, may I request our esteemed dignitaries to kindly join us for the launch ceremony alongside Dr. Prem Agarwal. And I would also request Dr. Meghna Singhania, Founder and Editor-in-Chief, Medical Dialogues, to please come up on the stage for the official unveil. Everyone, can we please give a round of applause for this official and amazing moment? The official launch of NAIDM. Congratulations to the entire team. Once again, a huge round of applause as we witness this special moment together. A very, very special moment for all of us here.
With the convergence of Dr. Sheth, Patiji, Sunita Verma ji, the dental chairman, the morning he came, and all other stakeholders, I'm sure this mission will go a long way. This is what they have to pursue in themselves only. We are not going to guide them a lot. We are only trying to create a movement in the country. We're going to relaunch it, remembering everybody again and again that this is what is required. करने वाले तो यही लोग हैं, हम लोगों का काम नहीं है. कैसे करना है वो डिस्कस करके हम बना सकते हैं. Thank you very, very much, all my dignitaries, all my people, to give so much of encouragement. And I'm sure this particular mission will become a movement. It is not an organization, it is not a platform. It will just become a movement which is carried by everybody, including a dean of medical college, including a medical director of a hospital, including a teacher, including a student, including everybody in the college. Thank you very much. Now we are, the next phase is only last that we have recognized certain people who are supporting, creating a catalyst or doing innovations. So we are giving some Phoenix Innovation Awards. So I request
So ladies and gentlemen, we now move to the last segment of the evening, the Phoenix Health Innovation Award Ceremony. Today we honor the pioneers, innovators and institutions transforming healthcare through the power of artificial intelligence innovations as well as scientific rigor. The Phoenix Health Innovation Awards celebrate excellence, innovation and impact in AI-driven healthcare and recognize those shaping the future of medicine and patient care. So ladies and gentlemen, let us begin the Phoenix Health Innovation Awards 2026. Before we begin the awards presentation, we would like to acknowledge and felicitate our esteemed jury members whose expertise, insights and careful evaluation have made the Phoenix Health Innovation Awards 2026 truly meaningful and credible. Our jury brought together distinguished leaders from healthcare, AI, public policy, medical research, innovation, and digital transformation, ensuring that the awards reflect true excellence and impact in AI-driven healthcare. May I request Dr. Abhijat Sheth to kindly felicitate our esteemed jury members. We begin with Professor Dr. Musharraf Hussain. Dr. Professor Anurag Mishra, Professor of Surgery at Maulana Azad Medical College, actively working at the intersection of AI, surgery and healthcare innovation. Dr. Saurabh Gupta, Mr. Ashish Sharma, and Mr. Pavan V. Kulkarni. I request all the jury members to kindly join us here on stage. Thank you so much, sir, and thank you all of you. And before we move ahead with the award presentation, sir, you all will be... Okay. Let us now begin with Phoenix Implementation Award for Health Innovation. Our first awardee is Amrita Hospital. Let's give them a huge round of applause. Do we have receiving the award is Dr. Sanjeev Singh. Our next awardee in this category is Mahajan Imaging and Labs.
Our next award goes to ITM University, Gwalior. ITM University. Please. And now, please. Santosh Deemed University. and I call upon GoodMed Medicare Solutions Private Limited, Mr. Dhruv Sharma, co-founder, Dr. Shaukat Hussain, scientist E at ICMR. He's affordable, scalable HPV diagnostic. Dr. Shaukat Hussain, I request Good Medicare Solutions Private Limited. It is redefining digital healthcare through AI-powered platform that converts the handwritten prescription to structured electronic records. Shyam Sundar Nandi. Shyam Sundar Nandi is a pioneer in molecular diagnostic and CRISPR-based technologies. He has developed rapid diagnostic solutions for multiple infectious diseases. Shyam Sundar Nandi. Sushil Kumar Singh. Sushil Kumar Singh is scientist D in ICMR, Bhubaneswar. आगे खड़े हैं. पता नहीं चला कौन कौन आए हुए हैं. Sushil Kumar Singh, scientist D at ICMR. Next award goes to Dr. Rucha Patel. आइए सर. सुशील कुमार सिंह. Next award goes to Dr. Rucha Patel, scientist D at ICMR and IIH. His work in affordable point-of-care diagnostic in bleeding disorder and G6PD deficiency and also Dr. Pooja Bhardwaj. Dr. Pooja Bhardwaj. आ जाइए. Now meet Pooja Bhardwaj. Pooja Bhardwaj. Now we move to Phoenix Impact Award. Impact Awards goes to Data Leads. Data Leads for Initiative Adira, one of the India's largest healthcare AI capacity building program. They were conducting a training session today. Data Leads. Jyoti Singh Rathore, the program manager for Data Leads. I call upon for the Phoenix Integration Award for Medical Research. And the award is AVS Suresh, Senior Consultant in Medical Oncology and Hematology. And the next award I call upon for Sir Gangaram Hospital, New Delhi. Dr. Ajay Swarup Mathur, Chairman Board of Management, Gangaram Hospital, is for integrating AI into clinical practice. I request Dr. Ajay Swarup Mathur, Chairman Board of Management, Gangaram Hospital. And the award in research category goes to Dr. Jyoti Singh. Dr. Jyoti is expert in medical biochemistry and AI-driven healthcare research. The Phoenix Integration Award for Medical Education. Award goes to Dr. Anmol Shinde, Professor at Provera Institute of Medical Sciences. He is a pioneer in AI-powered medical education through intelligent learning platform designed to improve competency-based learning. I call upon Dr. Suchin Bajaj. Has he come now? Please. Suchin Bajaj is a founder director of Ujala Cygnus Healthcare by integrating AI into medical practice, recognized as a lighthouse of Uttar Pradesh. Suchin Bajaj. And also request upon the Max Healthcare. People have come. Max. Dr. Sandeep Buddhiraja is a group director, Max Group of Hospital. Please, please. And I give some thank you awards also. One to Dr. Dharmesh Lal, Scientist E. He has participated and helped us in synchronizing the very good. Dharmesh Lal. Dr. Harini. Dharmesh Lal has helped us enormously into this organization of this program. Dr. Harini Rajgopalan. Dr. Harini Rajgopalan. Yes, young girl but very active. I request Dr. Sunita Verma to kindly give to Harini Rajgopalan. Mr. Rishabh Lal. Mr. Rishabh Lal. Please give applaud, please. And also to Dr. Sneh Shalini. Sneh Shalini has been a thank you, ma'am. This is a thank you award from ourselves. Charu Dutt Arora. And of course to Dr. Avnish Khare. Avnish Khare has been instrumental and guide us today's training program. And Dr. Jason Raipudi. They conducted the program today in the morning. One full hall was captivated by them. Avnish Khare, and Jason Raipudi.
Dr. Charu Dutt Arora. Okay. On behalf of Dr. Charu, we have Dr. Sonal. Right? So this one. Dr. Abhijat. Sir. These are done. So these are the next colleagues. So before we conclude this evening, we would like to express our heartfelt Dr. Karthik. We have one more awardee, Dr. Karthik Kohli. Can please have you on stage, sir? And ladies and gentlemen, we are almost at the end of the program, so we should end it with that energy that we started with. We should give a round of applause for all the awardees, in fact. A big congratulations to all the awardees. Before we conclude this evening, we would like to express our heartfelt gratitude to our distinguished guests and dignitaries whose presence has truly elevated this celebration of innovation and excellence in healthcare AI. May I request Dr. Prem Agarwal, Mrs. Meghna Singhania, and Brigadier Dr. Anil Kohli and Dr. Kamal Kant Kohli to kindly felicitate our esteemed guest. Dr. Abhijat Sheth. Ladies and gentlemen, a huge round of applause. Thank you so much, sir, for joining us. Srimati Sunita Verma. Let's give them a huge round of applause, ladies and gentlemen. Professor Dr. Sanjay Tiwari. Dr. Sanghamitra Pati. And Brigadier Dr. Anil Kohli. Thank you for your leadership, encouragement, and support towards advancing healthcare, research, innovation, and technology in India. Now, I would like to invite Dr. Kohli to deliver the vote of thanks.
Good evening, everyone. As we conclude Health AICon Phoenix Awards 2026, it is my privilege to deliver the vote of thanks on behalf of the entire organizing team. Today's event has truly been a wonderful celebration of innovation, collaboration, and the transformative role of artificial intelligence in healthcare. I would like to express my heartfelt gratitude to our esteemed dignitaries and distinguished guests, Dr. Abhijat Sheth, Chairperson, National Medical Commission, Mrs. Sunita Verma, Scientist G, and Group Coordinator R&D at the Ministry of Electronics and Information Technology, Dr. Sanghamitra Pati, Additional Director General, ICMR, Honorary Brigadier Dr. Anil Kohli, Padma Shri and Padma Bhushan awardee, and a distinguished dental professional for gracing this occasion and supporting the vision of AI-driven healthcare transformation in India. A sincere thank you to all our speakers, session chairs, and moderators for sharing their valuable knowledge, insights, and perspectives throughout the event. Your contribution has made today's discussions truly enriching and meaningful. My sincere gratitude to our respected jury members for their valuable time, thoughtful evaluation, and contribution in recognizing excellence in healthcare innovation. We also extend our gratitude to all our sponsors, Walter Kluwer, Hetero, ITM University, Elsevier, GoodMed, and Diabexi. I would also like to thank our co-hosts, NBE, ICMR, and AMTZ, and all other agencies for their support and association with Health AI Con Phoenix Awards 2026. And of course, this event would not have been possible without the tireless efforts of entire Medical Dialogues team, editorial, PR, MDTV, IT, business development, marketing, creative, data, accounts, HR, and admin. Every single person has worked as one unit to bring this vision to life. Ladies and gentlemen, let us give them a big hand. Finally, thank you to each and every one of you who is present here today for making this event a grand success. Thank you and have a wonderful evening. Thank you.
I would like you all to give a very, very resounding applause for Dr. Prem Agarwal, I think, without whom this would not have been possible. For his excellent management, for bringing all the stakeholders on one platform and making this possible. Thank you.
I wish that Health Icon becomes a success and will bring a transformative change into the future of healthcare in India. Thank you.